Hello everyone. I am Kamal Narayan, CEO of Integrated Health and Wellbeing Council, India's premier institution for health awareness, advocacy, and behavior change. I welcome you all to this second edition of Cancer Summit on the occasion of World Cancer Day. Before I begin, I would request my team to play the video on what happened on the first edition of Cancer Summit in 2020.
जो विदेशों में कई जगहों पर जो कैंसर टिश्यू बैंक होते हैं हमारे यहाँ भारत में कम है, तो हम ये कैंसर टिश्यू बैंक जगह जगह जहाँ कैंसर के इलाज होते हैं उनसे वो वहाँ पहुँचे।
We don't control the prices. You regulate the profiteering.
For every 3 patients that we diagnose, 2 succumb to cancer in our country.
This collective gathering reflects 2 things. It reflects the challenge that cancer poses on humanity everywhere across the globe, and also the resolve that we want to fight.
If one thing that the government and IHW, if we take a pledge and can do today on this World Cancer Day, is try and have every girl and boy in India vaccinated who are eligible with HPV, and also have every woman screened for cervical cancer.
Actually, there cannot be any bigger concern as the cancer is posing today to us. Cancer harega, desh jeetega should also be a motto for us.
Day last year, when we came together for the first Cancer Summit, the glimpse of which you just saw, to strengthen India's battle against much dreaded disease, little did we know that the year would entail another, more engrossing fight against a virus which took precedence over everything else. But as the dust is now settling down and we are close to winning the battle in much lesser time, thanks to tireless effort of our scientists, healthcare professionals, leadership, and most importantly, the people who made COVID appropriate behavior as the way of life. It's time again to focus on cancer that is killing over 1900 people every day. And it is not because we don't have treatment for it, but because the delay in diagnosing it or inability to pay for its treatment, or just because we give up on our hope of winning over it. As a disease, cancer holds a significant sway over the disease landscape globally. Until the beginning of millennium, it was considered more as a Western disease. However, standing at the threshold of its third decade, we now know how mistaken we were. According to WHO World Cancer Report published last year, there were more than 11 lakh new cancer cases, of which over 7 lakh people died of it. According to ICMR's National Cancer Registry Program data, by 2026, the total number of new cancer cases annually to be over 18 lakh, with almost equal distribution of it among men and women. But all these data come from a period when the world was on a standstill due to COVID 19, during which cancer patients were hit by a double whammy: delays in diagnosis or treatment due to disrupted healthcare system, and more than that, their own fear of catching the virus that kept them away from the hospitals. The other setback the fight against cancer had during the pandemic was our fledgling practice of preventing screening came to a grinding halt. Estimates show that the lockdown and travel restrictions might have allowed 1 lakh cases every month go undetected. Though during this time, we at IHW Council not only continued our efforts towards cancer awareness and advocacy, but also stepped it up drastically to exhort people, caregivers, and policymakers to keep doing what is essential for prevention and control of the disease. From a dedicated weekly web show that reached to over 2 million people so far, and featured India's finest oncologists share scientific knowledge and guidance with patients, their families, and to people at large, to initiating some of the mega movements such as Breast Cancer Action Month and setting up Breast Cancer Action Day on October 21st to make people move from awareness to action to stop breast cancers. ISW did not leave any stone unturned towards awakening, informing people for making a cancerless or cancer-free India. And today's Cancer Summit second edition is another step towards where experts from the country and the other parts of subcontinent have come together to take stock of the preparedness and chart a roadmap for the near-term future to help India address cancer in a mission mode. We are so privileged today to have a galaxy of most eminent names in the world of cancer care and highly influential health leaders. Let me welcome our esteemed guests, Ms. Padden, WHO representative to India, a public health veteran. Ms. Padden is working closely with the Government of India and Ministry of Health and Family Welfare to implement various health strategies towards enhancing health outcomes in the country. We have Dr. Suresh Advani, Padma Bhushan. Dr. Advani is a renowned medical oncologist and one of the best in India. He was Chief of Medical Oncology at the Tata Memorial Hospital and also set up the oncology department of Jaslok Hospital in Mumbai, where he is currently Chief Medical and Pediatric Oncologist and Hemato-Oncologist. Dr. Advani has been practicing oncologist for more than 4 decades now, and despite many odds of life, including being wheelchair bound, Dr. Advani has contributed immensely towards strengthening cancer care in India. We have Dr. Professor Pramod Kumar Julka, Senior Director of Max Institute of Cancer Care and former Dean of All India Institute of Medical Sciences. He is a luminary of compassionate and quality cancer care in India, among the most prominent advocate of cancer prevention and timely detection. Professor Julka has been honored with prestigious Padma Shri award for his exemplary contribution to oncology that spans over 3 decades. We have Dr. C.S. Pramesh. He is the director of the Tata Memorial Hospital, the largest cancer care center in our country, and also the convener of National Cancer Grid, a large network of 177 cancer centers in India. He also practices thoracic surgeon at the Tata Memorial Center and is also a member of Clinical Research Secretariat of the hospital. We are privileged to have Dr. Anil De Cruz. Dr. De Cruz is the Director Oncology of Apollo Hospitals and President of Union International for Cancer Control. UICC, and that is headquartered at Geneva, Switzerland. He is the first Indian to hold this prestigious post of the largest cancer organization globally, committed to the cause of cancer control. Prior to joining Apollo Hospitals, Dr. De Cruz was director at Tata Memorial Hospital. We also have with us Dr. Jareen Dilawar Hussain, MD and CEO of Integro Pharmaceutical. Dr. Hussain is the most diversified and pioneer healthcare professional, entrepreneur, and philanthropist in Bangladesh. A passionate, preventive, and holistic healthcare advocate, she has played a significant role in promoting palliative care concepts in her country and is General Secretary of Palliative Care Society of Bangladesh. We have with us Mr. Sumil Modi, General Manager Oncology, Novartis India, a veteran healthcare business professional who is also championing the cause of ensuring access of quality cancer care and drugs to every patient. And Mr. Raman Bhaskar, Director, Manipal Hospitals, Delhi, a veteran hospital administration and healthcare management professional, an alumni of IIM Kozhikode. Mr. Bhaskar has worked in multiple geographies, including in West Asia and Africa. We are also thankful to Mr. Bhaskar and Manipal Hospitals for their support in organizing this important program. So welcome all our speakers, and we are thankful that you have joined today with us to make this fight against cancer stronger. So let me begin this program with our guest from WHO today, Ms. Paiden. Welcome to the second edition of Cancer Summit.
Thank you. Distinguished speakers, dignitaries, and audiences around the country and around the world. A very good morning to you all. It is indeed an honor and privilege for me to participate in the second Cancer Summit with eminent experts and stakeholders on the World Cancer Day that is themed I Am and I Will. Now, according to the International Agency for Cancer Research, cancers are the third leading cause of NCD, non-communicable disease deaths in India, where around 1 million new cases of cancers are reported every year. Now, as you know, the economic impact of cancer is already significant, and it keeps increasing and puts a huge expenditure on households, putting them into catastrophic expenditure for treating cancer. There is clear scientific evidence that investment in cancer prevention can bring human, social, and economic benefits. According to current evidence, between 30 and 50% of cancer deaths could be prevented by avoiding or modifying key risk factors, such as not using tobacco or smoking tobacco, reducing alcohol consumption, maintaining a healthy body weight, exercising regularly, etc., etc. Tobacco use is the single most important risk factor for cancer and is responsible for around 27% of cancer-related deaths in India, according to ICMR. Under the WHO FCTC, tobacco control measures such as banning sale of tobacco to minors and tobacco advertising, making public spaces smoke-free, and raising taxes are highly cost-effective evidence-based measures which are being implemented in many countries and also in India, and this needs to be strengthened further. Infections such as hepatitis and human papillomavirus HPV are responsible for up to 25% of cancer cases in low and middle income countries. Vaccination against these HPV and hepatitis B viruses has potential to prevent around 1 million cancer cases every year globally. Now, the government of India has launched a national viral hepatitis control program with aim to eliminate hepatitis C by 2030 and achieving significant reduction in deaths and disability from other hepatitis infections. Under Universal Immunization Program, coverage of 3 doses of hepatitis B vaccine among children is around 91%, which is commendable considering the size of the population in the country. Now, cancer mortality can be reduced significantly if cases are detected in early stages through regular screening and early diagnosis and treatment. WHO recommends maximizing benefit and minimizing harm through organized population-based screening programs. Considering the rising prevalence of cancer, India has taken a leadership role by introducing population-based NCD screening program for three most cancers, that is oral, breast, and cervical cancers across the country as part of Ayushman Bharat Health and Wellness Center program. The program has potential to reach more than 500 million adults. Now, WHO has also launched a global initiative for childhood cancer in 2018 to reduce disparities and poor survival of childhood cancers globally. We are pleased to know that India is participating in this effort, and many institutions are actively engaged in the Southeast Asia Regional Childhood Cancer Network, and I'm sure some of you are involved in that. Now, training healthcare providers to identify cancer symptoms for early referral for diagnostic tests and investing in Make in India low-cost quality screening tests such as HPV testing kit for screening cervical cancer can save millions of lives. This needs to be adequately supported with interventions to raise community awareness. So communities, it's so important for communities to come forward for screening and also for taking preventive actions, and therefore engaging community becomes key for preventing cancers in the country. Government of India has taken proactive steps to link screening with diagnosis and management services for ensuring everyone diagnosed with cancer has access to treatment and ensuring continuum of care. I'm sure you know that very well under the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana Health Protection Scheme. Now, another important area to be addressed is to have structured referral and back referral for diagnosis and treatment, along with quality assurance through robust program monitoring and evaluation. Another important aspect of cancer prevention and control is investing in the cancer surveillance to provide spectrum of cancer burden and its determinants. Presently, only about 10% of Indian population is covered through National Cancer Registry Program, which need to be strengthened further. Another dimension is investing in cancer research. Indian medical fraternity and scientists have played vital role in global cancer research programs and has the potential to play a leadership role in evidence generation and saving lives. WHO advocates for continuum of care for cancer prevention and control, from prevention to management, rehabilitation, and palliative care, which is so important. WHO India is supporting National Program for Palliative Care program to strengthen the capacities of human resource and ensure availability of essential medication for pain relief as per National Drugs and Psychotropic Substance Act 2014. Across the globe, COVID pandemic has exposed weaknesses in health systems and impacted chronic care, including cancer services. We need to build back better and stronger in improving cancer services as a response to the pandemic and ensure we have resilient health systems to be able to cope with any kind of pandemic in the future without compromising on the services, both for cancers, for communicable disease, and other non-communicable diseases. The world's response to COVID-19 pandemic has reiterated the need for partnership across stakeholders. I'm sure everyone agrees on that. Now, in 2020, last year, a global strategy to accelerate the elimination of cervical cancer as a public health problem was launched to eliminate cancer with a 90-70-90 strategy. That is 90% of girls with HPV vaccination, 70% women eligible women are screened, and 90% diagnosed to receive treatment, and these targets to be achieved by 2030. The WHO is committed to support countries, especially in India where we are working, to implement global cancer strategies to minimize underlying equities and health disparities. The E-Summit today provides an important platform for knowledge sharing among stakeholders on cancer prevention and control. I congratulate Integrated Health and Wellbeing Council for bringing diverse stakeholders and experts together to further boost cancer prevention and control activities in India. Thank you very much for inviting us to this important summit. And I wish you all a very productive deliberations today. Thank you very much. Over to you.
Thank you so much, Ms. Padden, for giving such a wonderful overview about the prevalence, various initiatives from the Government of India, from the WHO and other important bodies. Thank you so much for this opening remark. And now I would go to Dr. Advani. And Dr. Advani, as Ms. Padden has, kind of given the entire overview of where we stand as far as the prevalence of cancer is concerned and where we are actually heading to as well. You have seen the situation or the prevalence of cancer in emerging, spiraling over the last 3-4 decades. What has led to this? Is it simply the lifestyle changes, the growth which we did in various aspects of life, or we also kind of ignored cancer at initial stages, or strengthening the care framework at the beginning?
I think there is no question, as it was mentioned, that the cancer is on rise. That there's no doubt. In fact, Bombay Cancer Registry has clearly shown 2% increase in the breast cancer every year for last 15 years. So that's a huge number. Of course, correspondingly, the cancer of the cervix has shown a downward trend, particularly in the major cities. So I think, but all other cancers, there has been definite increase. So I'm sure all this is related to our lifestyle. And also the fact remains that in spite of extensive information and knowledge of the public that tobacco is the main enemy for for the production of the cancer, even today, use of tobacco has not really gone down to the extent that we want. So I think that's where the whole track, which is get interrupted, that we know so many things about the preventive measures that we can take to prevent the cancer, but its follow-up is very, very doubtful. And that's where I think over a period of time, the cancer is increasing. Even today, the people, as it was mentioned, that we should have the regular exercises, avoid tobacco, smoking or chewing, and the vaccines, hepatitis B vaccine, HPV vaccine, which is available now, but still its application is less than 50%. I must say that hepatitis B has become universal, but HPV is still, there are a lot of doubt. Nobody knows when to take it, how to take it, So I think in spite of the knowledge and information, awareness, its real application remains doubtful. And that's where I think all of us, the government as well as the non-government organizations, have to do a very hard work to see that this information reaches to the root and ultimately helps us to give up all those factors which are responsible for the increase in the cancer.
Thank you so much, Dr. Advani. So I think the one takeaway from your point is that despite growing cancer prevalence, we also have a very high prevalence of cancer awareness now. But at the same time, that is not being applied on action, and which is leading to, I think everyone knows now, with the cigarette packs having such a big pictorial warning, Everyone knows that tobacco is going to harm and can cause cancer, but still it is not coming into action in terms of making a certain behavioral change. Thank you so much for highlighting this. Dr. Julka, despite
Yes.
this growing prevalence, where do you see the silver lining in terms of managing this better or preventing more people from getting this or saving more patients? So we have the prevalence, we have the kind of resistance to behavioral change. We are also lacking in certain areas in terms of taking the screening or maybe vaccination or care to reach to the last mile. But I'm sure there would be some silver lining where we can build further.
Yes, let me first congratulate you for this excellent summit, Cancer Summit. Through this and through other summits, what we can do is to increase the awareness amongst people about cancer. Because cancer awareness still, whatever level it has reached, it has not reached to the last, we can say there is a silver lining in between. Now, what I want to state that I have been doing programs on television, on the print media, on the electronic media as radio, All India Radio, all these programs telling them about early detection of cancer and the cancer, since the cancer prevalence is so high. In AIMS, I was the head of Delhi Cancer Registry. So as a head of Delhi Cancer Registry, I saw that National Cancer Registry program says that 14 lakh new cancer cases, about 14 lakh, are every year, and out of which about 30 to 40% are tobacco related. So why can't we, prevent this preventable cause? Simple primary prevention of tobacco related cancers. We cannot prevent even these. And not only tobacco, alcohol. Then the diet and exercise. We always say, don't get obese. Obesity itself leads to cancer. So basically tobacco, alcohol, obesity, and then we have certain preventive strategies, because early detection is the hallmark to cure. We had done a study at AIMS with National Cancer Institute of Milan on the breast cancer, and we found that average size of the lump in Indian women was 4 centimeters, whereas average size of women detected in Milan was 4 millimeter. Now you can see, if there is early detection, I used to say early detection is the hallmark to cure. So once we know that early detection, we can cure a person, and with good quality of life. Why not give them the good quality of life? And we should propagate more. These 30 to 40% who are tobacco related and alcohol related, we must prevent this at any cost. That is what I mean to say. Early detection, again, I reiterate, is the hallmark to cure.
Thank you so much, Dr. Julka. Early detection is the hallmark to cure, and early detection can definitely save lives. Dr. Pramesh, so we hear that there is a need of preventive measures, screening, early detection, and much of that also has to be, kind of supported by the public health system. How has our public health system responded to cancer prevention, diagnosis, and care so far? And where are the gaps and how effectively and urgently they need to be filled or can be filled?
So thank you, Kamal, for inviting me to be part of this wonderful meeting. And just like both, all three of the previous speakers mentioned, public health interventions are clearly the way to go as far as scaling up on cancer control is concerned. And I'm fairly certain that everyone else will agree to this as well. So while there have been several pilot projects, several demonstrations of efficacy of these interventions, whether it be education, awareness, or early detection, where we have not succeeded as well has been in scaling this up and creating a model which can be replicated across the country. So we have islands of excellence, islands of demonstration projects having been done in several parts of the country. And probably with the exception of the large national scale screening for NCDs, which was launched a couple of years back by the government of India, we've not actually had a very serious concerted effort at scaling this up. Nor do we have a very clear strategy on what the methods that we should adopt are. So I know I'm going to fairly controversial areas here, but if we were to look at effective screening modalities across the length and breadth of the country, while we've had, again, certain areas, certain states having demonstrated that this is possible on a state level, on a population base, a country with the same level of quality that is required. Very often we think of screening as people going and examining mouths, examining women for breast and cervical cancer early signs, and we think that's the end of it. The programmatic effort that it requires to actually maintain this, sustain this, and scale this up at a national level is often underestimated. And often the necessary monitoring and evaluation that's required, the quality control that is required, as well as the downstream thoughts on what happens after we diagnose a patient. We've had experience with 2 very large screening trials, and to me, it's the devil remains in the details. We've had patients who've been diagnosed with very early cancer in one of our rural projects, where after the diagnosis and being assured of close to a 70 to an 80% chance of a complete cure because it's been detected early, patients are not able to reach hospitals which are able to offer them the care, even if the treatment is completely free. So we kind of oversimplify the problem by saying that let's do the screening, let's provide them a hospital to come to get treated, and we've sorted the problem. It's much more than just that. The entire program needs to be thought through. And very often it might be small things like, my family will not be able to sustain itself if I don't earn my livelihood, because many of these are daily wage laborers. We live in ivory towers in cities of Mumbai, Delhi, Chennai, Bangalore, all of these places. But what happens in the hinterland is something that's very, very sobering. So I think that last mile connectivity, making sure that this awareness and education percolates right down to the last mile, ensuring that a distributed model of care is available, wherein patients for at least 70 to 80% of the common cancers need not travel more than at best 100 or 120 kilometers to access quality care, is something that we really need to work on. I'm aware that the government is looking at some of these thoughts, but again, the implementation is something that we need to look forward to. And I'm hopeful that with the recent budget showing quite encouraging signs with increase in the overall health budget. And I'm not again mentioning the one that's going to the Ministry of Health and Family Welfare. So because we know that social determinants of health are as important, if not more important, than just delivery of healthcare. And I'm hopeful that over the next few years, we will see the fruits of these efforts coming in.
Thank you so much, Dr. Pramesh. What I think is the message here, that there were a need of more concentrated efforts when it comes to screening, and not only screening, kind of ensuring the whole continuum of care for these patients who are diagnosed of cancer. While you are quite hopeful about that, the new increased budget on multiple areas, including one for that for clean air or for drinking water or many other things, will also be helpful in terms of reducing overall disease burden. But that is something which is on the long term, and we also need to have a shorter term solution as well. Dr. De Cruz, you are leading the global fight against cancer, and you have also been seeing, that how India has been taking this fight forward. Are we giving enough attention to it when it comes to, kind of eliminating or reducing the cancer disease burden, or we kind of get into the other more important or maybe more pressing areas, and cancer become kind of ongoing thing, and not much is being done in various aspects, whether it is availability of drugs, or making sure that the innovative therapies reach to the last man, or the people whom Dr. Pramesh said that being in hinterland, not in the ivory towers of our metro cities.
Uh, Thanks, Kamal. I think most of the points that you asked me have been covered in bits and pieces by the various speakers. We must be aware that government has made efforts. As Pramesh said, this time the budget has more allocation for health, be it tobacco. There are a lot of measures that have come in, banning of gutka, raising taxes on certain products, not allowing people to have smoke in public spaces. So there have been efforts in the cancer sphere. And yet, as we all know, these efforts have to be much more and they have to reach more people. I just want to make a point here rather than being absolutely cancer specific. We all work in our own silos. So today we are doing this meeting on cancer and we'll talk about banning tobacco and doing various things and HPV vaccination. And that's cancer. But I think what we need to is probably have a diagonal approach to our healthcare problems. We need to strengthen our primary healthcare facilities. People in the hinterland, not in the ivory towers, need to have basic primary healthcare. It will cover all the NCDs. Cancer is one problem. Yes, we are all committed to it. We work for it for years and years. And yes, we want to see a potentially curable disease either prevented or diagnosed early and we treat. But it cannot be in an individual silo. It must be part of strengthening our healthcare. And on the other side, you'll have to strengthen vertical healthcare delivery, and that is having centers of excellence that will treat people and people who are diagnosed. As Pramesh said, you diagnose in the first stage, they don't have access to healthcare. So for me, it's a very complex problem. We need to strengthen our primary healthcare. We have to strengthen our centers of excellence, and that and only that will help control. So public health measures, it's multifactorial, increased spending and social determinants of health. Everything has to change before we see the impact. But again, I just reiterate, whatever everybody has said makes a lot of sense. We have to do that in bits till we get there and have a lower incidence of cancer, or we can convert the excess mortality. Like I said the last time on your program, in India, for every three diagnosed, two succumb to the disease. In the West, it's 1:3, and I think we need to get there with time.
Yeah, thank you so much, Dr. Dr. De Cruz, for highlighting this. And definitely, if we want to tackle this growing burden of NCDs and many other problems, primary healthcare is the way to go, and strengthening of it is an important aspect, which is, I think, India is now kind of moving towards it. And post COVID-19, we have kind of understood its importance even more. Dr. Jareen, as far as overall access to quality healthcare is concerned, your country is ranking slightly better than ours. We are at, kind of 145 and you are at 133. That's a different aspect, that we have a much bigger population to cater to. Still, what is the state of cancer care there in Bangladesh, and what can we learn from there?
First of all, greetings from Bangladesh. As you know, I would like to salute you and your green team for organizing this beautiful platform on the occasion of World Cancer Day. And we know it third position in terms of death in the world. Bangladesh is, as you know, is the least developing country, and it is graduating to a developing country. So the problem is as much as what you have is what we have here. Cancer, to my exposure, I'm an anesthesiologist. At the same time, I am a CEO and MD of a pharmaceutical company. But my exposure to cancer has been from the time I have been a doctor. And I have been giving anesthesia to a lot of oncologic surgeons and I have been a major part in the palliative care also. So the scenario in our government, as very rightly said by the eminent speakers of this platform today, that prevention itself cannot take away the death. In the Western world, cancer is no longer treated as a killer disease. Rather, it's a chronic disease. You have remission, you have again, and then you take treatment, you go back. But unfortunately, to my utter surprise, I have encountered patients who are dying in the first stage of cancer. And that kind of gave me a question to ask myself and to ask the community of doctors, that why is a young teacher, for say, or a young banker is dying with the breast cancer detected in the first stage? So there is where the hitch lies. They do not have access to the target therapy. They do not have access to the modern therapy. When they are given radiotherapy, the man behind the machine probably is not as qualified to give radiotherapy as a man who would give it in a Western world or a developing country. So what happens, I have seen, and I have myself dressed a lot of lady who have suffered from first stage of cancer and who has had radiotherapy. I was nursing the wound rather than giving some solace to the patient who has been admitted in the palliative care. So we need robust implementation so that people in the lower strata, in the lower economic group or the middle-age group can have access to the right medication, can have access to those diagnostic centers where they can do their yearly health checkup. Yearly health checkup to them is unheard of. Whereas the tip of the iceberg where we belong, to us, we need to fly out to Singapore, we need to go to India, we need to go to Bangkok to get our health checkup done. But that is only this much of people who can access that. So we are trying, number one, for palliative care to be in our healthcare policy. So that should be a part of our study in the MBBS, because we are taught about curative procedure. We are not taught about death and dying. So the government, we are working, and I am a research assistant in the Postgraduate Institute of Bangladesh, where I'm working in tandem with the father of palliative care in our country, Professor Nizam, to bring this policy towards reaching the masses who constitute 160 million people of our country. It is sad to see a young mother is dying when she is crying for a little child who will take care. It is sad to see a young girl being diagnosed with cancer and she knows she's having breathing problem and she takes flowers in her nose thinking the flower will give her oxygen. I am a compilation of many stories of these patients who are no longer here and who no longer is with us. It is with sad and grief that I say that we have not been able to give that much of care, that much of attention to those people who are not with us anymore. We don't want to lose a generation. We want to build a generation with good health, where good health does not mean that it is only constricted to doctors and nurses. We want the daily farmer, we want a banker, we want a poultry owner to contribute to our healthcare system, because they all combine to a healthy life of every human being. And it is our basic right to get the right treatment at the right time. Thank you so much for giving me time. And I salute you for having this wonderful platform. And as I'm in correspondence with you, that I want to bring this unique concept to my country, that why should it be unique to India? It should be unique to my country. And it is time for you to spread your wings and bring this to Bangladesh. Thank you so
So
much.
much, Dr. Jareen, for kind of highlighting these stories, and I'm sure these stories are also common stories in India as well. And we too are having a very heavy burden of breast cancer. You highlighted about these stories about breast cancer. We too are trying to kind of bring in palliative care in our mainstream healthcare framework. So I think definitely both countries seems to be in the same boat and can definitely help each other in kind of improving when it comes to the health outcome for their people. Mr. Modi, Dr. Jareen highlighted about the innovative drugs and the therapies and which is not reaching to the people, and what I see that, and I was talking to one of.
Another thing, Mr. Kamal, your support to bring this.
Yes, yeah. So I'll be coming back, Dr. Jared, with some more, to understand, hear more from you. So, Mr. Modi, what I hear that there is more than 50% of medical research is going on, which is the entire medical research which is happening at present. Almost 50% of it is going on cancer care. Trying to understand cancer better, trying to come up with better drugs for cancer. And the innovation is kind of ever increasing, and with the new therapies are coming, and a lot of and these are definitely the biggest tool for saving lives and it's ensuring the quality of lives for patient. What is your view of whether this innovation is reaching to the people who are in need of it? Is there a the right framework that everyone, as Dr. Jareen also said, from a poultry farm owner to a banker or to maybe a farmer, if they get the cancer, can they get this kind of drugs which are now available and with which cancer has become no more a death sentence? It is something which you can treat, you can make it. It is not a killer disease now; it's a chronic disease, and you can live with it. So, what is your view on it? You being on the drug providing side, uh, where we are lacking or we are already kind of bridging that gap.
Thanks, Kamalji. At the outset, thank you for inviting me to this panel, and also the one tag that you said from your video last year, "Cancer harega, desh jitega," right? So that really sets the tone as we look at the overall cancer scenario in the country as well. Looking at the question that you very specifically asked in terms of access to medicines, when we talk about oncology treatment, when we talk about the innovative medicines that are available, right? So if you look at the last few years, I think two critical areas that we need to look at, and as Dr. Pramesh earlier said, Dr. De Cruz also mentioned, over the last 5 to 10 years, I think in India, when you look at it, the whole scenario of cancer care treatment has changed dramatically. I mean, who would have imagined 10 years back that if you were sitting in Guwahati or Vizag or Varanasi, you would have a Tata hospital right at your doorstep who would be providing cancer care? So, that perspective has completely changed. A lot of work has happened. And even the private health players, whether it is Manipal hospitals, whether it is individual doctors, everyone has decided to go to the tier 1, tier 2 cities and offer cancer care to the patients in those cities. At the dilemma at that point was, if I had money, I would travel to a Bombay or a Delhi and seek treatment. As Dr. Zareen said, go to Singapore or come to India. Or if I don't have money, I would resign to my fate in that particular city and stay there as well. So a lot of work has happened in terms of decentralization of care. The National Cancer Grid headed by Dr. Pramesh, I think they're doing a fantastic job in terms of standardizing the protocols so that quality cancer care is available. At the same time, Ayushman Bharat, in terms of improving health system, I think the government has done a lot of work over the years. I mean, who would have imagined that someone who's below poverty line today would have access to cancer care treatment? I mean, they don't see half a doctor in a primary healthcare center, forget getting access to healthcare, right? So through Ayushman Bharat, the government has done a lot of work. Digitalization will further help us, and as we see the future, I think the government's also working on the missing middle class, because the affluents will go to any part of the world to get treatment. The below poverty line gets covered by Ayushman Bharat and other schemes. The missing middle is where the struggle is always. So even the government is now making efforts as to how do we really get to that part of the population and provide quality medical care to them. Whether innovation is available today to each and every person in the country, the answer is no. right? So we've come a long way compared to where we were in the past, that nothing was available. From there today, at least standard protocols, surgery, a lot of standard chemotherapy medicines are available to the population at large. But if you ask me whether the innovative medicines are available to each and every person on the ground, it's not available, very honestly. But having said that, we are making our efforts to work with Ayushman Bharat as well, as to how we can ensure that our innovation reaches these patients as well. How can we be a part of their protocols and ensure that this innovation is made available to the patients? Because we have a firm belief that if you have innovation and if a large part of the population cannot benefit, it doesn't make any sense to bring this innovation to the country. So that's an area that we are working very closely with Ayushman Bharat, and thanks to the platform. I mean, we discussed this during the Breast Cancer Action Month as well. You would recollect when we had a lot of workshops during the Breast Cancer Action Month in October along with IHW. That was one area we started working around, and we've made significant progress from then till now. So that's one area as a company we would work, and over the years it's our commitment that how do we partner with various agencies to ensure that the innovation is made available to the people.
Thank you so much, Somilji, for highlighting that, and also, kind of showing that silver line, that, or looking at the glass half full. And also, I now strongly believe that the glass is not just only half full, it is also under the tap, and it is getting filled. And soon we will have the glass, completely full. So thank you so much for highlighting this, that how, better cancer care is now reaching to the, people, and to a large number of people under various schemes. So most of us have, kind of highlighted very strongly about awareness. Awareness is something, though we also see that the awareness is high, or we kind of have awareness which is not translating into action. But still awareness, in a country like ours, definitely the kind of level of awareness we have, it has to be further, kind of enhanced, and should be reaching to everyone. Mr. Bhaskar, how do you see role of players like healthcare providers like Manipal in, kind of further strengthening the awareness part of it, and also kind of nudging people, to translate the awareness into the action? What hospital, and which is, kind of the first point of contact for many patients, and there can be a lot of those kind of preventive screening and other things are already part of it. So how do you see the role of players like your group, contributing to it?
First of all, I would like to thank you, Kamalji, for arranging this session. I'm actually overwhelmed to be part of so many distinguished speakers. I might have been the bottom of the pyramid with looking at the kind of experience all of them have. So coming to what you're saying as what healthcare or private healthcares can do, I'll bring a very different perspective. Of course, one is a very important thing which we as a Manipal hospital we do is we create a lot of awareness. See, prevention is better than cure. We service our cars once in 6 months, but we don't do it with our health, because we always believe in a breakdown maintenance. कि अरे hospital जाएंगे, कुछ होगा तो hospital जाएंगे. So we create we do a lot of screening camps across societies, create awareness. But let me just change the perspective. I know all the distinguished speakers have spoken about the government schemes. There's a lot of government schemes which are running, which even the people, BPL people are not aware, creating awareness. Let me be a bit more critical here. I mean, no matter how big a picture we put on the cigarette packet, the consumption will not reduce. I mean, no matter how much we try, the success rate or penetration in adults who've been smoking is not, it's not easy. What we need to target is the young. What we need to start creating awareness is among the young, among the children, among the schools, among the colleges, because you'll be surprised to know almost 14 to 15% of the age group of 13 to 15 kids actually consume some or the other kind of tobacco. Every day, 2,500 people, my statistics will be plus and minus 5-10% here. Every day, 2,500 kids below the age of 18 try some kind of a tobacco. For them, why do they do it? some feel that, it's a status symbol, or a form of showing toughness. Girls specifically use it thinking that it will help them losing weight. They want to smoke cigarettes because they want to look cool. So, yes, definitely we need to continue to create that awareness at what do you call, a higher age group. But it is time, and very important, which is what as a group we are doing, is start creating that awareness right at the childhood level, right? Start talking about it. We feel that it's a taboo. No, we should not speak to the kids. They will get exposed or they will get spoiled. The fact of the matter is, today the kid is exposed to your mobile phones, your laptops, your internet, you name it, they're aware. They know about what's happening. So rather than us trying to, hide it from here or trying to keep it away from them, it is better to start creating those awareness programs right at the, age group, as good as, starting talking about it from class 8 or 9 about, what are the ill effects of smoking. Take away this myths of being cool, stylish. Have champions in colleges, schools who actually oversee that. That is something which I thought it's important to bring a perspective, and that is something which we are working very closely with many schools, many colleges, because like they say, you cannot change a earthen pot. You can't change the baked earthen pot's shape, but you can definitely mold while it is being in the hand, when it is being before being baked. I think that is what is very, very important.
Thank you so much, Mr. Bhaskar. Good that you are, trying to catch them young and, kind of spreading this information and awareness, and also kind of inculcate those behavioral, kind of attributes early on. I think Dr. Pramesh will be having some meeting, so I will ask one question before he kind of go out of this conference. Dr. Pramesh, National Cancer Grid. One, a very important initiative, I think, which is kind of expanded fairly large now, and definitely becoming a backbone of the whole, cancer care gradually. What is your kind of view on it, that how it can be further strengthened, and how Ayushman Bharat is kind of helping it take to the people at the last mile, and also what is your this Choosing Wisely program?
Thank you. The National Cancer Grid is a Government of India initiative, which has a fairly ambitious goal of trying to create uniform standards of cancer care across the country. Now, something like this is not likely to happen overnight or even over the course of a decade, but I think substantial progress has been done. Since it started in 2012, we have gradually grown on its membership, and currently we have 230 plus cancer centers, research institutions, patient groups, charitable organizations, and professional societies being members of this. So the three pillars on which the Cancer Grid stands is to have uniform standards of care, to create human resource adequate to treat cancer in the country, and create a ready platform for collaborative multicentric cancer research, each of which is an important component of this. So I'll be the first to accept that the strength of a network like this depends on its individual components and the support that we have received from each of those individual components. And this has necessarily nothing to do with the size of the organization or the reputation or how much it is regarded. We've had some very small cancer centers contributing much above their weight, and therefore the sense of collaboration and cooperation that we've had seems to be very, very opportune. To me, the biggest plus point is that we've had the leadership of these organizations coming together for a common purpose and keeping the patient at the center of everything that we do, which is to make them either live longer or live better. And that's the credo based on which we work under. So as you also mentioned, the collaboration with the National Health Authority has been very, very fruitful. And it has come as a very welcome way of ensuring that evidence-based practice is what is reimbursed under the Ayushman Bharat. So we live in a largely unregulated healthcare scenario, and though this was never meant to be a regulatory platform, it has ensured that adherence to guidelines is actually rewarded as part of care. And it is this level of quality assurance and quality control that we wish to bring into the entire healthcare scenario here. There are several other aspects of this. One of the main areas is value-based cancer care. So as you might have realized, there have been remarkable developments in cancer care over the last decade or 2 decades. But a lot of them come with a very high cost attached to it, which means that it is out of reach for the vast majority of India's patients who pay predominantly out of pocket. So while industry has done their best to try and reduce prices, have differential pricing, it is still a reality that many of these cutting edge advances are not available to the majority of India's patients. So which is where value comes into the picture. And we are currently working with groups in health economics, trying to find out how can we create a threshold based on which, how can we have a value-based threshold, something on the lines of how the NICE guidelines are done in the US and the ASCO and the ESMO value frameworks are created, which brings cost versus benefit and creates that matrix wherein we are able to suggest what is value-based cancer care. And towards this was the first step, which was the Choosing Wisely campaign that we took. As many of you know, Choosing Wisely is an international campaign run out of the American Board of Internal Medicine, which looks at identifying low-value or harmful practices which are common in various aspects of healthcare. We took up cancer because that's our forte, and came up with a set of 10 recommendations which need to be avoided, which are commonly practiced, have low value, no evidence to support it, and might actually be harmful, and also incidentally save costs as well. So I'll stop with that. And
Thank you so much, Dr. Pramesh, for highlighting this, that how this cancer National Cancer Grid is helping, and also its partnership with NHA is quite robust and fruitful. And I'm sure that with your mechanism of rewarding the good practices and the adherence to the compliance or the guidelines, is improving overall care even in the smaller centers. You said that the smaller centers are kind of contributing more sometime, or are more proactive in terms of feeding or sharing data and other things. So I'm sure that overall care is also getting enhanced. Thank you so much for highlighting this. Dr. Advani, I at the beginning mentioned that, and we have seen that it's a kind of research is coming from all across, that COVID-19 has kind of disrupted or delayed screening and the reporting of the cancer cases. Is it kind of contributing to the increase in terms of number of cases now, since most of the things are back to normal? And I can see you also in hospital today. In couple of last programs, we saw that you connecting from home only. So is it the number of cases? Are you seeing any spike post this COVID scenario? Sir, you are on mute. Dr. Advani, could you unmute?
Yeah, I think there's no question that everybody, all the public and people, patients, doctors, nurses, healthcare workers, everybody has realized that we are back on the work, and that there are enough ways and means by which we can protect ourselves from this virus. And obviously also the fact remains that the numbers have gone down drastically. And I'm sure with this vaccination process, everybody will be back on the normalcy. I can really see, at least in our practice all over in Bombay, that everything is becoming normal. People are traveling for their treatment, people are going for the regular checkups, and so it's basically that initial 6 months was a big problem for the people. Today, elderly people are also coming to the hospital, and I think that's indicates that now the fear of COVID-19 is gone. Of course, everybody, even today, takes care. And I think which is very important, that all of us should take care of the COVID-19 by putting on the mask and the hand washing and safe distancing. So I think with these three criteria, everybody has come to the normal, at least as far as the medical facilities are concerned. Even all the hospitals, they are now providing the state-of-the-art COVID-19 protection without hindering the patient and doctor's relationship. So I think that's a great movement which has happened. And in fact, I think that has given everybody the confidence that in spite of all the features which are little sometimes difficult, that we are able to cope up. And I personally feel that everything is back to the normal, and I'm sure now our treatment, preventive measures, everything should be on move. I think the most important thing is, again, go back to the public and see that we have an interface where the public and the medical professionals and social workers interact to indicate that we have to move forward in terms of the prevention of the cancer.
Thank you, Dr. Advani. So basically, we are back to normal. We are back to normal in the new normal, and but the cancer remains same. Dr. Julka, you
yes,
please.
Since I've got patients waiting, so I would just like to highlight what Mr. Bhaskar had told, that we should start from the school level. You know, we are getting young patients also, and we ask them, do you smoke? They say, we are going to hookah parlors. Now, this hookah parlor concept has come now, and as a just to show off, you know, peer pressure, and all this is happening. So these things have to be told, and we explained to the patient, he's 25-year-old boy with Hodgkin's lymphoma. Now, you know, we have to tell them that these hookah parlors and all this tobacco use, and they put alcohol also into that, so that we have to tell them. And secondly, there is an explosion of knowledge in the field of medicine and in field of oncology also. For every gene mutation, we have a different drug. Now, can we afford this? Because Dr. Parmesh clearly mentioned about cancer grid. It is, you know, I must congratulate him for making all this. But let me tell you that most of our population cannot afford these expensive drugs, which we prescribe them and then do molecular testing on them. You know, we try to get to various companies so that free molecular testing can be done in that, and we find out the gene mutations which are responsible for that. Ultimately, what is our aim? Our aim is to make cancer a chronic disease, just like diabetes and hypertension, and they keep on, you know, doing normal work and take the tablets at home, you know. So this is our main concept.
Thank you so much, Dr. Julka, for, you know, kind of highlighting, and then this aspect of, you know, the I think that the new forms of tobacco consumptions, yes, and, you know, the new ways, you know, actually in Europe, they shifted from smoking to what you call vaping, and they thought vaping is a better option than the smoking, and then vaping also kind of identified having the similar issues. So I think you know, there is a much more awareness needed as the younger age, as you said, and which can kind of make them choose wisely. I think that's one word again I will take from Dr. Pramesh's other campaign, which is towards the medical side, you know, the healthcare provider, but from the public point of view also, choosing wisely is something very important.
Yes.
Because, you know, we are talking about campaigns also, and that's a very important aspect of, you know, increasing awareness, mobilizing resources and kind of stakeholders. We are seeing that this I am and I will campaign, which Ms. Pedden also highlighted, and you know, UICC is also kind of leading a lot of efforts on it. What is this campaign is all about, and, you know, what are the strategies UICC is having for improving or, you know, kind of bridging the healthcare gap when it comes to cancer care in India?
First, let me respond to something more importantly about this tobacco, and this is coming loud and clear across all panelists. We understand that tobacco is a big concern in our country as well as globally. It's responsible for the maximum number of deaths and is purely preventable. And some great points have been made by all panelists. One is trying to focus on the youngsters, because there's enough data to show if the youngsters don't take tobacco till the age of 19, some countries 20, 21, they would never take to tobacco in their lifetime. So I endorse what Professor Julka, Raman, others said, to focus on these young kids. But there's an important point while pictorial warnings, health education on tobacco do have effect. A very, very important point is taxation and making it unaccessible. And I draw your attention to a very nice article by Prabhat Jha from Canada, which came in the New England Journal of Medicine, showing that as you raise taxes, consumption decreases. And for us in India, usually taxes hit the high-end products of cigarettes, and you can see a drop in cigarette consumption, but it does not affect the BDs and the chewed tobaccos. And I think all of us sitting across this table who can influence decision makers, people who make policy, need to keep these cheap products out of our youngsters. So I think it needs to be a multi-pronged attack, and then we'll be able to, of course, the point you made, Kamal, about vaping and various other things, the hookah bars that Dr. Julka made, it's all access, something that's trendy, but the man on the street goes for the other products, and I think we need to focus on that, see that it's not accessible to them. Quickly to come to UICC, what is the UICC role? Why did we start this World Cancer Day? Basically, it was to create awareness. It was to get people aware that cancer is a problem, and everybody then pitches in their own effort towards cancer control. We have a slogan, we have a theme. The last 3 years, it was I am and I will. We kept it, and this is the last year of I am and I will. And primarily this I am and my will gives you the leeway to mold this campaign on the 4th of February to your particular situation. You raise awareness, improve education, fight the stigma, inspire action, all with an impact to reduce the cancer burden. It's an open invitation to everybody to adapt, to personalize the campaign, which can be done by using materials that we have on our website and various other things. But moving away from this campaign, basically, if you look at the UICC, and I'll quickly tell you what the UICC is about, it's the largest NGO committed to the cause of cancer control globally, and as you said, based in Geneva. And our work is focused on 3 main buckets. One is advocacy for tobacco, e-cigarettes, cervical cancer, whatever you have. I'm not going to spend too much of time on that. The second is convening. We convene some of the most powerful meetings where we get together all stakeholders on the table. We have the entire international cancer community, we have government leaders, we get the media together, we get the civil society, all to put policy in place. So we have advocacy, we have convening, and the third is what we call capacity building, where we kind of get people involved, train them, help our organizations, our member organizations to get the skill set to fight against cancer. So when you ask what does UICC do towards cancer control, it is advocacy, convening, capacity building. We work with multiple partners, both within the government, that's things like WHO, IARC, IAEA, as well as private players towards this cause of cancer control. And our approach to cancer control, we've realized, is prevention, it's early detection and treatment, as well as palliation. And I want to make this point today on World Cancer Day, that palliation is something that's totally neglected. We must prevent cancers, I agree. We must diagnose them early and give the best treatment. As our distinguished colleague from Bangladesh made a compelling point, but let's not forget that we will have patients who will need palliation. And palliation has moved away from caring for only the dying patient into what we call integrated palliation, where you bring the palliative care worker, the palliative care professional into treatment the moment you have advanced cancer, and it's shown to have multiple benefits. I'm not going to spend time here highlighting those benefits. So in brief, Kamal, this is what we do at the UICC.
Thank you so much, Dr. De Cruz. I'm sure that you are also trying to kind of achieve these objectives, especially those focused on cancer, tobacco control and other aspects with the Indian government as well, to ensure that we have been seeing taxation increasing, as you said, on cigarettes, but at the same time, yes, there are many other cheaper products available in the market which people have easy access to. Let me go back to Mr. Modi again. Saumilji, you saw that kind of awareness is one part, and then the action is the other part. And awareness is not normally getting translated into action. So while the medical aspects are there, we are increasing capacity, as Dr. De Cruz said. A lot of new interventions are coming. There is a medication for every gene mutation, and there is a lot of new development. But at the same time, prevention remains the hallmark of cure, as Dr. Julka highlighted. And the prevention can happen only when we are, modifying our behavior, for which I think the action, and then again, I can take this I am and I will kind of concept also in that, because that is what highlights the responsibility of preventing disease or staying healthy on the individual, rather than on the, outside factors alone. So how do you see that, the whole awareness to action can be, triggered, and what stakeholders like you, or, Manipal Hospital, or, the thought leaders like Dr. Advani or Julka or De Cruz need to do, or, maybe institutions like WHO?
Yeah, I think, Kamalji, one thing that comes to mind as you speak, and as all the distinguished panelists have spoken, I think I could coin a term for this, and that term for me, what as a company we could do, or what a lot of other people could do, would be rapid, right? And when I say rapid, it covers all the various stakeholders who are involved in the treatment as far as cancer is concerned. And let me break this down for everyone's benefit. I think the first part that we talk about from rapid R is recognizing the patient's power. And I think this is one area where we need to really get even patients early in the treatment paradigm, right? Or even in the awareness and the screening part as well. What happens usually in our countries, patients are typically very passive during the entire treatment, but hearing the patient's voice is going to be very important. Are we designing the clinical trials with the patient's input in place while designing patient access programs, right? So most companies have good access programs in place so that a lot of people can benefit from it. But are we taking the patient's input while designing this program? So patient becomes a very critical element when we talk about screening, when we talk about awareness, when we talk about treatment as well. So how do we recognize the patient's power is most important to us. The second big that you rightly talk about from is awareness to action. That's the A I'm talking about in rapid. And what we've done over a period of time is like, breast cancer action one, where we work together. I think that was a very good example. It was not only about awareness, but creating a clear path forward that what we need to do. We are also working with groups like John Hopkins. We are running a program in Orissa where we are strengthening at the district level as well in terms of how they can diagnose cancer patients and then get them to the regional cancer centers. And so that's going to be very important, that everyone does n number of activities, right? As corporates we do, individual doctors do, regional cancer centers do, everyone in this country does n number of activities. But what is the impact we're trying to create? I think that needs to be predefined to reach any solution or provide any meaningful solution to the population at large. The third part of rapid, that is P, is the power of partnership. And here I would like to mention one thing. I mean, this is an area where, it's always said that we all together are one team, we are more smarter than an individual. And that's where industry and organizations like Tata or a lot of other organizations can really come together and work. We are working, for example, with SP Jain Institute, and we run program called Saksham, where what we try to do is, whether it is the patient advocates, whether it is other groups, how can we strengthen the NGOs and the patient advocates so that they can take the continuum of care to the next level. The other part being improving health system. As I said in my earlier part as well, right, through Ayushman Bharat, see, there can always be criticism of various programs being run in the country, but the magnitude of our country, it's just impossible, right, that on day one you will get it 100%. So what we really need to see, whether it is companies providing access or whether it is government providing access, are we making that incremental value addition, or are we creating that incremental impact year on year? Have we made progress? I think that's the most important part. And with digitalization, with National Cancer Grid, I'm very sure that our health system is on the right track. Government is putting in a lot of money. Of course, it will not happen overnight, as we said. It will take time, but step by step, it's going in the right direction. And finally, the decentralization of care, which I think, I'm not sure whether Dr. Advani is still online, but he was one of the, along with Tata Hospital, I think in the private sector, Dr. Advani was one of the persons who thought about it much earlier. I mean, he started practicing in suburbs of Mumbai. So you would say that, in Mumbai, everyone has an access to cancer care, but that's not the fact. He started practicing in the suburbs. He opened up a hospital in Ghatkopar where he started providing quality treatment to the middle class population. Now he goes around 80 kilometers away from Mumbai at a place called Ulhasnagar, where he provides, otherwise a lot of these patients would never get quality care. Like Tata Hospital opened at so many centers across the country. HCG, Manipal have gone to tier 1s and tier 2 cities across the country. I think decentralization of care is also very important. So I would want to leave you and everyone with a message and with a word that we've coined on World Cancer Day, that's rapid. Recognize the patient's power, awareness to action, power of partnership, improve our health systems, and decentralization of care. Thank you very much.
Thank you so much, Somilji, for giving such a wonderful coining this term. We have heard FAST for stroke detection and action, and I'm sure rapid will be and can be an important aspect or a new kind of rallying point for multiple players to kind of put their efforts on. Ramanji, your final remark that how this whole awareness and maybe the kind of term Somilji highlighted, rapid, can be taken forward in institutions like yours.
I think one of the important things which I already covered, just before 10 minutes about the youth. The other aspect, what it is we need to also look at some kind of PPP models, public-private partnerships, where we can, go down to tier 3, tier 4 levels. Because the fact of the matter is that your primary healthcare at these levels is not as robust as possible. Manipal is working with the government and few of the sectors like Sikkim and all. So that is something which we can create. I don't know, at the bottom pyramid, when you look at the BPL level, they are not even aware that there are something schemes like Rashtriya Arogya Nidhi scheme, which, provides care for patient care and treatment. So that is something which we can, which is another aspect which I said, which we can look at. And like I said, prevention is better than care. We service our cars once in 6 months. We don't do with our health. I mean, 30% of these problems can be taken care. I mean, if the government and the hospitals, the private hospitals come together, we can run, these free mammogram schemes, reach out to, these camps, basically at the grassroots level. See, at the education level, or when you call it tier 1 or a tier 2, we all have access to mobile phones. We all know what's happening in and around. But when you go to the grassroots level, I think that kind of awareness is very, very important. And like Mr. Cruz said, that yes, tobacco is something, and now if you look at it at the village level and all, I was talking about the youth consuming, the maximum consumption is tobacco, not cigarettes, because their access to this, some of the other kind of tobacco is very much there. I think the need is to go down at the grassroots level to create that awareness along with the government. The need is to reach out to our youth and of course run, this public-private partnership platforms where we can, carry out aggressive, like we said, rapid, aggressive awareness scheme. I mean, that is something we should look at. COVID is there, we have to live with it, but I think we need to start focusing on the other aspects of healthcare as well.
Thank you so much, Ramanji, and I'm sure Manipal, and we also recognize Manipal's effort and willingness to join us on this platform to kind of make this awareness reach and bring multiple stakeholders together to kind of strengthen our fight against cancer. So as a conclusion of this 1.5 hour of discussion which we had, some of the finest minds and leaders of cancer care in our country. I think what a message I would like to take away, and for our audience as well, that what word Mr. Somil has given, rapid, I would like to kind of give a different meaning to it, or kind of different expansion of this word. But this is going to where we are going to make a substantial difference when it comes to the prevention of cancer. Maybe the R of rapid stand for recognizing that anyone can get cancer. We have a tendency that cancer is something which will not happen to me, and which kind of keep me on the track of the various risk factors which can easily be eliminated, whether it is of reducing the tobacco consumption, or kind of taking up the healthy life attributes. The A of rapid, I think, is about action. That if you have got awareness and you have recognized that you too can develop cancer, because to not have cancer, the only way is to not to be born, because we by nature are susceptible to cancer. And as we have seen that we are living longer, we are the cancer numbers are also increasing. So if you have recognized that you too can develop cancer, act on it. So rapid, the A stand for act on it. P is about kind of practice good eating habit, practice good sleep, practice maybe kind of exercise, and ensure that you kind of stay on that track. That is one thing can help a lot in terms of reducing the cancer burden, or preventing the disease from you. I think I can keep improvising on your these efforts. And D, if in any case you are diagnosed of cancer, be determined that you will win over it. I think this is what rapid can stand for me, but at the same time, rapid can definitely be the way forward. So thank you so much, all our panelists today and our audience, for joining on this second edition of Cancer Summit. And the next session is going to be, we have already got our panelists for the next session, and also my colleague and co-founder of IHW Council, Dr. Bobby John, who will be moderating the next session. We have a lineup of esteemed speakers who will be discussing about what are the technological advancements available, how cancer fight can be strengthened with the technology. So thank you so much, everyone, for joining us today on this morning. Over to you, Bobby.
Kamal, thank you very much for the excellent session that you just steered through. Thank you all for those who were part of that session, joining us in our second Cancer Day conference. We switched gears from the broader aspects to something more specific, and it is my pleasure to invite and present to you Dr. Chandrasekhar Sibal from Fujifilm, Mr. Vibhav Garg from Boston Scientific, Dr. Anushil Munshi from Manipal Hospitals here in Delhi, and Dr. Bhavna Sirohi from Apollo Proton Center, Chennai. We have the privilege of having your expertise with us. Thank you all for joining us this afternoon. For those of you who are joining us on this program, whether it's through our live feeds or whether you're directly connecting in, thank you. Part of our exercise here is to enable you to understand the multiple dimensions in which cancer both presents itself and can be addressed at individual and at the larger collective levels. IHW is able to do so by standing on the shoulders of giants who are there on your screen. It is their words that matter. My job is to make sure that I ask the right question and enable them or clarify their answers back to you. To those of you who are part of this panel, Dr. Sibyl, Garg, Munshi, and Sirohi, if there is need, I will interrupt you so that I can be able to translate or simplify or clarify a question. But otherwise, the words are yours. You have an audience who will be listening to you very carefully. For this session, for the next 50 minutes or so, we're going to think through and understand what is it that is new and exciting as far as the world of cancers is concerned. Cancer is not new. The dimensions of cancer, the burden of it seem to be increasing, but that seems to be also a result of better awareness, earlier diagnosis, and more facilities available. It's treatments that have really been jumping forward. Significant advances have taken place, where earlier it was restricted to a few chemotherapeutic agents, few modalities of radiation, a lot of broad surgical interventions. Today, you're able to go very, very specifically. And so let me start with the clinicians here. To Dr. Bhavna Sirohi. You've seen cancer and you've seen advances, and you've been part of leading some of the advances in how cancers become treated in this country, as elsewhere too. What are the most exciting things that are happening? And I see that you've also had a change in affiliation since the last time we've had you on this panel. Welcome.
Thank you. Thank you so much, Mr. Bobby John. It's a pleasure to be part of this meeting, because I think IHW, I must congratulate that you are doing great work in creating awareness about cancer. And I have moved to Chennai, to the Apollo Proton Cancer Center, because I think for me, I'm quite passionate about, and I think that's where the future is for cancer care, is site-specific oncology, not only in surgery, which is happening in a lot of government centers, including AIIMS and Tata, but in private sector as well. Because I think to drive excellence, we have to try and choose 2 or 3 tumor types, which we are able to do education and research in. So I think the Apollo Proton allows me to do that. The greatest advancements I think that I have seen, and which are very relevant to us as a country in India, which is a low and middle income group country, is that technology is important, in surgery, radiation. But I think the 2 modalities that help curing cancer, and Anushil is there on the panel as well, and I'm sure he will talk more about it, is surgery and radiotherapy. So I think we have to, as a nation, make sure that patients are diagnosed early. For that, we have to try and region-based screening strategies have to be adopted. Like in Northeast region, we know stomach cancer is quite common. In certain cities, breast cancer and colon cancer is common. So we have certain screening modalities like a mammogram, a stool occult blood test, which should be part of a national screening program, especially, based on the incidence. If the incidence is high in that region for stomach cancer, we should have risk-adapted screening strategies for that, so we are able to diagnose cancer early. So that is one, I think we have to, there are enough advancements that have happened, we just need to implement them. Second thing I think we have to do is every new cancer patient who's diagnosed early must get appropriate surgery. It's very important that the key stakeholders, especially in the government, drive the right surgery for the patient. So in this day and age, I'm still seeing patients who's undergone a colon cancer surgery and has had 3 lymph nodes removed, which is not acceptable. There are guidelines, there are principles of cancer surgery where, you need to have at least 12 lymph nodes removed. So I think we have to get the basics right before we move on to, the robotic surgery, the newer modalities, and all of that stuff. Because I think the higher technology or the more costly technology is not important. It's more important that we do at least the surgery and radiation right for our patients. And of course, in my field in medical oncology, there have been amazing advances with, liquid biopsies. You have DNA-based blood tests, through which we can diagnose cancer and find out targeted treatments which can help us treating. The AI-based, the artificial intelligence-based treatment modalities that we can choose. So I think all of that is also quite important. But like you said, early diagnosis, getting the treatment right the first time, especially the surgery, I think we have to invest in that as a country.
Sorry. As a medical oncologist, thank you so much for highlighting the need for effective surgical interventions in the first place. And that's very, very key and at a very base level starting point for an effective outcome for individuals and at a broader level.
Yeah.
Thank you also for pointing out that your outcomes are only as good as how early and how appropriate a diagnosis you get. If you don't have an early detection, then the abilities of your treating team, physicians and everybody else around them is going to be just that much more constrained. And so therefore, for those of you that are watching us, please, these are not very difficult things to do. If you're a male, feel around your body, look into a mirror, look inside your oral cavity. If you feel that there is a change in color somewhere, if you think there is a small nodule or a lump that seems to be behaving differently from what you saw it last time, please do consult. For women, if you feel while having a bath or while you're able to examine yourself a lump in your breast, please make sure that you do get to your care provider. The earlier you pick up, the better it is for you and for your treating team so that you can get on with life. We have an economist with us, and I want to kind of switch to him wearing his economist hat rather than his current Boston scientific hat on. Help us understand, with the vast scale that we are kind of looking at cancers in India, what is the cost, or what do you estimate as the cost of the missed opportunities of early diagnosis? And then we'll get on to the things that Dr. Siroya has kind of pointed out, to the advances, the specifics, and then look at how things are changing on. But just wearing your economist hat, please.
Sure. Thanks, Bobby, and thanks for inviting me for this panel. It's such a pleasure to be here again. And I think on this World Cancer Day, it's very, very opportune time for us to discuss what we are discussing on this panel and this conference throughout. I think before I really wear my hat of an economist, health economist, I think Dr. Bhavna just gave some statistics about what cancer are we struggling in India, and I think I want to really read out few more so that people are aware. And I was just browsing through some literature some time back, and I found out there are corners in the country who are supposed to be the highest incidence of cancer in the world, right? And that's not a good news for a country like ours. Globally, non-communicable disease is like 71% of deaths. India, it is almost 63, and out of that, 9% is cancer. If you do the age-adjusted incidence of gallbladder cancer in women, New Delhi is 10.6 per 100,000 of the population, which is world's highest rate for women for this cancer. I mean, so, and then if you really get into the central, south and northeast India, we have the world's highest incidence of cancer associated with tobacco, which is chewed as well as smoked in India. Aizawl district in northeast, of Mizoram has the world highest incidence of cancers in men of the lower pharynx, which is almost 11.5 per 100,000 people. We're also talking about the tongue in the same area, tongue cancer, 7.6 per 100,000 people. So I think we are talking about the kind of, India's pockets where you have the highest incidence of cancers, which is really, really concerning for all of us in various healthcare segments in the country. And I think now if I veer the head of economist here, we are total NCDs, sometime back, the number which was given, Bobby, was $30 trillion, the kind of burden of non-communicable diseases that we have.
Is that for India or global?
We're talking about global,
Okay.
right? So and then I think India being capital of so many of those non-communicable diseases, you talk about diabetes, you talk about cardiovasculars, and then now cancer is adding to a lot of it basically. And I think that's where it becomes even more important for us to focus on, as Dr. Bhavna is talking about, how do we get the patient early into the care continuum cycle, right? So diagnosis, that has become more and more important. And I think in the earlier panel also, I was hearing a couple of speakers, how do we bring a patient closer to a facility where a screening can be done? And that screening, the challenge remains is, we have seen many government programs as well and many individual screening many screening program run by the different organization. The challenge remains is when we don't connect the screening with the treatment. Yesterday I was happy because I knew that I don't have any challenge. I got screened and I was told that you have this XYZ cancer, diabetes or cardiovascular aim, and then I'm left open in the society. I think that's where remains the challenge as to how do we really connect the total care continuum. And I think that's where you are also trying to, reduce that burden on the health economy by bringing people at right time in this care continuum at the time of diagnosis and taking the patient right from the diagnosis to the treatment and to the palliative if required, basically of that, right? So I think this care continuum for cancer treatment is very, very important. We have, if you remember, Bobby, last time when I was on the panel, we talked about the kind of infrastructure that we have, in the country for diagnosis, which is maybe at times like your cyclotrons and your PET CTs for diagnosis, and then taking the patients throughout to the treatment to the palliative care. So I think there is a need to look into the whole paradigm in a holistic manner, from a diagnosis to the treatment to the palliative. There was a scheme of government, you would recall, NPCDCS.
Sure. Before we come to the thing, I mean, there's something that you've said that kind of intrigues me. And it ties back to what Dr. Bhavna had started off with. That we need screening, we need targeted, geo-targeted screening or population-targeted screening. We also need maybe disease-specific or system-specific targeting. And even if we do so, and that's your point, I think, that I want to kind of highlight here, even after having done a good screening, if you don't connect people to a good next step, which is probably a surgical procedure, then all the costs and all the benefits that you had sought to get from that screening is also kind of undone. And that is something that we should take seriously. Not doing something is bad. Doing something and then letting go in between is a double whammy, which means you have incurred the costs and it hasn't delivered the care that people ought to have realized. And there's a moral hazard to this too. And so therefore, the message that I would like for all of us to hear, for those of us in the audience who are listening, that if you're conducting a screening camp, or if you're responsible, if you're part of the ecosystem that makes these decisions, ensure that there is connectivity. They have to, you can't just do a job and walk away. You have to hand over the people because it's their lives. And this is where I'd like to kind of now bring in Dr. Munshi here. When people come in and assuming that there's a team, cancer is not a single person effort at any point in time. At least that's my understanding. So if you've had the diagnosticians work their way through, the medical oncologists and the surgical folk have also done what they have done. At some point, they also come to the radiology side of the team. What time do you need to be in place? Do people need to be scared that some radiation is happening? And I'll come back to the proton bit a little bit. It all sounded like very nuclear going on there. What is it that people need to be aware of? And how have things changed for the better?
Thank you, Bobby, and a very warm welcome to all the listeners today afternoon. And it's really commendable the kind of work that the organization is doing. I'm the head of the Department of Radiation Oncology at Manipal Hospital, New Delhi. And what I would like to say that over the last 15, 20 years especially, there has been a phenomenal rise in the finesse of the technology that we are using. And when I say technology, I don't mean the technology that's readily visible. For example, radiation oncology, you really are seeing at ground level how the technology is evolving, but also the technology, for example, which is not so much prominent, but working in the background, for example, the IT and AI and things like that, which have really improved the continuum, starting from maintaining a healthy lifestyle to diagnosing cancer early, to treatment and subsequently follow-up. So this entire care has been affected by technology in a big manner. And talking specifically about the treatment part, we are now in a period where more and more of interdisciplinary care is being talked about, a very holistic approach rather than treatment specialties fighting with each other for kind of dominance or something. It's more of an environment where you sit together across the table in tumor boards and then decide a holistic plan for a particular patient. So that way, more and more people and more institutions across India, across the globe, are recognizing the need of interdisciplinary care and providing, and especially please remember that in cancer, unlike other specialties, cancer is a specialty where you need many further specialties working together, because do remember that most of the patients are going to require actually two or more modalities of care: surgery, radiation, chemotherapy, and immunotherapy, so on and so forth. So most of the patients would require two or more modalities of care. And it is very appropriate that you at upfront only, obviously you can change the plan as per the patient's response and so on and so forth, but at the beginning you devise a kind of flow of care for that particular patient based on the information that you have, based on the imaging and other things that you have. Specifically talking about, we know there have been so many advances in surgical oncology, image guidance surgery, and special knives that they have got these days, medical oncology advances, T-cell therapies, vaccine-based therapies, so on and so forth. And it's all really very exciting. Obviously, our end aim is to individualize treatment. So look at the way we are working. We have to work at two levels. As, for example, the economists in the panel and the financial experts in the panel would think of broad things, would think of population-based approaches. But simultaneously, as doctors, we have to boil down to that particular patient and see what is the genetic and what is the pathology of that particular patient, so that we can finally boil down and give an individualized kind of treatment to that particular patient for having the best outcome for that. Ultimately, that individual's health is of the most importance when the patient is in front of us. So we have to work at both levels simultaneously together. And in radiation oncology, the advances have been phenomenal. We were using very crude machines, soft X-rays. In fact, there used to be just one department of radiology around 40 years ago, and they used to treat by radiation, therapeutic radiation. But now our own specialty of radiation oncology has evolved, and linear accelerators, MRI-based linacs, protons, flash radiotherapy, and I think the list is endless. And the entire aim is to increase the tumor control rates, improve survival, and decrease side effects for our patients.
Dr. Munshi, thank you so much. And I'm glad that the flavor of interdisciplinarity and of collaboration comes through from both the clinicians who have kind of spoken right now. That unlike in the past where it could be a kind of a real Superman cancer specialist, it is today veering towards almost like a board that's coming together to allow for a discussion on what seems to be best for the individual. And it draws on from the best in multiple disciplines. It's no longer siloed. So thank you so much. I also like to kind of highlight what you said, Dr. Munshi, which is that as clinicians, you are honor bound. You have a moral obligation for the highest outcome possible for the individual. Without detracting from that, we also have to recognize what Mr. Vibhav Garg said earlier on, that the numbers are not in the singles. The numbers are in the millions. To be able to recreate a proton center like the one that Dr. Sirohi has, and I will come to Mr. Sibal very quickly, because between him and Mr. Garg, I mean, they are the people who enable clinicians to be able to run or operate in such centers with the technological advances that they and their companies kind of lead on. We have to kind of come to a place where how much is enough, and is it possible to do things early so that we are able to avoid more and more expensive interventions for everyone. It's a hard question to ask. Not everyone will come on day one. Not everyone will be screened. How many can we optimally screen? How many do we need optimally to be accessing the kind of services that either Manipal Hospital with Dr. Munshi or at Apollo centers in like Dr. Sirohi have? I mean, how do we kind of make sure that there is more of that? And this is where I turn to Mr. Sibal. Companies like yours, Fujifilm or Mr. Garg, Boston Scientific, and there are many. You're not the only ones. There are many. And it's both in the radiology part of it, and as Dr. Munshi kind of pointed out, there are phenomenal advances in the way we are looking at advances in monoclonals, in vaccine-based therapies, in gene-based approaches, or in the surgical side, how we are kind of getting in. How are companies like yours beginning to think through in the same way that Dr. Munshi mentioned, working as a team? Or is it that you sit in the company and you design something and then say, right, we will now go and sell it to the hospitals and the doctors? How is your partnership taking place?
Yeah, so thank you very much, first of all, for giving us the time and opportunity, Dr. Bobby, and thank you very much all the panelists for bringing in this kind of a topic. And I'll tell you what Fujifilm is doing and what are our future plans for this. So as you know that Fujifilm was a film company. The film role used to come, but we have expanded now into healthcare in a big way. And now we are into COVID vaccines. We are into very many areas which were not, the Fujifilm was not known for. It's now into the helm of the technological things, not only the films. And the film has gone out of the business because the digitalization has happened. And that's the way forward. Digitalization is going to bring a lot of transparency and everything. So that we are also going to be part of that. So what we are doing actually is that we have the products like full field digital mammography, CRs, DRs for digitization of X-rays. as well as many other like endorectal or colorectal, this thing. We have endoscopy systems for all these screenings. So we are making manufacturing all these things. And what we are planning in India is that screening, public-private partnership, and AI. So multiplication of all these things, screening into public-private partnership, into AI. And we have already done in Assam, more than 100 centers of X-rays have been installed in the smallest of the small places. And they are connected to teleradiology. All of that are, an immediate report has been given to the patient within few hours, where even to reach is also very, very difficult. And not to say that there will not be any specialist doctors will be available on those centers. So screening is very, very important step which we are taking. Not only in Assam, we have done the screening with the public-private partnership in Himachal Pradesh, Uttar Pradesh, we are doing in Maharashtra, and many, many other states we are going to do that with the public-private partnerships. We've also done a lot of things on the mammography education to the doctors, that the new advancements in mammography like 3D tomosynthesis, the CEDM written for the biopsies. We have done a lot of papers from India. A lot of books have been written in this thing. We also started a fellowship program in breast imaging with Max Hospital. So these kind of things we are doing. And also we are collaborating with healthcare professionals for development of AI technology in India. So we are developing the deep learning, and with the help of medical care, taking these to the next level. Because once we have the screening on board, what we'll do that you will have to do a mass screening, but you have to have the doctors to report those things also. So AI is going to be a very, very helpful tool there. So once we are doing, and we have recently opened 2 days back a screening center in Bangalore. That is the first in the world where all the AI technologies which Fujifilm has is going to be utilized for screening the patient. And with the help of that, we are going to give the reports to the patient. And the main aim is early detection of the cancers. Because we know that once the cancer is detected early, the treatment becomes so much cheaper and it is more effective also. So the cost of the treatment is also less. So our point is that if we can detect them at the earliest, and we know that in Japan, in US and other countries, we are mainly talking of the breast cancer, there the mortality rate is very, very less because the screening programs are there. But in India, the screening programs are not there and the population is so huge. So we are making those excellence, center of excellences, where those screening can be done and people who want to get them screened can come, and who has some history or those kind of things of their parents or their family members, and all those people can come and they can get there. And also in the corporate world also, we are trying to have this kind of yearly screening programs or kind of things, so that corporates can also avail those things. And we are going to install 100 these kind of centers across the Southeast Asia. India is the first one, and we are going to have many, many such centers with the help of AI. And we are going to detect all the kind of cancers with our technology, latest technology.
Right. No, thank you. And the thing that I want to kind of pick up from what Mr. Sybil has been speaking, a laudable initiative to kind of deepen the reach of imaging machinery so that there can be better and earlier diagnosis. The thing that he's kind of pointed out, and I want us to be aware and also take on board, is the fact that radiology and machines that are imaging are essentially producing images. We do have a shortfall of specialist radiologists who can, in real time or in near real time, report on what is being imaged. And that gives rise to a gap that we had pointed out earlier when we were at consent. Screening has been done, you've taken a film, and then the appropriate bit, the next bit has not happened. And that's where, I mean, repeatedly, Mr. Sybil kind of use the word AI, artificial intelligence. It's not about something very, very fantastic, but we have seen experience from, say, tuberculosis and other places. If it's an image, and this is also the future of medicine and of making a diagnosis more efficient, if it's an image, it is likely to be amenable to analytics using AI, which means you can move images far away. You can train AI engines in such a way that it can spit out fairly decent medical expert grade diagnosis, sometimes even better than that, as we are discovering in tuberculosis, so that you don't have to wait. Today, the turnaround time for a tuberculosis X-ray diagnosis is less than 90 seconds. Is it likely that we can apply this to the centers that Mr. Sibal is kind of talking about? It will require the expertise of many, many medical specialists to train the engines. But as we go forward, it could actually begin to make the delay of a diagnosis, at least for an image-based modality, so much more quicker and more reliable. Let's turn to the other side of the technology part of it. And Boston Scientific continues to kind of innovate in multiple areas, and your products come in multiple sides. It's not just one side of the story. How are you, again, the same question that I'd asked, how much of a collaborative effort is it between you and the clinicians to understand and then to provide for the instruments or the tools that are appropriate and useful for them?
Thanks for that, Bobby. Again, I think, let me put it this way, the collaboration between healthcare professionals and Boston Scientific R&D engineers is like the backbone of the technologies that we bring in, every year, newer technologies for various ailments across the globe. With that thought in mind, Boston Scientific opened R&D center in India back in 2016, and we have opened another one now in Pune as well. So there are two R&D centers which are very, very closely working with healthcare professionals like Dr. Munshi and Dr. Throhi to bring out, first of all, to understand on the ongoing technologies, what are the challenges that they face in various segments that we deal in. And also after that, what are the improvements that can be brought in to make them even more effective for the patients from a clinical outcome perspective, and for the physicians like the two on the panel from a delivery perspective, from an intervention perspective. So I think that's very, very critical for us. Another thing that I want to talk here is technology development alone at times is also beyond the thought process that we have for so sometimes it is like incremental innovation, and sometimes it is like like extreme innovation. So I want to talk about here a similar innovation which is not yet launched in India, but I want to talk about it, something called TheraSphere, which are yttrium-90 glass microsphere therapy for the treatment of hepatic neoplasia, right? And this is giving fantastic results, wherever it has been launched. And that's it, like we are talking about, insoluble glass microspheres, to be very, very targeted therapy in this particular cancer type that we are talking. And then also we have something called, cholangioscope, which is used for various cancer type in GI cancer. Obviously, GI is not like one type of cancer, there are multiple cancer out there. So I'm saying the technology is taking incremental steps as well as the extreme step when you're, and I think Dr. Munshi was talking about it, targeted therapies in cancer. Dr. Sirohi talked about it, the targeted therapies in cancer is so becoming important, and that's where your next generation technologies are coming in, which are providing a very, very targeted therapies in cancer. So I would say that I think this collaboration is very important for companies like us to bring newer technologies on board. Thank you.
I would just place a nuance there to what Vibhav said about the nature of innovations. A lot of innovations are incremental in nature. They just build on something and they keep on moving. And then he used the word extreme. I'd like to kind of scratch that word with due apologies to you and say there are incremental technologies, and then there are incremental innovations, and then there are disruptive innovations. They completely disrupt the way you've been doing things, and you have to now look at a whole different way of doing things, simply because it makes sense, simply because it gets you better outcomes, simply because it drives down costs, simply because more people are able to use it. That is something that we would seem to need more of, especially given the context of the numbers and the wide variety of people who need care, and the paucity of both the centers and the specialists who are able to address the vast need. Is it possible to clone Dr. Bhavna Sirohi and Dr. Anshil Munshi 1,000 times? Is that a good thing for cancer care? Absolutely. Is it possible in our lifetimes? Certainly not. Is it possible to get the kinds of centers that they have in every taluk of this country? I can hope, but I won't be able to hold my breath for that long. So then the question comes back to the clinicians here. You're sitting pretty much at the pinnacle of your professional and infrastructure pyramids. How do you see the kinds of services that you're able to give, the highest quality of care to the one that lands up in front of you? How do you see that same care now being distributed across the 750 districts of this country? Especially in the light of what has been spoken about earlier this week. Our finance minister basically said we will have more centers, more decentralized facilities across the country for health. This has been a year of health. This has been a year when people have understood that if a company comes up with a new intervention, it requires trials. It may not work in the first go. There's a better understanding. And I think there's a better partnership also shaping up in the minds of people. How do you kind of use that backdrop for ensuring that the skills and the interventions that you both have are more made widely available? Let's start with Dr. Bhavna.
So I think I must congratulate Mr. Sibal and Mr. Garg for doing great work via Boston Scientific and Fujifilm. I think it's very important. 70% of our countrymen live in the villages, but most of the cancer centers are centered around urban areas. I mean, patients have to travel thousands and thousands of miles, say from West Bengal or Northeast India to get to a place like Tata Hospital. Or, I see a lot of patients in Apollo in Chennai who come from Northeast and from West Bengal. And so AI is going to be very important for scalability. But I think we have to be very careful that we have balances and checks built in, so that, it's great to do X-rays, mammograms, and all the technologies. The 4 cancers which lend themselves to screening are, breast, for which you can do an X-ray of the breast. But it's very important that, the facility that you have is a digital mammogram. If the patient is less than 50 years of age, you also build in something like digital breast tomosynthesis, because otherwise you're going to give false reassurance to the patient. It will be a false negative. The patient will not come for a screening for another 2 or 3 years. And how are you doing these quality checks to make sure that this happens? Because I was involved with this in London, I remember. It's a lot of research and a lot of hard work that goes into it. So that's for breast. The second cancer that lends itself is a common cancer for us is cervix cancer, So you can, yes, there is a technology where you can take pictures. The lady can take the pictures and send a screenshot, and the gynecologist or the doctor can assess it and see whether there is any abnormality. So that technology is coming up. We should try and scale it up. The third cancer is colon cancer, for which, the Western world does a fecal immunochemical test. So we do the test in India, but we do it by the GAIAC method. But we don't elaborate. What I've seen in most corporate sector, in most centers, is that, the GAIAC method needs at least 3 separate bowel movements, which means, 6 stool samples. I could not convince my uncle and my mom to give 1 stool sample. It took me like a week to get that sample, because it's, as Indians, we just don't. And so how do we get around that? It's becoming a common cancer in the cities. So we have to adopt something like fecal immunochemical test, which needs no dietary measures and needs 1 stool sample, and you have the result in an hour. So we've started this here at Apollo, where I am, and I think at Max as well, where I was previously, we started that. So these are the technologies we need to get to every center in the city. I mean, 80% of our patients are treated by the private centers, not the government centers. So this has to be, again, scalable. The 4th cancer is head and neck cancer, very common. One can do simple clinical exam. Every dentist, every ENT specialist should be doing that. And a narrow band imaging, Lugol's iodine, simple, very cheap, very cost effective. This should be done. And again, an Anganwadi or an ASHA worker in a village could take the pictures of the cervix after a visual acetic acid or of the oral cavity and send it to a specialist, like a hub and spoke model. So I think this is where you can really help in scaling up the clinicians. I mean, at Apollo, I think one of the reasons I moved was like the hub and spoke model. At the Apollo Proton, there are 14 cancer centers. What we are trying to do is in cancer have unified guidelines and care pathways, which are site specific. Because that means that if a surgeon is operating, let's say stomach cancer, a minimum of 15 lymph nodes are removed, and that is peer reviewed. So like in UK, if a colorectal surgeon hadn't removed enough number of lymph nodes, they were named and shamed in Daily Mail. You are supposed to put up your results on the website of the trust. And they were asked to go back and retrain, even if it was a senior surgeon. So I think these kind of things we have to, it's not just the screening, exactly what you said, Bobby, that, the second level also has to be robust enough for us to improve the survival. I mean, our survival in India is terrible. The 5-year survival for breast cancer is 60%. In all the Western countries, it's 85 to 90%. Why should a lady living in India have a poorer survival just because of geography? That should not be done.
And that can be repeated for cervical cancer too. Why do we have poorer outcomes for our women with breast and cervical cancer when it's so much more easier to be able to do much better outcomes? Can we come in early? Can we know in our communities? For those of us that are listening to this conversation, can we have these conversations in our homes too? Encourage where appropriate for early screening and seeking care. Where there are adolescents, even begin talking and thinking about how you would get an HPV vaccine in place. And that's something that's also easily possible for a prevention on cervical cancer as a modality. And so those are not too difficult to do. And HPV vaccine is not just for women, it's also for men. For boys and girls, it is something that should be talked about with your clinician and be able to be uptaken at your level itself. Dr. Munshi, building on what...
Bobby, one thing, I just had to leave. So just quickly, I just wanted to say Australia as a country has eradicated cervical cancer. So, we have eradicated polio. So we can also do that by a coordinated screening strategy. So by getting it on the national immunization schedule. And also, along with screening side by side. So we as a country can easily do that if we put all of these two strategies together.
Thank you so much for pointing that out. And so therefore, again, it's not just Australia with cervical cancer, but it can also point to hepatitis B related cancers as far as Taiwan and Korea are concerned. I mean, phenomenal advances where immunization based approaches have taken prevention of these cancers to a level where elimination has been thought of and elimination has been possible. Cancer and elimination can be thought of in the same breath, provided we get our act together. And immunization is one way to go. Dr. Munshi, what do you think, building on what Dr. Sirohi has said, how do you kind of see things going so that there's better democracy of services?
So I think Dr. Sirohi has beautifully articulated the preventive kind of approaches that need to be taken and early detection approaches that need to be taken and how they need to be percolated throughout the country of India. So what I would like to begin with, and I hope everyone in the panel, in the audience is listening to this, Mr. Sibyl and Mr. Garg especially, I have my ears. So what I want to say is that India's population is around 1.25 billion right now. Around we see around 1 million new cancer patients every year. We have around prevalent 3 million cancer patients in our country as we talk now. Fortunately, the incidence of cancer compared to West, compared to US, is still low in India. Although because our numbers itself, the population itself is so big, so our problem is also kind of bigger. But cut to 2050. Cut to 2050. Our population pyramid would have changed. Presently, 50% of the population we have is less than 25 years of age. 50% of the population is less than 25 years of age. 2050, our fertility rates are already lowish. We'll have a much older population moving around. I take a ride in metro once a while, and when I see around, they're all youngsters. Compared to me, they're all 30s and 25 and this thing, that's it. In 2050, that would not be the case. And with that, the spectrum of cancer would change, the incidence of cancer would change, the type of cancers we are seeing, that will change. And please keep that perspective in mind when we are talking about technology, when we are talking of evolution, detection, diagnosis, treatment, and everything. Because if we are not geared up to that, we'll be always taken up, we'll be facing some kind of a surprise as we move ahead. So that was one thing that I wanted to talk about. The second thing regarding the suggestion, we have recently published an article in the Indian Journal of Cancer regarding the kind of problems and the possible solutions related to radiation therapy throughout India, regarding the asymmetry that we face region by region, north, east, south, west. Our percentage population and the percentage of machines catering to the population is grossly, there is a mismatch between the two, especially when we talk about the eastern part of India. Much lower machines you have compared to the population. I must say things are getting better now. But compared to the standard norms, we are far, far lower. We urgently require probably more than, we currently have 600 radiation oncology machines in India. We probably require, just to go to the world standard, 1,000 or 1,500 more. And if you want to really be at the upper level, at this developed nation level, maybe we need 5,000 machines. So that is the kind of scale that we need. The problem is, it's not only the machine setup that we should be bothered about. Because you set up a cancer center, you set up a machine, you get an infrastructure, so that is fine. But then you need to have personnel. And it's not that you just cut and paste a person, bring him from some part of the country and put him there. He needs to have a support for his family, for a good school for his children, and so on and so forth. It needs to be looked in a comprehensive manner, and then only that person and that center is going to flourish and going to do well. So these are the smaller things that need to be taken care of when we are talking of bigger things, such as putting up machines, putting up infrastructure, and putting up this and that. So it's just not you put a center or make a machine or set up a machine at a remote part, but you need to take care of the rest of the things as well. And then only that center is going to do well. Some panelists in the panel talked about public-private partnership. Yes. I think, and we have brought this out in our article as well, that public-private partnership is definitely a way forward. If both join hands, I think it will be a win-win situation for both. I think some steps need to be taken in this direction from both sides. And I think it will be a win-win situation for everyone in this country. The poor, the more affording, everyone. All patients will get better quality care if we at least start using this model in some parts of the country. So these are some, and some more we have, you can go through our article, we have given more suggestions in that article. So these are the things that I wanted to highlight to this panel. And I'm sure the economists of the country are wise people, the health experts and the policymakers must have taken note of these issues. And I'm sure, as I see in the last few years, things have become better. Earlier, it used to be a kind of a reflex thing. A person living in a tier 3 city, with the detection of cancer, the second thing he would do is take the next train or the next flight to New Delhi or Mumbai or any big city to get the treatment done. that trend is reducing now, which is a good thing, which means that people have more confidence in their local centers. So that confidence building needs to be done up, because cancer is a scary word. Cancer, I mean, you could have a serious heart ailment, but you still feel it's okay. I mean, it can be managed. But the word cancer instills such kind of fear. You would not believe it. In the past few months, we have seen so many patients delaying their treatment, and that's why I was. In a way, it was a paradox, because cancer is such a big kind of a threat, a scary word. The coronavirus beat cancer also in the past few months, because we had patients coming in stage 3 and stage 4. Why?
Right.
Because they did not want to report to in view of the prevalent pandemic, and it was kind of a paradox. But otherwise, we know what a scary word this is, and that is why need to instill confidence in the people that the center they have in the city or the adjacent city is a good center. Will give them good quality care, integrated care, and once the results start coming out from these centers, people will have more and more confidence, and that will be a self-sustaining and a propagative system. That's all I wanted to say. Thank you.
No, thank you, Dr. Munshi, for pointing out that as we go forward, as we look 20 years out, that the nature, the visage of the general population is going to change. It's not going to be as useful as it is today. And with that, we will get to see an increasing number of people presenting with cancers. And that then presents to us both a looming problem, but also a present opportunity. How do we take the kinds of expansion ideas that Mr. Sibbal from Fujifilm or Mr. Garg from Boston Scientific have outlined, partnering with physicians, with care providers, with institutions, figuring out how to deepen and extend the availability of screening and diagnostic services, for which we have our next panel almost in place. And then we'll talk a little bit more about diagnostics, but also then to be building up more integrated teams, as was kind of, as we began this conversation, we talked about, that it's not merely about just the medical people, it's also the surgical setups, it's also the radiation and the oncology and the imaging setups. They all need to come together and work together. And they need to work together with our biopharmaceutical people. As we're moving, I mean, we've had to let Dr. Sirohi go. As we're getting to precision in radiation services, proton beam therapies and the stuff like that, when we're talking about precision knives that Dr. Munshi had kind of pointed out earlier in the program, we're also getting to very precise therapeutic regimens for individuals. That will become a partnership not only in the hospital, but between the hospital and the developmental labs that companies are innovating in. And that will be a partnership unlike what we have had so far. Earlier, it's been slightly on two different silos. The innovators are in the companies, the users are in the hospitals, and the patients are paying for both. The future, and this is where I want you to wear your future glasses, Vibhav Garg, and tell us, how is this coming together? And what do you see as the opportunity for India?
So, Bobby, I mean, it's also a conclusion for the session, at least from my perspective, is, it is, I think technologies, getting into the therapeutics, I mean, from a diagnostic to a therapeutic side, and Dr. Munshi talked about it, that you keep taking names and you keep taking advances, and those advances are available in the country, like Western words, and clinical outcomes are almost equivalent to the Western words. And I think this is high time that we start realizing those things and start even advocating. So we talked about it last time also, Bobby, if you remember, IHW should start doing even the advocacy around those things, with government as well, as to how these newer technologies that Dr. Munshi talked about it, how the newer technologies are bringing the better health outcome, better clinical outcomes for the patients in the country. I think that's very important to think through, because when you look at the schemes the government is rolling out, whether it is PMJ or, we still see a lot of older thought process getting into how do we really make them to reach to a new level where the patient, whatever spectrum, socioeconomic spectrum they belong to, they're getting the best of the available treatment in the country. I think that's what I would also recommend at the end of my at least remark, that IHW should take up that advocacy, and it should make doctors like Dr. Munshi meeting more often to the policymakers and the regulators to make them understand that why these technologies are so important to be in the country. Thank you so much.
Thank you, Vibhav. Mr. Sibal, you've talked about the scale up. You've talked about the Bangalore Center. You're talking about a vision where there'll be greater numbers of imaging centers or even modalities of treatment that Fujifilm itself is involved in. But it's not just Fujifilm. It's the entire ecosystem of innovators and companies that are providing for the infrastructure. How do you make it also not only accessible, but also affordable? Just want to use that word once, at least in the whole conversation.
Yeah, so as you understand that now National Health Digital Mission is also coming, and more digitization is happening. And as the number of patients are growing, our cost per patient is also going to come down. And once the new technologies are coming and once we are installing these equipments in many places, definitely we are trying to reduce the cost, and indigenization is the way. We are going to try some partnerships in India where we are going to manufacture these products at a much lower cost as compared to what we are getting from Japan or US or other countries. So that's also on the cards, and we are trying to develop some partnerships with the local vendors where we are amalgamating our softwares and our technologies. And the cloud is going to be a very, very important thing, that we are going to have the patient data on the cloud as the electronic medical records, as we say, and there the comparisons of their older reports can be done. So for cancer patients, it's very, very important that once you have a cancer, then you can refer to your old reports and can see the progression of those cases. So this cloud data, that digitization is the step forward towards democratizing the healthcare services and providing these services at the places where it's very difficult to reach also, and for providing the best care. Like Dr. Munshi is sitting in Delhi, but he can get the patient from anywhere now with the help of the teleradiology or teleconsultation or those kind of things. So these things are, the technology is going to solve these problems. And definitely the insurance is going to take the thing that insurance is going to pay for that patient. Definitely somebody has to pay for that patient when Dr. Munshi is going to do a surgery or do the radiation therapy and those kind of things, and the scanning of the patient. So those kind of things has to come from the insurance sector, and the government of India is also providing that Ayushman Bharat for families below poverty line. So I think that National Health Digital Mission, the cloud thing, EMR, all these things combined will give a very robust infrastructure to provide these services at a much lower cost.
Mr. Sibal, thank you so much. And as I kind of wrap up this, I take three things that you've said, and I take them hopefully. Hopefully, the government gets a bigger canvas or a bigger rollout for cancer services.
Yes.
Hopefully, technology.
Yeah, not only cancer, but all the diseases, cancer, TB, any kind of disease.
Absolutely. But this today being Cancer Day, I'm just want to kind of focus on that. Okay.
Yes.
So there's a hope that the government kind of gets cancer a little bit broader. Technology won't solve anything, but the hope that technology will make things easier and better. And the fondest of hopes, which is that the insurance sector might actually prevent people from getting poorer simply because they had a cancer. And I say that that's the fondest hope because that's where the most amount of work needs to be done. Today, when a cancer diagnosis is handed over to an individual, and in many cases, it's not done in an empathetic manner. It happens in a screening camp, you just get informed, and then like we said in the beginning of this conversation, there's a gap, and then you have to go search around for what next kind of a thing. A diagnosis of that is both shocking or numbing, and then comes the cost aspects of it. People sometimes delay seeking care simply because they may not have access to resources, or they think that it's going to be far too expensive. A diagnosis of cancer should not become both a impoverishing diagnosis and also a miserable diagnosis. It has to be something that has to be delivered with the reassurance that there could be technological support, there could be governmental safety nets, and there would be definitely supports that prevent people from getting to be in an impoverished state. Because if that three don't happen, or if those three happen really, no technological support, no government support, and impoverishing happens, we're not going to see better cancer outcomes the way we have aspired for. Thank you, Dr. Munshi. Thank you, Mr. Sibal. Thank you, Vibhav Garg, for joining us. And thank you to Dr. Bhavna Sirohi, who was with us and had to drop off a little bit earlier, for engaging with this conversation. And for those of you that were on the audience listening to this conversation, I hope you will have the prevention-related conversations at home. For women, self-examination and seeking early care. Self-examination for men too. It's not just limited to women. Do have the conversations around immunization. For children, the hepatitis B vaccine is already there. Do consider the HPV vaccine for your adolescent girls and boys. Those are preventive, and they will take care of many things as we go into the future. If you have a diagnosis, do not hesitate, even despite COVID, to get to your care providers. They know how to care for you. They will keep you safe from many other things, and also begin the intervention that you need so that you will have a better outcome. Thank you so much for being part of this 1-hour conversation. We move on to our next panel, where we have an equally distinguished set of experts to talk about how we get into a better diagnostic situation. We have Dr. Ravi Gaur with us, who is the Director and Chair of the Medical Advisory Committee for Onquest Laboratories. We have Dr. Vandana Lal. Thank you, ma'am, for joining us from Lal Path Labs. We have Dr. Geeta Manjunath. She's joined us from Niramai Health Analytics. Dr. Somashekar, I don't see him already on, and I don't see Dr. Harsh Mahajan either as of this moment. The earlier conversation, and just to kind of bridge between the two sets that we had clinicians earlier on. And one of the flavors of that hour's conversation was that we need to diagnose earlier. Any delay in diagnosing people with cancers is actually leading to suboptimal intervention and outcomes for them. And since all of you, by name and by way of your enterprises and your professional lives, have worked towards better diagnostics. Let me start with Dr. Gaur, and then I'll kind of reach out to Dr. Lal and to Dr. Manjunath. What do you see as the problems towards better distribution of diagnostic services, especially as far as cancer is concerned? People know, people can get into blood tests, people can get into many kinds of testing, but what is it about cancer testing that remains to be done?
Good afternoon, Bobby, and I think it's probably I'll say, like, thanks to IHW Council to having this EE Cancer Summit, and aimed at creating the more awareness of cancer. The cancer is, especially on this World Cancer Day, when we all get together and make sure that we're going to defeat the cancer sooner or later. Now, there are it's a lot of challenges when it comes to the initial diagnosis or early diagnosis or a preventive screening. Cancer is really hard to go through, and even harder to watch someone to go through. Now, that's a problem. This is where the fear has come. People have got a fear. There is an underlying fear associated with it. And that fear persists today in spite of tremendous advancement that has been made in cancer diagnosis. I think we need to take the fear out of its equation and ensure that continual care for the patient. Now, this is, I think, the biggest challenge to date for the diagnosis is one, of course, the definitely availability to the remote primary health center. But then the infrastructure, skill out there in the primary health center, awareness. There are a lot of awareness, not even in the healthcare providers, probably at the primary level. They don't know about the screening methodology. They are not aware. They don't feel the importance. And then most of the patients even remain in the stage of denial. They will not like to go to the doctor and say, like, if I go to some screening methodology, something comes out, what is going to happen? Even something comes out, they don't know how to follow it up. This is a challenge. I think you just mentioned nothing in your previous session and summing up, but the patients, unless they have a supportive infrastructure, integrated approach, right from screening, early diagnosis, the final diagnosis, treatment, prognosis, and follow-up. Because that's where the fear is. Because if there is a screening availability out there and there's no infrastructure for the further treatment or the final diagnosis, then what will happen? There'll be more of a cure. They don't want to go there. Now, that's something which is like, a little glaring. We need to create a strong infrastructure, regional centers, or maybe the primary level centers. And diagnostic is advanced. If you're talking about the newer diagnostics.
We'll come to that in a second in the advances, and we're going to do that. But you kind of talked about we need to kind of expand. And let me just kind of put a few numbers here. We have, let's put it this way, the ambition that was announced earlier in this week with the finance minister's budget speech, that we will have a couple of lakhs of centers. We'll have every district covered. Last year and before that, we've had the Ayushman Bharat with its 150,000 health and wellness centers and its diagnostic centers, all supporting. We've seen that push come in from the government side. We also have private chains, and then I kind of notably, I mean, we have Dr. Lal with us. The Lal Path Lab infrastructure is pretty much visible every district of this country. I don't think there's any district that's missing out right now with your board, ma'am. We have seen that, and I'm not kind of exclusively saying that. I mean, we have Dr. Mahajan here. The OnQuest itself is kind of growing. You have that parallel stream also growing, and yet, when it comes to looking at screening in people with cancer, with an early diagnostic test, what is it that's missing? Is it the infrastructure and the reach, or is it the clinician who is failing to point people to the right test? Lal, ma'am.
Good afternoon, everyone. Thank you for inviting me for this summit. Being the World Cancer Day, I can speak volumes on cancer, but due to limited time, I would just speak on how the infrastructure is developing in the remote areas. This is by virtue of the fact, not what I have read, but what I do in practice. My husband and I have started a foundation, a philanthropic foundation, through which we are dealing with the government of India at the primary health center level. And these centers have been given to us in Uttarakhand. What we have seen is that there is an extreme dearth of clinicians, of the ANMs, the ASHA workers. So to put this infrastructure in place, it's going to take quite some time. So since we have joined hands with the government, it is the diagnostics we are going to look after. However, it is not an easy path, and it is going to take time for it to reach the village level. Now that is what our aim is, that our aim is not to highlight what is happening in the metro towns, because they're all health and tertiary hospitals are available. But it is with the aim of the government of setting up the primary healthcare center, the medicine is moving from tertiary care back to primary care. Because there is a lot of stress on non-communicable diseases, and cancer is one of them. If this happens, the screening happens at the primary healthcare level itself, then it is going to reduce the burden on the tertiary hospitals. So it is very important for diagnostics to move into the remote areas rather than be limited to the tier 1 and tier 2 towns. So we have to develop a model of rural diagnostics where it is, that is at a very affordable price for the patients, and teach them, go to the community level and teach the preventive healthcare, which has to be talked about and trained. The people have to be trained. So this is the work which I have initiated with my husband.
Right. Thank you, Dr. Lal, for pointing out that, and so eloquently, that diagnostics cannot remain restricted to the metros and the tier 1, tier 2 cities. It has to move down. But you also, in passing, mentioned that even the presence of infrastructure does not guarantee that there will be diagnostic procedures, because somebody has to direct the individual to take that test. Or with Dr. Manjunath right now here, they need to be aware that they could do the test for themselves. And I'll come back to Dr. Mahajan in a second, because nobody orders a X-ray for themselves. Somebody prescribes it or somebody recommends that they go and get a test done. But in your case, Dr. Manjunath, you're basically saying that there are some kinds of diagnostic screenings that individuals could do if they are aware, and it could be easy. Let's get to hearing from you before kind of focusing on where the gap between the available infrastructure and somebody pointing the direction is existing.
Sure, it's my privilege and pleasure to be part of this eminent panel with Dr. Mahajan sir, Dr. Lal, Dr. Gaurav as well. And I completely agree with Dr. Vandana ma'am in saying that, yes, diagnostics and screenings have to move to the rural areas to essentially make affordable, accessible screening possible to everyone in India and everyone in the world. And how do we make this happen? So our take is to combine technology with the available sensing methodologies, and then try to bring particularly the AI, artificial intelligence-led solutions to behave like mini, doctors, if I can use the word, in the sense like just to provide the screening facility and provide some additional bandwidth and additional skills to the health workers to administer them at the grassroots level, right? So that is what we are talking about. So as most of you know, so we have actually developed for now a breast cancer screening solution, which is a more of a triaging solution to say whether the lady needs to be brought to the hospital right now or, she's sort of safe. This particular decision can be taken by a health worker. So that way, the problem that Dr. Vandana very nicely pointed out as to the difference between the demand versus supply, the number of doctors and the number of patients that require attention. Obviously, because of this, the doctors and the experts, such as those on this panel, should focus on people who require, literally very deep care immediately. Like for preventative healthcare, if we can combine technology with some kind of remote diagnosis that Dr. Gar also mentioned before, like telemedicine and some kind of point of care devices in the hands of health workers, then suddenly you have the bandwidth or the scale or the infrastructure available to you. So particularly talking about our own experience, when we developed this, we also made sure that people adopt our solution, come forward for screening, despite the shyness and other things that were discussed before. And the way we did that is to make it completely privacy aware. We created a changing room experience. The lady enters a booth, it is completely closed, nobody is inside, not even a technician, and she has to disrobe for the breast cancer screening, but she sits in front of the device is controlled from outside, and she comes out after 10 minutes and a red or yes, no answer, right? Whether she needs to be brought to a hospital is kind of ready, right? So this kind of thing has actually made a lot of women come forward for this test, and we have a lot of word of mouth happening. Almost 35,000 women have been screened in villages as well, working with foundations such as those mentioned before, with Karnataka Cancer Society and many other rural institutions. We have done this. Of course, this can also be done in hospitals, but talking about taking the early screening or early diagnosis and screening to nooks and corners of India, combining technology with remote diagnosis and providing power with the health workers, I think will can increase the infrastructure for screening very quickly.
So we have an approach here where you're taking the technology down, one, making it comfortable for individuals to be interacting with, and becoming closer to them, nearer to the point where they are, and enabling them to make a decision whether they need to step into a higher center or be reassured that they can kind of go back home and there's some time that they can come back again.
Yeah.
Dr. Mahajan.
Whenever doubt, obviously you can get the remote help.
Of course, you can get remote help. But still, I mean, I just want to go back to the gap. Even if we increase the number of diagnostic and screening centers, somebody still needs to point, please go and get it done. Is that becoming a critical gap? And earlier where we talked that we don't have enough diagnostic centers or the available facilities, is now the pointing facility becoming a gap? And is that something that you have a message for clinicians and the general public for?
Thank you very much, Dr. Bobby. I think you've hit the nail on the head. You know, education, I think, is the most important thing which needs to be stressed on. Education for the masses, of course, but also for the physicians, for the gynecologists, for the surgeons, for GPs at large. That is very, very, very important. And we say that every technology is available in the tier 1 cities, which have brilliant hospitals, great doctors. They're all specializing in their own field and they're overburdened with work. And if we talk in the context of breast cancer, where does a lady with a breast issue, whether it's pain or some nodularity she may have felt or even a lump, who's the first person she goes to? By and large, it's a gynecologist. And you'll be surprised that how many gynecologists actually can, point the patient to the right direction, that this is what you need. So I think the first focus has to be on ourselves, on the medical fraternity itself. We need to be aware, we need to be educated. You know, the breast surgeons, they know it all. The oncologists, they know it all. But the person where there is first contact, they need to be sensitized, they need to be educated, they need to be told whether it's a X-ray mammogram that a lady does, whether it's a ultrasound that should be done, at what age, what is the screening, how frequently it should be, the difference between an average risk woman and a woman who's at high risk. Those are factors. And, we may build any kind of infrastructure, as you alluded to. And but if we are not doing it right, then we are again going to end up patients coming in stage 3, stage 4 cancer and not in stage 1 or maybe early 2. So I think the emphasis, apart from being building infrastructure, and it's a must what Dr. Lal is doing through her philanthropic endeavor and many others like that. The government itself at the primary level, at the PHC level, also this education needs to percolate. And it's only then that we'll catch cancer early and hence be able to cure it or adequately treat it and save lives. And, everyone knows that prevention is better than a cure. Prevention is also cheaper than cure. And so in countries like ours, we need to focus as much on prevention as on treatment itself. Thank you.
Bobby, I'd like to add on Dr. Harsh Mahajan, one liner here. You know what rightly he said, because like even our physicians probably at the middle level also, I'll probably say that many of them are not aware, like especially the lung cancer, if you see, majority of the lung cancer patients, if I think probably say if I'm not 50% occasion, they are treated with the anti-tubercular drug before they come for the cancer treatment. I think that's where the problem is actually. This is
that's what I wanted to pick up. I mean, because Vandana ma'am kind of really pointed out that, and then I want to expand out. Because while on World Cancer Day, we can talk about awareness for the general public, we can talk about screening and early awareness and things like that. We don't want people like Dr. Somashekar to be so busy in trying to kind of solve the many things that come late. Prevention is better than cure. An early diagnosis is better than a later diagnosis, both for the management and also for the outcomes. And in doing so, the audience for this kind of a conversation really is among those who see patients the first time around. The primary care physicians or the middle level physicians or care providers that Dr. Ravi got pointed out to. You cannot afford to flub up a in-time diagnostic direction. Because if you miss it, then you are pushing people into a poor outcome situation. And that's where I think we need to kind of focus on. Let me just get Dr. Somashekar in first before kind of come back to you, Dr. Gaur, and then start the conversation all over again. Dr. Somashekar, of the 100 people, and I'm kind of really kind of blindsiding you with this question, when you get 100 people, how many of them have had a delay simply because their first care providers or first sets of care providers did not get them triaged into the appropriate testing module?
Okay. See, you know that I'm the current president of Association of Breast Surgeons of India. And then we did an audit and census across India about the breast healthcare, and we also published in Indian Journal of Surgical Onco. Now there are 2 to 3 things. Number one, unfortunately, breast cancer lump is painless. So most of the women correlates cancer with suffering pain. And most of the women who come in India, we just say, you know your breast well, you're a lady, you've been examining, you're checking, you know it better than anybody. Why didn't you come? It is painless. So painless cannot be cancer. So from patient side, they wait for lump to come. The moment a lump comes, it is at least 1 or 2nd stage sometime. Now the third important thing what we have focused through Association of Breast Surgeons is, unfortunately, most of the people in India still use FNAC. It is a known modality that to diagnose a breast cancer, other than the mammogram and ultrasound, you need to do a core biopsy to do the test. It is a paper done. There is a 6 to 8 weeks of delay from the clinician side after a patient presented. See, patient delays for 3 to 6 months, sometimes as much as 11 months. Now, we can't blame them because it's their health and they've been sitting in home. We have not given awareness to them. They are not aware, or they are afraid, or they think painless lump is not cancer. After having reported to a clinician, whoever it may be, we're not going to debate where, even then, just by doing an FNAC, which gives inconclusive diagnostic, inconclusive pathological assessment, no proper foolproof test report can come. There is a lot of delay in that. It is forced on. Minimum 6 to 8 week delay happens. So we have audited this. Patient delays roughly 3 to 6 months. And by doing an FNAC instead of core biopsy, there is a 6 to 8 weeks delay. And then referring it to a center which can deal the breast cancer. It didn't have to be a quaternary cancer center or a regional cancer center, at least an appropriate medical college institution where there is a surgeon, a medical onco and multidisciplinary available. It didn't have to be a state-of-art cancer center. There is further delay of 2 months. Now you can know there is a stage migration. Patient waited for stage 2. If they come at stage 3, it is delaying by 3. If they come in 3, they are in 4. So that's one of the reasons through ABSI we run awareness course for clinician, for patient. Please identify, do a core biopsy, diagnose, avoid delay, not more than 2 to 3 weeks from your side. And when a patient comes, educate the surrounding people, their husband, their sister, brother. So let the things change. So unfortunately, this is what is happening in India.
Thank you so much, Dr. Somashekar. I mean, for also putting the numbers behind it. Those are audited numbers. And then you kind of, you're speaking from authority that while there may be delays at an individual level, where there should not be a delay, where there should be appropriate and quick action, we actually end up in a cul-de-sac, and that is problematic. Dr. Ravi Gaur, between an FNAC to going to a core biopsy sampling, I mean, what is the expertise level that you need to jump to? Is it at the procedural level, or is it at the pathological level that you want to kind of, the pathological expertise that you want, so that clinicians are able to then intervene in?
I think probably I'll say the both live, because when it comes to the FNAC, probably the facilities or FNACs are not even like tier 3 or tier 4 cities. They don't really exist even, number one. Number two, like I'll draw something for cervical cancer like a pap smear. in a primary health center, if somebody, first no facility to give a pap smear sample, how do you collect the sample? The lady doesn't want to go there, it's a cumbersome procedure. From there, go to district hospital, and they come to firstly, they have to come to district hospital, or the sample to be collected at primary, come to district hospital. Sometimes you've seen 3 to 4 weeks to get a pap smear report. That is, I think, the skill level at even the pathology level who's going to report those cytologists in the reports. That is all a missing part. Now, similarly, I think for the FNAC, we don't have a good aspiration cytologist or a pathologist available at tier 3 and tier 2 cities. Even then, there's always a misdiagnosis, and the slide goes for a second opinion and a third opinion, and by the time is passed. And similarly, I think the awareness, we have just mentioned the topic about biopsy. I think probably that's something which is, yes, if something in the biopsy, FNAC report is not coming, I think if it's not possible, it's going to take 3 weeks, better to go for a core biopsy in the nearest district center or surgical center. I think that's the most viable answer. But do we have the infrastructure probably? Do we have the facility? Is the patient aware? Not only I think the healthcare providers, even like the GP level or a physician level, they try, okay, let me do the procedure. The patient doesn't want to travel 100 kilometers far away, 200 kilometers far away. But if they feel the cancer comes out, whole family is shattered. I think this is something which is I started with patient, they all stay in the stage of denial, right? The patient and even the doctor say, oh, let's wait for some time. I will give you anti-inflammatory drug. Let's do something. Then we do FNAC and then we do biopsy. I think that's a denial, probably awareness. Because denial is one reason because they don't know what's going to happen next. So unless you create the infrastructure, the shortage of infrastructure, skilled people, the technologies, we need to really have what Dr. Geeta was mentioning, the point of care, some kind of disruptive technology, which is an AI based, which images can be transmitted from right, left, and center, and reports can be given. I know about a technology called tumor trace, which is especially from cervical cancer, where the sample is taken and without staining, without anything, within 7 minutes you put under the small kind of a lens, automatically an AI-based algorithm comes out, which is like, okay, this is a normal pap smear or an abnormal. At least that is good enough to take it to the next level. These are the, I think, areas we need to work on. Secondly, this, this self-sample collection, I think, an area, because blood sample, FNACs, biopsy, can we do something about like, say saliva sample, can be the oral cancers, can we do the oral swab kind of a thing, or even like some biomarkers which are now like, we are heading for a new molecular biology, circulating tumor cells, or liquid biopsies, or blood samples. I think those are expensive today. They're very, very not even available in the tier 1 cities that the great expertise. Sure. But I think we need to put a lot of efforts into it. And I think combining together technology, bringing down the R&D, bringing down the cost, and making this available at the very, very primary level, integrating them all together, that's going to work. Otherwise, this is going to be a difficult task.
Thank you, Dr. Gaur. I want to talk to Dr. Vandalal. I mean, you are at a fascinating intersect where you have services, what it means to kind of set up and deliver services, but you're also at a foundation level, you're beginning to kind of intersect with the public health delivery systems. And we are seeing, and as you correctly identified right in your first space, there is a gap. How do we kind of direct people into the appropriate both diagnostic pathway and then make sense out of what is coming out of it so that the next steps can be taken? How do you see, both with your experiment in Uttarakhand, which you've just begun, not experiment, your project in Uttarakhand, how do you see this being transforming the delays that Dr. Somashekar just pointed out to?
So what has happened is that WHO has listed the essential diagnostic list, which has been adopted by the government, by the Prime Minister's new program for health at the primary healthcare center level. And in that, answering Dr. Gaur, there is the test, a very primitive test though, which they have put for cervical screening. And they are training the ASHA workers and the ANMs to do that test, which is acetic acid test. Now that's a very primitive test for people like us who are in the diagnostics, but where the rural villages where nothing is available, at least something is better. Secondly, what is more important is to go down to the rural, the villages, which are, each district has a number of villages attached to it. At each village level, you have to work with the sarpanch, because it is the sarpanch whom the villagers listen to, and through them recruit the local girls and boys to spread the word of screening for cancer. Now, cancer is a very kind of a dirty word. People get scared the moment you talk of cancer. But it's very important to spread this at the grassroots level, because by the time your internet reaches there for your telepathology, teleradiology, it is a long way off, which we have seen on ground level. The National Digital Health Mission has started an e-Sanjeevani services. These e-Sanjeevani is the internet services through which telemedicine will function. But even those cables have not been laid down as yet in many areas. So by the time it comes up, it's a long way off. And this telemedicine is the way which we will be able to connect the villages to the metro cities and the tertiary healthcare. But how much time it will take is questionable. So that is one problem. So it is the diagnostics division which we are in charge of setting up the diagnostics unit in these areas, so that at least the screening of basic tests can be done, like for anemia and for non-communicable diseases. Pap smear has been done, but otherwise we have to go to the villages and educate the men and women there to feel for lumps, not to ignore them, to come to these centers immediately. And that is going to take some time. It's not going to happen in a day.
Right. Ma'am, thank you so much. I mean, yes, and for the audience, there is a responsibility on your side. What Dr. Somashekar pointed out, especially for women with lump breast, delays of between 6 and 8 months means you're coming further down in your disease progression. That is something is entirely in your hand. That is not in the clinician's hand. And so therefore, whether it's women, whether it's a vaginal discharge, or whether it is a nodule or a skin change that you're seeing on your breast surface, you need to be aware, you need to ask, is this something that I need to be worried about? Men or everybody else, if you see a change inside your oral cavity, mucosa, the color, something, or if you feel a little bit of an erosion, you definitely need to ask either your physician or your dentist, or ask somebody who knows something about this, or even Google it up, and you will see images and they will kind of tell you that this is something that you need to get some diagnostic for. Those are delays on your side, and the government and social work organizations and non-governmental organizations are all trying to get this message across to you. Prevention is better than cure. Where there is an immunization possible, do that. Where there's an early diagnosis possible, please come in. We can't diagnose you while you're at home. But once you're here, and this is where I want to kind of turn back to the clinicians here on the panel. We have this notion of continuing medical education, which now people have to get CME credits. Is this something that we need to push a little bit more on about diagnostic delays for cancers? Is there a module that can be done that kind of pushes people to say, if you miss out on X number of referrals, then you really need to be either doing some remedial education or being penalized for it? What are the clinicians and the senior people on this panel thinking about this? May I start with Dr. Mahajan?
Well, I think that may be an extreme step, maybe a necessary step. But to start with the fact that you're going to be penalized, maybe taking it a little too far. I think everyone, we became doctors because we wanted to be, we wanted to heal, we wanted to cure. And I think everyone wants to continuously keep upgrading their knowledge, keep learning. And towards that end, if our associations were to get together, then it would be very, very useful. And these, in isolation, all of us are doing it. The Radiology Association is doing it for the radiologists. Sometimes we do interact with the clinicians. Similarly, pathology and cancer, all of that. Maybe the time has come when some modules can be created for clinicians at large, and especially for the super specialists, because we all are getting tunnel vision. No one is seeing the patient as a whole. We see a patient as an organ system. And that's where, we direly lack the GPs that used to be there, who would know the ins and out of your body, of your family. And since you trusted them so much and you were constantly in touch with them as a family, they were the first, stop for anything medical. And I think we need to, apart from the CME, there's no denying it should be there. And I think the government should make it mandatory. And relicensing, if it is done every 5 years, that would be good. Of course, you would have the associations, take out, processions against it. It is necessary. It would be useful. But at the same time, somewhere along the line, we need to redevelop, refine the GP system, which would also help in, quick diagnosis, quick turnaround, and ultimately, these people are able to send to the correct person. Right now, the person has no choice but to go to a specialist. And with abdominal pain, you go to a urologist, certain things will get checked. You go to a gastroenterologist, something else, and so on and so forth. So that's another system. I think a country as large as ours and with a population that's as diverse, I think the GP system also needs to be revived. But no doubt the CMEs and the credits and to accumulate certain credits should be made mandatory.
Thank you, Dr. Mahajan, for kind of lifting the issue of the primary care providers or the general practitioners, as you kind of put it, and the role, the equipping, and their distribution. This is something that we need to kind of rediscover for ourselves if we have to have better healthcare spread. And as we do that, I want to kind of take the experience that Dr. Geeta Manjunath's company itself and your modality is having. You're trying to use technology as much as possible to stand in for what should have been a good GP practice, at least in a specific way. Is there a way that between what you're doing, the models that you're doing, and what the LAL Foundation is trying to kind of now begin to equip people, is there a way that you can develop modules for GPs that say, look, system-wise, people present with only a few things. They can present with a pain, they can present with a lump, they can present with a fever, they can present with a bleed, or they can present with a discharge, or they can present with a loss of consciousness. A few. And of course, there's something wrong with the breathing kind of a thing. Not many more than that. What are the basic sets? One that I'm kind of pointed out to an essential diagnostics list. Whittling it down, what are the basic things that you need to kind of get done? How do you kind of get that from a technology perspective, from a programmatic perspective, so that the CME that we've talked about, or the delays that Dr. Somashekar pointed out that kind of are vital, that are destructive for individuals, can be avoided? Dr. Manjunath.
Sure. Of course, like I said, it's amazing to be part of this wonderful expert panel. And so from bringing in from a technology standpoint here, there are many videos that have been created by organizations such as the foundations that we talked about earlier, from AIMS, ICMR and all. What I realized, just even leaving the physicians alone, even for the end users to say what symptoms are actually symptoms, all of these things. So we have been conducting webinars for consumers, for example, to play these videos, call experts to actually talk to them every month and so on. So something like that, can be enhanced, right? Probably like a quick reference symptoms or reference, tools, software-based tools, mobile-based tools that can be developed for even GPs and gynecs to have some quick reference and analysis of a person coming in. We've also seen that simple clinical breast examination, right, also requires a particular method of doing, and not everyone is comfortable and knowledgeable about doing this. So these kinds of basic understanding definitely, of course, they would have studied and maybe requires a revision. And so that is one thing that is done. Second thing we have done, particularly in our case, is even if there is no symptom, people have to come, like Dr. Somshekar sir was saying, right? Earlier, stage 0 is even better, stage 1 is even better, right? Smaller sub-centimeter lesions, if they can find, then there is less treatment cost and better efficacy. So with that in view, we've taken these solutions to different rural areas, like we mentioned, right? So we've also worked on a mini version of this, which is a GP's version of it, which is more like a handheld that can be provided at the gynec's clinic. This we call direct to doctor, direct to physician, right? So these are conducted and administered by the gynec and or the GP, and they may not be able to buy the device. So we've also evolved a business model to say it's a shared model. They will say every Monday we have this facility available. So women are more comfortable going to the nearest physician, their family physician, rather than to sort of very big hospitals for preventative or early sort of the first first point of contact, in some sense, whenever they see some abnormality or discomfort. So in that sense, having these tools available even at the gynec and the physicians, and almost on a shared basis, so it doesn't hit their pockets as much, but also conducted by our specialists, our technicians, if they do not have enough staff in their place, but it is administered by the physician and GP. This is something we are doing as well. We have received a lot of good interest from the gynecology community for doing this, in addition to clinical breast examination. Many times, it's an adjunct to make sure that we do not miss any small lesions. So that is something that we have tried. There is good interest for that.
Right. Dr. Somshekar, I mean, what the way that it's coming to as an
If I may just come in, Dr. Bobby, just to add something to what Dr. Geeta has said, the government of India had a program, and I was on that, to develop, similar to what Dr. Geeta's company is doing, a thermography for breast cancer screening. So in Thrissur, in one of the government labs, they've developed a bra which has these thermography sensors, and using that, these are sensors developed in that lab, very, very sensitive. And so with that, you can actually take it to the PHC, and the lady there can do it. This then brings the picture onto the computer, and then there is an AI algorithm which tells you whether there is a chance of malignancy or not. And this is still the early days. It's going to come into practice very soon, but already this is available. So just to say that technology, especially artificial intelligence, we've ourselves in our group, Caring, we've developed technology, chest X-ray, to determine whether it's TB or it's cancer. AI will do it. So where there's a shortage of radiologists and where you actually do mass screening, these things are going to be very, very helpful. And actually the scientists, the engineers are there in our country, and they are after it, they are building it, and we'll be there very soon. So it will not just be, because shortage of doctors is not going to go away in the short term. So we have to find newer technological solutions.
Right. Dr. Somshekar, I mean, between what
device also uses our software. Yeah.
Right. So what Dr. Geeta has said, what Dr. Mahajan's kind of pointed out to the newer advances that are happening right now to enable earlier diagnostics. What is your wish list? I mean, outside of the technology part of it, in the real physical clinical examination world, what is your wish list for those that are seeing people for the first time? What are the kinds of skills or questions or diagnostic tools that you want people to have ready access to?
See, it is very important to know certain facts which are India-centric. That's why from Association of Breast Surgeons, we brought Indian solution for Indian problem, make in India for Indian solutions. So we brought a guideline, and we also brought second thing, ABSI consensus guideline to be practiced by any basic second tier city surgeon to standardize the breast care in India. These are the two main work which we did and which was accepted in St. Gallen's Breast Cancer Congress. Now, it is very important to understand, even though the incidence of breast cancer is maximum in Western world, and we are contributing less than 20%. Mortality is 50% from India, which means a breast cancer lady in Western world, even though incidence may be 5 times more than India, they live 97% of the time 5 to 10 years. But in India, 1 out of 2 women with breast cancer will die within 5 years. So it is very sad. We contribute less numbers for the incidence, but maximum for mortality. So that means there's a problem with patient, public health care, government organization implementing the national cancer programs, registries, and clinicians, all of us. Second thing which is very unique to India is, India houses the largest number of young women with breast cancer in the world. We are 1 decade early. If it is 5th, 6th decade above, we have maximum patient between 30 to 40 years to 40 to 50. So by virtue of this, our breast cancers are dense breast. The conventional modalities like mammogram are unfortunately not useful for us. Dense breast, X-ray breast technology, diagnostic tools are not so useful. So which means we need both an ultrasound and we need a mammogram, then a clinical breast examination, which is impossible for a country like India, where a pap smear is easiest, very, very easy. Government invested phenomenal amount. We couldn't 100% succeed. So we moved to a vaccination drive. If we can't screen million women, we'll just at least give vaccine to eradicate it. We have started the other way around. So now if we understand in India, young woman, dense breast, we cannot have a qualified clinician, radiologist, ultrasound, all moving out periphery, impossible. That's why the Tata Cancer Hospital in Mumbai started a randomized trial. Clinical examiners know, still going on, but still it will always be inferior. I was part of a World Health Organization project. Can we have a piezo crystal based device which can be charged? Doctor is not required. An ASHA worker can carry to periphery. Once charged for 6 months, it goes. Whenever they scan, the image comes to a doctor on their iPhone, iPad, and then we interpret, because we know that if we screen 1,000 women, 2 has to be called back. I did a pilot study based on which WHO identified that as the innovative device of a year, but still there was a lot of limitation with that available for us. A lot of state governments in India, Telangana, Delhi, Rajasthan implemented it. 7 countries across the world, not possible. So for me, what should be an ideal one? An ideal one is painless, X-ray or any electricity devoid, which can go to rural area by their own lady and acceptable for a woman. So which an ideal device is not yet there, because most of the current device needs a woman to come to an institution. It didn't have to be in hospital, but to a center. We are not able to go to periphery. So it should a device should go to a village, do there, not that we say we come here. So nobody has been able to master it in India, in the world, for Indian women. So we are reaching there now, that with lot of push from the government, that Make in India and then startups and new technological innovation hub is India. We are reaching there, but not yet there. So for me, an ideal device would be something which a portable device goes to a woman, and woman didn't have to come, and it is highly acceptable for them, which can be done once a year only, say on their birthday or their anniversary and marriage. So you can remember that you are once. See, remember, we have to give this message: diabetes, hypertension. You have to do it every month, every 3 months test. Cancer, once a year screening pack. So a pap smear or HPV or a breast screening, and oral cancer, prostate, colon. We would cover almost 90% of cancer in India, which is the main burden for our healthcare. So I would want the technologists, maybe IAS institution, many institutions to join hands to make something like this, where India is a place where we have PHC system, Gram Panchayat system. Imagine every PSC Gram Panchayat, the moment they get elected, they get equipped with certain basic things to screen 6 top cancer in India. It is available there in their village. So we just say, on this day, you are important day, marriage, anniversary, birthday, or this, it's free. And rather than penalizing, incentivizing, they said 2 children, you get 1 promotion. If you do this particular area, then you get a free education to women, cycle to women. So we'll not penalize, we'll incentivize. A family which did once a year screening package, cancer of themselves and their husband, children, family, get incentivized in whatever way.
Thank you, Dr. Somsekhar. Thank you. Yeah, and I think Dr. Vandanlal is kind of mentally making notes for pilot projects in her own foundation areas in Uttarakhand, some of this incentivizing thoughts that you kind of put in together. But I mean, you made a point, and it's what we call in jargon target product profile. You want a kind of a device or an intervention that is going to closer to where the person is. There are only three ways of doing things. Either the person comes to an institution to the test, or the test goes to the person, or something travels in between, and that's images. And that's where I want to turn to Dr. Ravi Gaur. I mean, you kind of briefly began, and I interrupted you then, because it has bearing. It's not just about the devices and the images. It's also about some of the newer modalities of tests, markers that can be picked up. They don't necessarily need to be. Right now, they're complicated. But COVID kind of has shown us that they need not be very complicated also in picking up molecular markers or using them in readily available test equipment. Is there right now something that's getting us to a point where we can democratize some of these sophisticated tests so that there can be specificity and sophistication for both the diagnosis and the early initiation of treatment?
Yes, I think very importantly said. The patient bring the patient to the diagnostic centers or to the centers out there. It's a very difficult situation. Most of the time they avoid. In any case, I've seen people carrying on a lump in the forehead for years together. I've seen doctors carrying on the lump in the forehead for ages together. They never get an FNAC or something done. Then the fear of scare. So one important point is, yes, we really need to go as close to as patient as possible, near patient care. That's one. Like for pathology, one of the is like digital pathology, what we talked about. Can we have a small, like kind of a aspirate or anything from there? Probably an image, which is something like swab, which is collected out there, put on the slide, and the images are sent to the collection site wherever the specialists are. So they don't need to travel. They don't need to worry about it. I think these technologies and the new biomarkers need to be developed. There are many of the new biomarkers which has come in the space of companion diagnosis. In fact, that's what we call it. When the cancer is diagnosed, we have a specific target-based drug for that particular cancer, because no two cancers are alike today. Every cancer is this unique kind of a thing. And no, like they say, over 75% of people don't respond to the same drug. There is a variation. Some person respond to one drug, same cancer, not responding to same drug. So this personalization of medicine, especially personalized diagnosis, the companion diagnosis is the need of the hour when it comes to the treatment part or targeting the treatment part, or maybe coming out with the early relapse, because that's where something, because biggest challenge is, like we have seen roughly about 30 to 35% of patients after first round of cycle or first round of therapy, they don't come back because then suddenly they come back after 2 years, the tumor is spread all across, all effort is gone. So some diagnostic modality which are now getting molecular at the genomic level, those should be made easily accessible. And that is where I think a lot of work is going on in the Western world. It's happening in the bigger cities. It's happening in the large centers also in India, but they are still expensive. The cost is pretty much. Right. We need to put a lot of efforts into it. I think government can work out, let me say, because if you can go something like preventive genomics or preventive screening genomics, although the cancers are not hereditary, but very few are hereditary, but the environment, lifestyle, pollution, and the age, a lot of other factors together. If you can work out some screening methodology for on the spot and putting a risk score to the screen, like it's not like, one value, all put together, so the individual gets a risk score. You have an annual checkup. This is something which is mandatory, and this is your risk score. And based on that risk score, the person follow-up can be done. And that can easily be done today. They have AI-based software and apps are available, which now everybody is carrying an Android phone. Now, we also parallelly have a NDHM, the National Digital Health Mission, unique health ID has been created. I think that is going to play a very important role. If we have everybody get a unique health ID and you have a preventive health check, and so whether it's an alert which goes to you, you put your data right there, whatever, any symptom, 5, 6, 7 common symptoms, open your mouth in the morning every day, just see what's there. That's it. Is there any skin crack or something, non-healing wound, get back. The common language, common things, probably even they send a small photograph or something like this, probably that can create a AI-based, imaging-based combination and integrated diagnostic centers. That's, I think, technology is available actually to some extent, but we need to take up the startups and probably more of such ventures need to go to the periphery and be worked out. Otherwise, and lastly, you mentioned what I think incentivize. Now that's a good thing. Probably, I will say a primary health center doctor who's responsible for 100 families or 200 families. I think we should give him a zone there. In your area, how many people have developed cancer? How many people have been able to take care of themselves or be in a wellness state? Every monthly, yearly report, and that's where the appraisal and incentive is. That is going to work very well tomorrow.
Right. Thanks. I mean, what we have are what I would qualify as a target product profile that Dr. Somashekar kind of outlined for us, and a target service profile that Dr. Ravi Gaur has kind of outlined. I want to turn to the two ladies here on this panel. Between the two of you, and I want the two of you to wrap up this session for us. How do you see this target product and target service profile, both from a technology perspective, Dr. Geeta, and then from a programmatic perspective at the last, Dr. Vandana? How do we kind of approach this? How do we kind of set this up as both an aspiration and a program of work going forward? Dr. Geeta first.
I think we are coming back to this difference between the number of doctors versus number of patients. So getting some kind of a government intervention, now this budget had some things nicer done for insurance and so on. So getting some kind of this sort of service mindset, get into some government program and making this available, let's say, on a mobile, because that is sort of almost the first device that every family will have, will bring in the technology, the infrastructure provider, the access provider, all of them together to provide the service to everyone.
Right. Vanda ma'am, last word on this one.
See, the diagnostics as far as the genetic biomarkers for cancer are concerned, also the prices are going down in the world. The technology we commonly use is next generation sequencing, and it is the aim, which used to be at $500 is now coming down to $100. So it is very much possible for us to innovate, and we have a big IT industry within India to do that and do some development with our biomedical engineering units, and we can bring down the cost drastically. It is possible. It is happening. It happened with COVID also, and it has happened with many other tests. So it is not difficult to bring down the cost of certain specialized investigations in India itself if we indigenize it.
Thank you so much, Dr. Vandana, for pointing that if we work towards localizing, indigenizing, advanced testing, it is possible. And the experience over the last 1 year definitely points in that direction. We can actually get fairly sophisticated tests more widely available and be usable. As we sum up the last
Dr. Bobby, I'll add on just one line here. You know what Dr. Vandana is saying directly, because if you look at the high-end cost tests which are in India versus the West, I think our pricing is still almost like 1/4 or 1/5 of that pricing.
Absolutely.
And that's something that done wonders. We are proud of it. I think we can do much, much more, provided there's a good collaboration between the private government sector, R&D, and of course institutions which are the academics people together.
Sure. Thank you so much. The point that Dr. Somashekar made, I want to go back to that. There are delays at the patient level, often ranging up to 6 to 8 months in the case of breast cancers or breast lumps. And there could be similar or even longer delays if there are lumps or discharges or other manifestations that are visible or felt by the individual, but people don't seek care. The medical fraternity establishment cannot do anything about that delay. That has to be a concerted effort of communication, of community mobilization, of education, of awareness that people need to undertake. It will be between government, it will be between private sector organizations, it will be at the family levels that people have to discuss. That if there is something, please seek care earlier. Early is better than later. Prevention is better than trying to get on a curative pathway. So those delays, the responsibility and the need for action is outside of the healthcare system as we know it. But if you come in if you do present, and this is again from the results that Dr. Somashekhar's ABSI audit tells us, a lot of people do not get the appropriate first level diagnosis. And this was pointed out in the earlier segment too by Dr. Bhavna Sirohi, that there are delays at the clinician level. People get into loops of treatments before they end up into the correct diagnostic slot. And that is something that we need to address. And we've had a conversation. Should continuing medical education be a little bit more focused on these diagnostic delays and errors at the primary clinician level? Should the associations, the various specialties, begin to work collaboratively across so that there are uniform early diagnostic triage pathways determined? That is something for all of us to work together for. Is there a possibility of democratizing or further spreading out and making affordable, sophisticated testing? Yes, it's possible. Whether it's Dr. Mahajan, the way he pointed out about the imaging, or whether it's a sophisticated testing of the molecular diagnostics that Dr. Lal and Dr. Ravi Gaur have pointed out, or whether it is early signals in a non-clinical, with a non-clinician, like Dr. Geeta Manjunath's technology has pointed out. Is it possible to pick up early signals and get treatments initiated? All of that are possible. The message from this last 1 hour was, thank you so much, Dr. Vandana Lal, Dr. Geeta Manjunath, Dr. Ravi Gaur, Dr. Somashekar had to leave, Dr. Harsh Mahajan. Thank you for sharing from your wisdom and for engaging in the conversation. The message to all of us is this: prevention is definitely better than cure. A good diagnostic earlier actually enables you to get to a better outcome. The statistic that I want to leave behind is the one that Dr. Somashekar kind of pointed out with. We have far lesser incidence of breast cancer, but we account for a disproportionate proportion of the breast cancer morbidity mortality in the world. That is untenable. Let's make sure that we do better than this as we go forward. Thank you very much for your time with us. Thank you for the panelists to have shared of their wisdom with us. Over to you, Kamal, for the next session.
Thank you. Thank you.
Everyone, welcome to this session of the second edition of Cancer Summit powered by Manipal Hospitals. In this session, we are going to discuss about how food and nutrition can help prevent cancer and also what role it plays in making your cancer treatment more effective. The extremely critical role played by food and nutrition in our overall health and well-being, and even preventing from all kinds of diseases beyond any question. And it's equally critical for facilitating the healing process in case of ailments. And this significance has been aptly captured in this Ayurveda proverb, which says, when diet is wrong, medicine is of no use, and when diet is correct, medicine is of no need. And this is equally true for prevention, management, and treatment of cancer as well. And under this, how food can help us, kind of prevent diseases, and even if, when we are managing cancer, how it can help in the whole management and healing process. We will be getting much more insight in this panel of luminaries of nutrition, health, and cancer care and research who have joined us this afternoon. So let me welcome Dr. Salini Singh, Director, National Institute of Cancer Prevention and Research, Dr. Sikha Sharma, Founder and Managing Director of NutriWell Health, celebrity dietitian Isi Khosla. She is a clinical nutritionist, columnist, author, an entrepreneur, researcher, and also a welfare worker. We also have Dr. Asha Nair. She is a scientist at Cancer Research Program, Rajiv Gandhi Center for Biotechnology, Thiruvananthapuram, and Dr. Vedant Kabra joining us from Manipal Hospital. He is the head of surgical oncology at Manipal Hospital in New Delhi. So welcome all our speakers and panelists today. And we have a very interesting mix of experts where we have, oncologists, nutritionists, and also cancer research luminaries. So I'm sure the audience and all the other attendees are going to take away a very holistic information out of it. So let me begin with Dr. Salini Singh. Dr. Salini, you are heading the cancer research part, and what is the role of food you see when it comes to the prevention side of cancer and also in cure or management of it?
So thank you, Kamal. Do you want me to present a few slides also?
If you would like, we will be happy, no issues.
Yes, so let me share my screen with you.
Request my team to kindly, yes, I think.
Yeah, so good afternoon to all, and I congratulate the health and wellness.
Yeah.
It's a little complicated. Integrated Health and Wellbeing Council.
Yeah, it's yeah, thank you.
IHWC. So for organizing this event. So let me speak actually in common language, which is like Hindi and English, because हमने क्या किया है कि अपने और भी लोगों को ये शेयर किया है लिंक, because ये प्रिवेंशन का काम जो है, it is not just the work of scientists and doctors alone. इसमें कॉमन मैन की जब तक हमको सहायता नहीं मिलेगी और उनका रोल नहीं होगा तो अदा सही तरीके से, तो ये हम आगे नहीं बढ़ सकते, ये लड़ाई को हम हार जाएंगे
जी।
तो मैं मिक्स लैंग्वेज में आपको इसके बारे में थोड़ा बताना चाहूंगी कि रोल ऑफ अवेयरनेस, डाइट एंड लाइफस्टाइल से कैंसर की लड़ाई कैसे हम जीत सकते हैं। तो जब हम कैंसर के बारे में सोचते हैं या पता चलता है कि किसी को कैंसर हुआ, तो देयर आर डिफरेंट काइंड्स ऑफ इमोशन। शॉक होता है, डिसबिलीव होता है, एंगर होता है, ब्लेम होता है, सैडनेस होती है, होपलेसनेस होती है, पिटी भी होती है। बट दिस इज ऑल्सो अ टाइम फॉर रिफ्लेक्शन एंड इट लीड्स टू सेटिंग न्यू प्रायोरिटीज एंड न्यू गोल्स अपने लिए और फैमिली के लिए। तो जो कॉमन क्वेश्चंस दो तीन आते हैं, हम सिर्फ उस पर ड्वेल करेंगे बिकॉज देयर आर लॉट ऑफ अदर स्पीकर्स ऑल्सो, वो अपनी अपनी बात बताएंगे। तो व्हाट इज कैंसर, ट्रीटेबल है कि नहीं है, और मैं क्या कर सकता हूँ या मैं क्या कर सकती हूँ इसको फाइट करने के लिए। तो जैसे सबको पता है कि जो पर्पसलेस ग्रोथ ऑफ सेल्स होती है वो कैंसर होती है। कैंसर की जो सेल्स का डीएनए होता है वो डैमेज हो जाता है और वो मल्टीप्लाई कर लेते हैं। नॉर्मली आफ्टर फ्यू मल्टीप्लिकेशंस किसी भी सेल की ग्रोथ रुक जाती है, लेकिन जब कैंसर होता है तो वो मल्टीप्लाई करते जाता है। और जब कैंसर 1 सेंटीमीटर के साइज का हो जाता है लगभग, तो वो डिटेक्टेबल हो जाता है क्लिनिकली। इसमें होता क्या है कि जो सेल प्रोग्राम्ड होती है कि कुछ डिवीजन के बाद में उसकी डेथ हो जाएगी, प्रोग्राम्ड सेल डेथ, वो खत्म हो जाता है। तो कैंसर के क्योर के लिए कई तरीके के प्रावधान हैं। सर्जरी है, रेडियोथेरेपी है, कीमोथेरेपी, अब कीमो ओरल भी है, इंट्रावीनस भी है। लेकिन मोटी बात यह है कि अगर कैंसर फर्स्ट या सेकंड स्टेज में डिटेक्ट होता है तो ही सर्वाइवल पॉसिबल है, 5 ईयर सर्वाइवल अच्छा होता है। जैसे कि अगर अर्ली स्टेज में है तो 98% तक भी सर्वाइव करते हैं। लेट स्टेजेस जैसे जैसे होती है तो सर्वाइवल कम हो जाता है। बच्चों में जो कैंसर होते हैं लगभग 70% के करीब कैंसर्स जो होते हैं क्योरेबल होते हैं। और सेम गोज विद अदर कैंसर जो कि जिनका कि प्री कैंसर स्टेज जो होता है लॉन्ग होता है, मतलब 10 से 15 साल होता है। तो अगर आपने अर्ली पकड़ लिया प्री कैंसर स्टेज में, जैसे सर्वाइकल यूट्रस होता है, ओरल कैंसर होता है, उसके प्री मैलिग्नेंट लीजन्स होते हैं, तो फिर उसका क्योर पॉसिबल है। इसलिए निराश होने की भी इतनी जरूरत नहीं है। कैंसर ट्रीटमेंट में भी नई रिसर्च हो रही है, टारगेटेड थेरेपीज आ रही हैं। उसमें क्या है कि वो ऑन्कोजीन्स और ट्यूमर सप्रेसर जीन्स को भी हम लोग स्टडी कर रहे हैं। नई जो अभी आई हैं थेरेपीज वो मोनोक्लोनल एंटीबॉडीज के फॉर्म में आई हैं जो कि काफी इफेक्टिव हैं। लेकिन हमको अपने पेशेंट किसको देनी है वो बहुत केयरफुली चूज करना होता है। वैक्सीन के ऊपर भी रिसर्च चल रही है और इम्यूनोथेरेपी पे भी चल रही है। बट मैं क्या कर सकती हूँ उसको कैंसर को रोकने के लिए, या मुझे हो ही ना कैंसर, तो उसमें मॉडिफाइबल रिस्क होती हैं जो हमारे हाथ में है, और जो नॉन मॉडिफाइबल रिस्क होती है वो एनवायरमेंटल होती हैं जो हमारे हाथ में नहीं है। तो कमिंग टू द दोज रिस्क विच आर नॉन मॉडिफाइबल, जैसे कि एडवांसिंग एज में ज्यादा कॉमन होता है, जेंडर में कुछ लोगों को, जो विमेन होती है वो किसी कैंसर के ज्यादा प्रोन होती है, मेन कुछ और होते हैं, कुछ हेरिडिटरी फैक्टर्स होते हैं, बाकी कुछ एनवायरनमेंट में हमारे कार्सिनोजेंस हैं, कॉस्मेटिक्स हैं, केमिकल्स हैं, रेडिएशन है। तो ये लार्जर पॉलिसी लेवल पे प्रिवेंशन का काम इन चीजों का होता है। इनहेरिटेंस के लिए जैसे थोड़ा सा मोटा मोटा बता रहे हैं कि इनहेरिटेंस जो होती है हमें अपने फादर और मदर से मिलती है, और हर क्रोमोसोम में एक क्रोमोसोम फादर से होता है, एक मदर से होता है, और जब उनके किसी डीएनए सीक्वेंस में थोड़ा चेंज होता है, म्यूटेशन उसको कहते हैं, तो फिर वो हमारे पास ऑन हो जाता है इन आवर बॉडीज, एंड उससे हमारी रिस्क बढ़ जाती है। इसका मतलब ये नहीं कि अगर हमारे पास कैंसर की जो सेल्स हैं, म्यूटेटेड सेल्स हैं, तो हमें डेफिनेटली होगा। नो, वी कैन स्टिल प्रिवेंट इट बाय मैनेजिंग आवर मिल्यू, इंटरनल मिल्यू जिसको कहते हैं, अपना एनवायरनमेंट मैनेज करने से। तो वो हम आपको थोड़ा सा बताएंगे। तो डेफिनेटली अगर आप जो जिसके पास नहीं है म्यूटेशन वो नहीं पास ऑन कर सकता, जिसमें म्यूटेशन है वो ही पास ऑन कर सकता है। तो इसकी नॉलेज भी बहुत जरूरी होती है, क्योंकि कुछ तरीके के कैंसर्स होते हैं, हेरिटेबल कैंसर्स होते हैं, उसके तरह तरह के नाम है, सिंड्रोम्स हैं, और कौन सा ऑर्गन ज्यादा अफेक्टेड होता है वो सारा सब पता चल जाता है, और ये सारा लिस्टेड है इन द लिटरेचर, आई नीड नॉट ड्वेल अपॉन। कमिंग टू द मॉडिफाइबल रिस्क ऑफ कैंसर, तो जो ये सबसे इंपॉर्टेंट है, क्योंकि ये हमारे अपने हाथ में है इसको कंट्रोल करना। यूज ऑफ टोबैको, अल्कोहल, फिजिकल एक्टिविटी, वेट कंट्रोल, न्यूट्रिशियस डाइट, सेफ सेक्स प्रैक्टिसेस, और रूटीन कैंसर स्क्रीनिंग। बाहर के देशों में सनलाइट और यूवी लाइट का एक्सपोजर भी इंपॉर्टेंट है, और सबसे इंपॉर्टेंट जो आजकल बात कर रहे हैं वो डायर्नल रिदम की है। कैसे हम अपनी बॉडी को इस रिदम से अलाइन करके अपनी नॉट ओनली कैंसर की रिस्क बल्कि और अदर क्रॉनिक डिजीजेस की रिस्क हम इसको मॉडिफाई कर सकते हैं। तो एक एक करके चलते हैं। तो ये जो प्रिवेंटेबल कैंसर्स हैं, लगभग 35 से 50% कैंसर्स वर्ल्ड वाइड जो होते हैं, दे कैन बी प्रिवेंटेड बाय दीज मॉडिफाइबल फैक्टर्स। तो टोबैको रिलेटेड कैंसर्स इसमें से 40% हैं, इन्फेक्शन रिलेटेड कैंसर्स 15% हैं, लाइफस्टाइल रिलेटेड लगभग 10% हैं। कैंसर जो टोबैको की वजह से होते हैं लगभग बॉडी के सारे अंगों में अफेक्ट करते हैं। तो इसमें बहुत हमें सोचना ही नहीं है। फिर भी क्या है कि जो हम लोगों की पॉलिसीज हैं उसमें ज्यादा इसका महत्व है, क्योंकि जो एक बार जिसको टोबैको की एडिक्शन हो जाता है उसको छुड़ाने के लिए बहुत मेहनत करनी पड़ती है। तो हमारे इंस्टीट्यूट टोबैको सेसेशन क्लिनिक भी चलाता है, तो हम प्रिवेंशन की उस तरह से काम भी करते हैं। तो अगर आपको थोड़ी सी स्टैटिस्टिक्स दिखाएं तो प्रेवलेंस ऑफ टोबैको कंजम्पशन इन इंडिया क्या है, 25%, मतलब 1 in 4 मेन भी हैं, उसमें विमेन भी हैं। टोबैको इज नॉट जस्ट सिगरेट स्मोकिंग, स्मोकलेस टोबैको भी है। हमें कई लोग ऐसे मिलते हैं जो कहते हैं कि हमने सिगरेट पीनी छोड़ दी, लेकिन क्या खा रहे हैं, अब तंबाकू, गुटखा खा रहे हैं, पान मसाला, ये सारी चीजें। तो इसलिए जरूरी है हम लोग जब पेशेंट की हिस्ट्री लें तो हम ये सारा कुछ पूछें कि आप बीड़ी सिगरेट पीते हैं कि नहीं, और तंबाकू खाते हैं कि नहीं, क्योंकि ये स्विच होता रहता है। कई लोग डुअल यूज करते हैं, दोनों चीजें यूज करते हैं, तो ये भी बहुत जरूरी है रिकॉर्ड करना। अब इसमें देखिए, अगर एनुअल इकोनॉमिक बर्डन ऑफ ऑल डिजीजेस एट्रीब्यूटेबल टू टोबैको यूज कितना है, तो इतनी बड़ी सी फिगर आपको दिख रही है। और अगर आप रेवेन्यू जनरेशन देखें तो बहुत छोटी सी फिगर है। तो लाजमी है कि अगर हम रेवेन्यू जनरेशन का ये दलील देते रहें कि हम इसलिए टोबैको प्रोड्यूस करते हैं क्योंकि वो रेवेन्यू जनरेट कर रहा है, तो ये सही नहीं है। तो ये जो प्रिवेंशन का पार्ट है ये हमारे पॉलिसी लेवल पे उनको प्ले करना होगा। अल्कोहल, इट इज नॉट मच स्पोकन अबाउट। जहां पे भी आप लिटरेचर देखेंगे कहेंगे लिमिटेड अल्कोहल यूज करिए, बट दैट्स नॉट करेक्ट। यू शुड stop alcohol. One should stop alcohol consumption. थोड़ी सी मात्रा में भी 10 ग्राम्स 12 ग्राम्स भी वो कार्सिनोजेन है। ये बहुत क्लियरली लिटरेचर ने आइडेंटिफाई किया हुआ है। बट स्टिल हम देखेंगे कि पर कैपिटा कंजम्पशन जो है अल्कोहल का बढ़ते जा रहा है। दे अफेक्ट डिफरेंट ऑर्गन्स, सब जगह रिस्क होता है कैंसर का। ओबेसिटी, इसके बारे में ज्यादा लोग बात नहीं करते हैं क्योंकि बहुत डिफिकल्ट होता है मैनेज करना, बट इट कॉन्ट्रीब्यूट्स टू नियरली 6% ऑफ कैंसर्स। और सारी बॉडी के लगभग कोई अंग ऐसा नहीं है जो कि छूट जाता है। बट प्रॉब्लम क्या है, वो सब लोग सोचते हैं हमारे फलाने हमारे फैमिली में ये मोटे थे इसलिए हम भी मोटे हो गए, बट ऐसा नहीं है। इट इज अ रिजल्ट ऑफ रॉन्ग ईटिंग। अगर हम प्लेंटी ऑफ लोकली अवेलेबल फूड्स खाएं, जो फ्रेश फ्रूट्स एंड वेजिटेबल्स हैं, मोस्टली इन अनकुक्ड फॉर्म, तो आप प्रिवेंट कर सकते हैं। प्रोसेस्ड फूड या अल्ट्रा प्रोसेस्ड फूड जो होते हैं मेन कल्प्रिट होते हैं। मैं तो ये बोलती हूँ जिसको अपनी इंटरेस्ट है अपनी हेल्थ में, दे शुड ट्राई एंड गो टू द किचन एंड मेक देयर ओन फूड टू द एक्सटेंट पॉसिबल। उससे सबसे एक बॉडी का कनेक्ट होता है फूड से। जो आप खाते हैं अगर आपको पता ही नहीं है किसने बनाया कैसे बनाया, तो एक अलग फीलिंग आती है खाने की, हम खुद बना के खाएं, चाहे कितना भी कोई बिजी हो, बट वो इतना तो कर ही सकता है अपना हेल्थ को ध्यान में रखने के। तो टू द एक्सटेंट पॉसिबल वन शुड डू इट। अनहेल्दी डाइट्स, हम लोग कहते हैं कि जी हम लोग प्रोसेस मीट नहीं खाते, रेड मीट नहीं खाते, स्मोक मीट नहीं खाते, तो इसलिए हम लोग बहुत हेल्दी हैं। नो, ट्रांस फैट्स एंड दीज काइंड ऑफ फूड्स आर एम्पली अवेलेबल एवरीवेयर। एवरी डे आई सी मॉर्निंग में लोग उस पर पराठे खा रहे होते हैं या चाउमीन खा रहे होते हैं इन ठेलों पे। सो दीज आर द मेन फॉर्म्स ऑफ अनहेल्दी डाइट। पास में एक फ्रूट का भी ठेला होता है, वहां पे भीड़ नहीं होती है। कमिंग टू इन्फेक्शंस, लगभग देख लीजिए 2 लाख केसेस जो हैं जो इन्फेक्शन रिलेटेड कैंसर्स हैं। तो इसमें चीफ कल्प्रिट्स आपके ह्यूमन पैपिलोमा वायरस है, हेपेटाइटिस बी है, हेपेटाइटिस सी है, और हेलिकोबैक्टर पाइलोरी जो स्टमक कैंसर कॉज करता है। इसमें से इंपॉर्टेंट ये है कि ह्यूमन पैपिलोमा वायरस का, हेपेटाइटिस बी का वी हैव अ वैक्सीन, लेकिन हमारा वैक्सीन कवरेज बहुत ही पुअर है। सो इट इज नॉट अ नेशनल प्रोग्राम, तो इससे लोग लगवाते नहीं है। अब इसमें बीच में कुछ मिथ्स भी हैं, कुछ लोग डरते हैं, बट इसको प्रमोट करना चाहिए। हेपेटाइटिस बी तो हमारे वैक्सीनेशन इम्यूनाइजेशन प्रोग्राम में है, बट एचपीवी नहीं है, जिससे कि सर्वाइकल कैंसर होता है। सो दिस इज द स्टैटिस्टिक्स। बिसाइड्स वैक्सीनेशन फॉर एचपीवी सर्वाइकल कैंसर, देयर आर अदर रिस्क फैक्टर्स जो कि हम फिर भी प्रिवेंट कर सकते हैं, लाइक स्मोकिंग, जो कि विमेन में भी है। फर्टिलिटी अगर रिड्यूस करें, बिकॉज हाई फर्टिलिटी इज ऑल्सो रिलेटेड टू सर्वाइकल कैंसर, एंड अर्ली sexual intercourse, that is also related to cervical cancer. So these are the preventive factors apart from the vaccination. तो आप देखिए स्क्रीनिंग कवरेज जो है हमारे पास 3% ही है टोटल कवरेज। If we can increase this, certainly we will catch these infections much earlier. Same goes for hepatitis B and C. तो safe injection practices, blood transfusion practices and vaccination, ये सब हमें practice करना चाहिए। Coming to lifestyle, सब लोगों के अपने अपने आइडियाज हैं about lifestyle। तो ये वेरियस काइंड्स ऑफ लाइफ्स अवेलेबल हैं। इट इज फॉर अस टू चूज द राइट वन विच वी थिंक। तो सोशल परसेप्शन जो होता है वो भी बहुत इंपॉर्टेंट रोल प्ले करता है इन चूजिंग द राइट काइंड ऑफ लाइफस्टाइल विच इज नॉट गोइंग टू कॉज यू कैंसर और एनी अदर क्रॉनिक डिसीजेस। ये किसी बच्चे ने अच्छा सा ये बनाया था, सो आई जस्ट थॉट इट्स अ नाइस थिंग टू डिपिक्ट। एक्सरसाइज एंड फिजिकल एक्टिविटी, फिजिकल एक्टिविटी को लोग नाप तोल के करते, जी मैंने 30 मिनट्स कर ली, मैंने 40 मिनट्स कर ली, अभी ये एविडेंस आ गया कि 4 times a week करनी है। डोंट गो इनटू ऑल दैट, डोंट गो इनटू दोज नुआंसेस। वर्क एंड फिजिकल एक्टिविटी शुड बी सॉर्ट ऑफ रिलेटेड टू ईच अदर। अगर आपका सेडेंटरी वर्क है तो आप फाइंड न्यू वेज टू हाउ टू मेक इट नॉन सेडेंटरी। डिस्कवर न्यू वेज टू इंक्लूड योर बॉडी पार्ट्स इन योर डेली एक्टिविटीज। डू सम आउटडोर हॉबीज, गार्डनिंग वगैरह करके कम्युनिटी एंगेजमेंट करिए, एंड मेक फिजिकल एक्टिविटी अ वे ऑफ लाइफ रादर देन अ रिचुअल कि हमने इतने स्टेप्स चल लिया या ऐसा। तो दैट इज व्हाट आई वुड से, कि इतनी ज्यादा छोटी छोटी चीजों पे हम स्ट्रेस देते रहेंगे तो मेजर जो चीजें हैं वो छूट जाती हैं। डायनल रिदम जिसकी हम बात कहते हैं, दिस इज नॉट मच स्पोकन अबाउट बट इट इज वेरी इंपॉर्टेंट। आप सनराइज के साथ साथ अपनी डेली और सनसेट के साथ साथ अपनी पूरी लाइफ को अलाइन करिए, एंड दिस विल सेट लॉट ऑफ थिंग्स in the right direction. तो जो देखा गया है कि जो लोग नाइट शिफ्ट में वर्क करते हैं कंसिस्टेंटली फॉर मेनी इयर्स, उनमें ये क्रॉनिक डिजीजेस और कैंसर्स की प्रेवलेंस मच हायर होती है. So besides everything other being equal, so please don't say I'm a night owl or things like that. अपनी बॉडी को जैसा बनाया गया जिस काम के लिए, उसको सही ढंग से यूज करना चाहिए. So look within, अपना देखिए मेरी क्या रिस्क्स हैं, what are and then what do you feel about them, what is your perception, are you willing to change, are you willing to modify. एक्शन प्लान अपना खुद बनाइए. उसके बाद यू कनेक्ट टू स्क्रीनिंग प्रोग्राम्स जो कि हमारे गवर्नमेंट के हैं, कम्युनिटी सर्विस में एंगेज करिए, हेल्दी ईटिंग करिए. इसमें कोई बहुत सोचने की बात नहीं है. ऑफ कोर्स वी हैव पैनल्स में अपने न्यूट्रिशनिस्ट होंगे, बट होलसम डाइट, सिनर्जी होनी चाहिए. कब खा रहे हैं ये भी पता होना चाहिए. ये नहीं कि सारे टाइम खा रहे हैं, क्या खा रहे हैं. ऑफ कोर्स व्हाट पे तो ज्यादा जोर होता है, बट कब खाना है, कैसे खाना है, किसके साथ खाना है, ये भी बहुत इंपॉर्टेंट है. So these are some of the examples which are from my own kitchen. So then 3-4 slides और हैं जिसको मैं फोकस करना चाहूंगी. We should talk about.
Can we come later on some of the slides?
Shall I go back?
No, I'm saying that can we come back to you for some more slides, because I think a few things which you have talked about are important, and we can take some more information from the other panelists also.
हाँ, नहीं बस मैं I just want to focus on 1 or 2 slides more, that's all.
Please go ahead.
हाँ, so प्राइमोडियल प्रिवेंशन में ये कहना चाह रही हूँ कि हमारी गवर्नमेंट और पॉलिसीज, इन लोगों को इस पे ध्यान देना होगा. So these are the few things, taxes, advertisement, information, तो ये चीजें जो हैं वो गवर्नमेंट को मैनेज करनी होती है और पॉलिसी लेवल पे एक्शन लेना होता है. प्राइमरी प्रिवेंशन अगेन गवर्नमेंट प्रोग्राम्स जो कि हम कैंसर स्क्रीनिंग प्रोग्राम्स वगैरह करते हैं, जो कि हेल्दी इंडिविजुअल्स पे फोकस होना है बिफोर दे गेट सिक. ऑफ कोर्स सेकेंडरी प्रिवेंशन पे ज्यादा जोर है और टर्शियरी प्रिवेंशन पे भी हमें पता लगता है ये नया हॉस्पिटल खुल गया, ये हो गया. सो दोज आर द अदर थिंग्स. बट इंपॉर्टेंट वन मोर स्लाइड इज द क्वाटरनरी प्रिवेंशन. आई वुड लाइक टू जस्ट रीड इट आउट. इसमें क्या है? एक्शन टेकन टू प्रोटेक्ट इंडिविजुअल्स, पर्सन्स एंड पेशेंट्स फ्रॉम मेडिकल इंटरवेंशंस दैट आर लाइकली टू कॉज मोर हार्म देन गुड. जैसे ओवर मेडिकलाइजेशन, अगर कोई नई चीज आई है एकदम उसको इम्प्लीमेंट करना. ऑल्सो यू हैव टू टेक एक्शंस और गिव इंटरवेंशंस व्हिच आर एथिकली एक्सेप्टेबल. ओवर मेडिकलाइजेशन से बचें. एंड दैट्स माय फाइनल थिंग. यू मस्ट टेक पर्सनल रिस्पॉन्सिबिलिटी. You cannot change the circumstances, the seasons and the wind, but you can certainly change yourself, and that is something you have charge of. Jim Rohn, motivational speaker, I found has said this, and I found this very apt, at least for the theme of I am and I will. Thank you.
Thank you so much, Dr. Salih, for your wonderful presentation, and you showed some very tempting food dishes also in your presentation. It's almost, I think many of our audience are with us since morning. I hope they would have taken their lunch, or while sitting and watching this program, they should keep grabbing something, because eating on time and eating right is very important as far as prevention of disease is concerned. Dr. Salini, can you remove this presentation, please?
Yeah, I'll do that.
Thank you. Thank you so much, ma'am. So, since you have captured almost the entire gamut of cancer, causes, prevention, cure, and from individual level to the government level, the regulatory part of it, everything is very well captured. So now we'll go a little deeper in various other aspect, and especially the theme of this particular session about nutrition and lifestyle, how it can impact prevention and cure or management of cancer. Dr. Kabra, I will come later to you, because Dr. Salini has captured a lot of medical aspects also. So let me go to the nutritionist among us. Dr. Isi Khosla, since Dr. Salini has taken English as a medium, तो मैं भी कोशिश करूंगा कि हम लोग both languages पे बात करें, जिससे कि हमारे audience को भी help होगी. तो इसी जी, अच्छा खाना, समय पे खाना, रेगुलर खाना, these are the areas जो डॉक्टर शालिनी ने बताया कि बहुत इंपॉर्टेंट है। और नॉर्मली हम लोगों की लाइफ स्टाइल में जो कि नई मॉडर्न लाइफ स्टाइल है, जिसमें सिडेंटरी भी है, जिसमें वर्क फ्रॉम होम जो कि कोविड का आउटकम है, जिसमें वी आर सिटिंग इन फ्रंट ऑफ डिजिटल डिवाइसेस फॉर लॉन्ग, वी आर काइंड ऑफ snacking more, the more junk is being used. The modern lifestyle में ये भी है कि लोगों के पास उतना समय नहीं। डॉक्टर शालिनी ने बहुत इंपॉर्टेंट बात बताई कि खाना खुद बना के खाना चाहिए। अब शायद ये लग्जरी सभी लोगों के पास ना हो जो सुबह 8 बजे ऑफिस के लिए निकलते हैं और रात को 10 बजे या 9 बजे या 7 बजे वापस आते हैं, तो शायद ये लग्जरी ना हो। हाउ डू यू थिंक कि ये जो न्यूट्रिशन और फूड का जो रोल है हमारी हेल्दी लाइफ में और प्रिवेंशन ऑफ मैनी डिजीजेस इंक्लूडिंग कैंसर, इसको कैसे हम मॉडर्न सिनेरियो में भी मैनेज कर सकते हैं?
फर्स्ट ऑफ ऑल थैंक यू फॉर इनवाइटिंग मी। और ये सब्जेक्ट बहुत ही अहम है, बहुत इम्पोर्टेंट है, खासकर क्योंकि आज कैंसर को हम एक स्पेशल डे में मान रहे हैं। एंड वो इसलिए है क्योंकि द स्टेटिस्टिक्स आर गेटिंग स्केरियर बाय द डे। You know, the number of people and fatalities with cancer are increasing and are likely to triple by the year 2025. And the conversations जो हो रही हैं खाने पीने के बारे में, चाहे लाइफस्टाइल के बारे में, और या कैंसर क्यों हो रहा है, एक ये बहुत बड़ा सवाल है कि क्यों बढ़ रहा है। तो ये सवाल उठ रहे हैं और they are very important and very pertinent. And I will just take this forum to also mention that just a month ago I have lost my very dear cousin, जिनका हम ये कहेंगे कि उनसे अच्छा लाइफस्टाइल किसी का नहीं हो सकता था। He was a senior gastroenterologist of the country, and he died of a lymphoma at 67 years of age, and with a very short battle. It was too soon, you know, with the kind of the disease he had. So when it comes close to you, you feel even more vulnerable and far more shaken by this whole thing. बहुत फिट थे, ना मोटापा था, ना कुछ जंक फूड था, ना कुछ स्ट्रेस था, बट था जो भी था, कैंसर बना, and he succumbed to it. So one or the other, they are raising many important questions, and I believe that there is more money being spent in this this research for cancer than even NASA has ever spent so far, and it is still eluding us. And what is really coming out of this is that we are perhaps missing something in terms of our addressing this. जैसे डॉक्टर सिंह ने कहा, मोटापा को मान लीजिए, मोटापा बहुत मुश्किल है कंट्रोल करना। तो जानकारी तो है मोटापे के बारे में, जानकारी तो है कि ये कैंसर के रिस्क फैक्टर्स हैं, लेकिन we are not being able to arrest the epidemic. It's become an epidemic. So where are the gaps? Why are the links missing? And I think today with modern scientific research, we are able to answer to a large extent what is going on and why this is happening. And the root cause of all these so-called lifestyle diseases, including cancer, seems to be lying somewhere in the digestive tract, in the gut. And this is something which was the Hippocrates, the father of modern medicine, had said so many years ago, 2,500 years ago. This was what he said, all diseases begin in the gut. So what is happening in the gut, and why are we getting so vulnerable to diseases which we were not earlier? So what we find is that the answer is in what we call a leaky gut or an increased intestinal permeability, which according to now senior scientists, very, very recent research, that almost all diseases, I would not even use the word almost, diseases begin in the gut thanks to the leaky gut. And इसके लिए जब हम ये बात समझते हैं, so we need to understand that what it is in the leaky gut which is causing this problem to, problems to appear. This is what we call the microbiome, the the microbiome or the flora that is a part of our body, which we have ignored all these years. We have not given attention to these tiny microorganisms, the bacteria, the fungus, the viruses, which are in a state of balance in our gut. And any disturbance in this balance is what we call dysbiosis. And dysbiosis is the starting point of inflammation in the body. And inflammation is today being linked to almost all diseases. Like I said, it's a gut, but what is it in the gut? It is the inflammatory factors which are the starting point, be it heart disease, diabetes, or cancer. So today we are in a position to sort of get to the root cause, and therefore a diet which is anti-inflammatory is going to be very, very, the diet. You cannot have, I mean, a person may have cancer, heart disease, diabetes, obesity, but you cannot have different diets. So the diet that needs to be really talked about is an anti-inflammatory diet. And what, not only the anti-inflammatory diet, also an anti-inflammatory lifestyle. So like ma'am just pointed out, smoking, alcohol, stress, and all of these other factors which are actually are pro-inflammatory. They increase the inflammation in our body, and all of this is mediated through the gut flora. तो जब तक हम अपने गट डाइजेस्टिव सिस्टम को एड्रेस नहीं करेंगे, मुझे लगता है कि हम इस वॉर को नहीं जीत सकते. और जो एक कहावत है, क्योर इज इन द कॉज. So once we really get to the cause, to the root cause, only then we'll be able to deal with the problem. And when I say what to eat, it is, आपने बिल्कुल ठीक कहा, what to eat है, how much to eat है, how to eat है, when to eat है. So क्या खाया, कितना खाया, कब खाया और कैसे खाया, ये सब जरूरी है आपको एक होलिस्टिक अप्रोच से करने के लिए. और यह हम देख रहे हैं कि जो इन्फ्लेमेशन की मैंने बात करी, तो क्या खाने में, what are the inflammatory factors which are there in our food. फर्स्ट ऑफ ऑल, जैसे मैम ने कहा, प्रोसेस्ड फूड में जितने भी एडिटिव्स हैं, जितने भी कलर्स हैं, जितने भी केमिकल्स हैं, वो हमारे गट फ्लोरा को परेशान करते हैं. they cause dysbiosis and opening of the tight junctions. Simple thing like MSG. MSG is nothing but monosodium glutamate, which is used, or today it is banned, but it is, the different variants of MSG are still being used. And these open up the tight junctions. This is the biggest problem with MSG. So whether it is additives, colors, or whether it is pesticides, whether it is the toxins during the agricultural production of our food or the industrial production of our food, all these chemicals, or for that matter, even modified food, जैसे गेहूं को लीजिए जो बहुत हाइब्रिडाइज्ड हो गई है, it has an immunogenic effect. वो एक बहुत एरिया बहुत तेजी से बढ़ रहा है, इसके बारे में जानकारी साइंटिस्ट को भी अब समझ आ रही है कि हो सकता है कि जो मॉडर्न गेहूं है वो एक इम्यूनोजेनिक प्रोटीन है और उसकी वजह से ये गट प्रॉब्लम्स आ रही हैं, डिसबायोसिस हो रहा है. इसी तरह चाहे दूध लीजिए, डेयरी लीजिए, डेयरी इज गुड, बट maybe it has changed because of the various reasons. High yielding varieties, lots of hormones are being injected, antibiotics are being injected. So ये हमारे food में बहुत important, we are seeing the inflammation caused by these. Independently, in the earlier days, if you just give me the timelines, I will work around that. Please tell me how much time and I'll...
No, actually, the points you made, especially, the loss of one of your relative to cancer, despite having, the best or, one of the ideal lifestyle. I wanted to take it to Dr. Asa Nair, actually, that, despite following, the best possible lifestyle, which you said, and being a doctor himself,
being a gastroenterologist.
Yeah, so you talk about gut, and he is the kind of expert of gut. So Dr. Asa, since you are involved in the research of cancer, what is that is making it more susceptible, vulnerable for cancer, and how much of this prevention which we are talking can actually be effective in terms of preventing this disease? Because this is something which Mrs. Khosla, which she mentioned, this is something which is becoming quite rampant, quite widespread. We keep hearing cases, people without any history of, smoking, getting lung cancer, brain tumor, so many such things. So what is the, your view on that? So this is what I wanted to, kind of make Dr. Asa and I talk about.
Sure.
Thank you for the opportunity for sitting me with such learned people, and I thank once again the organizers. Yeah, I am a cancer researcher and I work mostly on colorectal cancers. Like Khosla ma'am has mentioned, my work is on working on the cancer stem cells of colorectal cancers. So what we have been seeing is that you don't need specific reasons for a cancer cell to blow up. They might be inflammatory conditions, high inflammation, which we don't know. But in the gut, what we see is this total replenishment of the crypt cells, the lining of the gut, where how much of food you put in, they try to digest. So that is why the olden times, the people will tell, have food before 8 or before 7. So what happens is, after that, the digestive system gets slow. All becomes slow as the diurnal effect takes place, as the sun sets down. So the whole system slows down. So the digestion becomes very, very slow. So what happens? This guy chews, and by the end of the day, finally digest the system, whatever food we put in. So that is a very heavy action on the gut. Very, very heavy action on the gut. And the toxicities which the food the young generation is having is completely mutating the bacteria. The nice bacteria, the biome, like ma'am told, the dysbiosis, which is happening is the bacteria is getting mutated. All the toxins are put in. It is not like the olden days, cooked food at home, like ma'am told, cooking food at home. No, it's all the additives, the chili powder, all are bad. Nothing is good as we see. So what happens is the bacteria changes. It undergoes mutation. That is for sure. So I study the biome of the people in the West and here of Indian biome. We see that there's complete difference just because of their food habits. We cannot go into a Western style staying in India or staying in this part of the region, but we are Westernized. And the next thing is, like ma'am told, food is important. You are what you eat, right? You are what you eat. That is stabilized. Everywhere it's stabilized. So what happens is, unless you have a mutation like the TNBCs, the triple negative breast cancers, where you have a BRCA1, BRCA2 mutations of the breast, where the breast is gone, and you know that you get a metastasis to the liver, there's no cure yet. There are problems in that. There's immunotherapy, everything. But what happens is, there is a mutation, known mutation, the BRCA1, BRCA2 mutations. So these mutations, of course, are reasons for cancer. But people without chewing tobacco or without smoking can get a lung cancer or an oral cancer, of course, is still a mystery. It's still a mystery. I have no shame in telling that. Still, people are going on doing research to find out why this happened. One researcher catches one molecule, another researcher catches another molecule. What is cancer? A blow up of the map. The whole system is blown up. If you have fever, you treat them with paracetamol. The doctors here, you treat it with the paracetamol. Of some other disease, you have a specific drug. But personalized medicine is not there for cancer. So we step into the process of prevention. That is very good. And the lifestyle is very, very important. But just look at the attitude of the young generation. Colorectal cancer is very highly increasing in the young generation. That is for sure. We have the NIH data, we have the Globocan data, we have the ICMR data, where the young generation by 40 years are getting colorectal cancers, either the rectum or the colon. Especially the Indian population are with the rectal cancers. And I don't know of the other states. I work in Trivandrum. I have the RCC data, the Regional Cancer Center data, where more than 75% of the cancers are rectal cancers. So there are many reasons for this. Very fast lifestyle. Lifestyle means morning you have to, the children or the mother or the father get dressed and push them up. You don't even ask your children, did you have your bowel movement? No. They store that up and go to school. the putrefying bacteria sitting in your system, that is dangerous. Very, very dangerous. One of the lifestyle changes that should be made. Okay, and then the attitude of the youngsters. We can talk for hours, eat this, eat that, don't do this, don't do this. Will the young hear? No. What is their attitude now is just enjoy life. Life is important. Pizza, this thing, that thing, drinks, right? Like I have been watching this. Then the most important factor of every food items now in fast food is maida. The maida in that. Yeah, that is a very, very important thing where the digestion of that flour will take hours in your system. So all these are nutritional facts, which are small, small facts. The common man also knows this. But the lifestyle is like that. Nobody is there to screen. They must have door-to-door screening program, either the breast or the colon or the cervix. Door-to-door screening program must come from the government level, as ma'am told. We don't have that. And usually colon cancer is considered cancer of the old. No, it has changed. It is cancer of the young now. So what happens is, so as it goes on, because of the changes in the global environment and also of the attitudes, also of the economy, the cancer is still a disease which you see like this with, oh, okay, he got cancer, fine. Like ma'am told, first and second grade, you'll be treated. Third, you'll come with a liver metastasis or something like that. So I agree there are inheritable cancers which are genetic. Sometimes when the parent line, it can come. It can come. But some cancers, like the oral cancer without a tobacco chewing or the lung cancer without a smoking, is still a mystery. And one more thing I have to tell is, your mind contributes a lot. Who is not stress-free today? All are full of stress, full stressed up, right? So that is one of the biggest factors which all have to see that the environment they work or the way they carry out their life is stress-free. So if what is in your mind goes to your gut. You're sad, can you eat? No. You're happy, of course you eat. So what happens is modulate the system in such a way so that, like ma'am told, like Kosla ma'am told, gut is very, very important. The biome, the inflammatory conditions, the nutritional foods you take. So all these are very important factors in bringing about a very healthy environment for a person to prevent himself from cancer. And like ma'am told, the diet, lifestyle, exercise, obesity, breastfeeding, all these are important things. But another thing which we have to see is how many people in the grassroots level knows this. We can sit here and talk, but who are really going to the masses and telling that this should be done, that should be done, that should come out. Many don't know. Many don't know that what is cancer also they don't know. If we go, I take classes in the slum, they ask this. Pardon?
Thank you. I think let me go to the other panelist also.
Okay.
Some
yes.
good point.
Yes.
Dr. Shikha Sharma, are you with us, Dr. Sharma? Yes. Okay. So, Dr. Sharma, you are, you have been trying to bring in a lot of, public awareness on, behavioral change and the good food habits and all that. Dr. Asa has identified or highlighted a very important point that the today's generation, despite knowing, and the families, this knowledge, is flowing from generations that, almost what is good, what is not good, eating on time, even the bowel movements we see, kind of talked about, everything is something is part of, a very, very normal life in our country. Now, what is that, this resistance, and how has been your experience in terms of bringing this behavioral change among the people, or maybe even the youngsters? Many of them would be consulting you for, slimming regimen or, weight loss and something like this. How much they are ready to kind of switch to a healthy lifestyle?
Correct. So, like you correctly pointed out, now, when we look at an individual, we normally say, oh, this individual is not making a change, or this individual is not agreeing or changing their lifestyle to eat healthy. But really, are we really individuals? We are not really individuals. We are one, we can almost say we are a cell in an organ. And what is this? So there are, like, suppose if we call the community as a body and the organ as a family. So we are one cell, and our family is surrounding, which is a milieu, and then our community is surrounding, which is another larger milieu, and finally our ecosystem. To give you a typical example, that 99% people want to fit in. They want to fit in with their families, they want to fit in with their friends, they want to fit in with their society. Now, when we say fit in, which means that we don't want to stand out, we don't want to do things which others are not doing, or where we stand out as people who are trying to be different, or we are trying to be different from others, and which is not acceptable, because in a Asian culture, in Southeast Asia and Asia, particularly India, we like to go along with others. We don't like to say, no, I'm different than you and I am an individual and therefore I'm different. Now, what does it lead to? Typically, if you go to any home today, most people, when they serve you tea, they will serve you fried snacks. If you go to a conference, they will serve you oily food. If you go to a wedding party, they'll serve you oily food. If you are traveling from Delhi to any other place, or any other place, in the flight, in the train, in the restaurants, you will get a certain kind of food. If you want to drink water and there is no water, you'll end up picking up a fizzy drink because it's cheaper than water. In this milieu, for somebody to say, no, I want to only eat healthy, means they have to have extreme high level of self-control and also an ability to say no to everybody else. Because the first thing which happens is, and this is typically what our patients would say, is that when we try to say, no, I don't want to have that fried samosa, I don't want to have this kind of food, the first thing people would say, oh, you are dieting. Oh, that's so sad. Second thing they would say is, eat today, doesn't matter. Tomorrow you can start your dieting. So, the word has, instead of healthy, nutritious eating, people are mixing it up with, oh, you are dieting, or you are trying to do something different, which is away from our families, or which is, like, for example, what is happening in most corporates today, when people celebrate, they have a pizza party. And the fizzy drinks come along with the pizza. This is the reality. Now, when we look at in terms of behavioral psychology says that if you put, suppose, somebody who is 60 kilos of weight in an environment where the average weight is 100, they will gain 5-10 kilos. Because now they will start relaxing and trying to follow the environment. If you put the same person in Japan or in Singapore, they will start losing weight because suddenly everybody around is very slim or very fit, or there is a culture of fitness. So I think what I'm trying to allude to today is that the community, the institutions, like, for example, what is the community of a child? School and home. What is the community of a grown-up? Their associations, their office, and their home, and their friend circle. So if these communities are having a certain cultural way of eating and living, then it is really hard for an individual to say, no, I'll do something different. Now, yes, some individuals do that, but sadly it happens when they are stricken with cancer. So when they're stricken with cancer, then they will make that extra effort, and also the community gives them the benefit of doubt ki nahi, ab thoda parhez ka khana hai, nahi khana hai. But the rest of everybody is still eating that kind of food. So what I'm trying to say is, I think today what we really need is the change. Not only has to for real change to happen, communities have to get involved, which is that school is the best community because that's where we learn habits, and family is the second, and third is where we work, where we live, where we work, and where we study. So, and where we play also. So these are the three areas where I think institutions have to come in and start making a change.
Yeah, thank you so much, Dr. Sarma, for highlighting, and then also highlighting that if we want to bring in change in the individual, preferences, choices, or lifestyle, we have to change the community as a whole. That's a different thing that my child, when he goes to school, he eats healthy because only healthy food is served. While when he comes to home, he only wants unhealthy food, and he kind of ask it with right, and rightfully asked for it. So. Dr. Vedant, you heard, a lot of preventive side of it. People come to you when they have already kind of got the tumor and you remove their tumor surgically. while we have understood a bit that, many of the cancer are being caused by almost, 50-70% cancers are caused by preventive causes like tobacco consumption and many other. And Dr. Asa said that many of them is still mystery. What is your opinion about that? How cancer kind of disease be prevented by lifestyle modification or by food, or what kind of food you suggest to your patient or in your community outreach?
So, Kamalji, I think most of it has been covered, and Dr. Shalini very extensively covered every aspect of cancer prevention. But I would still like to make a few points since you have asked me what kind of preventive measures. So, apart from the lifestyle modifications like no substance abuse, smoking and alcohol, and a good nutritious diet, I think it is very important to be a holistic well-being. It is not only your physical health which is important, it is also your mental and spiritual health which is important, because it's a combination of all. Your mind actually controls your body. If the mind is disturbed, then it definitely disturbs the body. And Dr. Nair did mention that there are some mysteries still around, and I'm sure many of those mysteries we have the answers here. Because the mind is disturbed, it creates a pro-inflammatory state. It stresses the individual cells, and it also creates pro-cancer environment in the body. So a stable mind and a stable spirit, by, we are in India, and I think India can actually lead in this matter as well. Dr. Shalini said that the way Indians cook, the way Indians have been eating traditionally is, in India, it is a freshly cooked meal every time. It is locally available food, and it is seasonal food. So there is a food for winters and there is a separate kind of food for summers. You have to have locally available foods most of the time. Now with globalization, you can have anything ranging from kiwis from New Zealand to pizza from US or Europe, wherever. But most of your diet should be locally available, freshly cooked, and seasonal diet, varying according to the seasons. This is what I tell my patients also, and it should be a variety of diet. It should be a good mix of diet. You cannot run away from fat. You cannot be on a purely protein diet and no carb diet, which many people go for. You have to have a balanced kind of approach and balanced diet. Add to it the other part, the spiritual part of India, is you must practice physical exercise, yoga, and meditation, which will soothe and calm your mind. In today's world where everybody is running, Dr. Nair mentioned very nicely, the child, somehow you have to pack off the child to school and your responsibility is over. So in such hurry, you even forget to ask whether the child has eaten well and passed motion or not. So all these things, you have to calm your mind and then act accordingly. So these are few things that I would definitely tell my patients. You mentioned patients come to me when they already have cancer, but that's not entirely true. The whole family also comes to us who do not have cancer, and that is where we have an opportunity to teach them. We also get patients, very few, but we do get people, I would not call patients, people who come for cancer screening, because they are not patients. They come for cancer screening, and our job is to guide them properly for timely screening, what should be the interval of screening, for those who have higher risk than the normal population. So somebody who has had a family history or some other risk factor which raises the risk of a particular cancer as compared to general population, we may do more intensive screening using much more investigations and more frequently. So this is where our role for primary prevention is also there. And secondary prevention definitely is there by modification of lifestyle and everything.
Thank you so much, Dr. Kabra, and thank you for highlighting that, when you practice, it is not just the patient who come, the whole family come, and that is, I think, opportunity where we can, kind of instill or, kind promote some healthy habits. The theme of the World Cancer Day today, this time is that I am and I will. And today during, multiple deliberations, we have also, kind of coined another, term for promoting prevention against cancer, is that rapid. Rapid is the R stands for recognizing that anyone can have cancers. We normally live in the state of denial that, we can't have cancer, or cancer cannot come to me because I'm, following a healthy lifestyle, or because of this region or that region, or I don't have risk factors. The, A is act, go for screening, do your self breast exam, or, any other aspect of screening or preventive checkup which are available. P stands for practice, eat healthy, kind of practice exercise, do regular exercise, mental, kind of calming practices like yoga. And, I stands for inform your family members, your friends, your community about the risk of cancer, about how they can prevent cancer. And D stand for that you must decide that you can defeat cancer. So this is a new term which has been kind of given by one of the expert today, rapid, and we kind of feel that this is something can be a way forward. We are left with 6 minutes for this session to kind of wrap up. I will quickly request all of you to kind of give your a remark or your tips which the audience today can take away and can actually try to act on. So I begin with Dr. Kabra, and then we'll go backward.
Okay, so I'll just succinctly summarize everything that we must be aware. And awareness does not only mean patient, awareness also of the doctors, which Dr. Harsh Mahajan did mention in the previous session. Doctors of different specialities also should be aware of symptoms of cancer or early signs of cancer. Screening appropriately on time for appropriate cancers. A diet which is rich in fiber, low in saturated fat, full of fresh vegetables and fruits, and a vegetarian diet is a preferred diet. Good physical activity and a holistic well-being, sense of well-being, I think will go a very long way in preventing cancer. One more important thing, there's a taboo. Patients would not come to awareness sessions, or people would not come to awareness sessions as if by listening to the word cancer, they will get cancer. And this is what I have experienced many times. Even patients would say, Doctor Sahab, wo to nahi hai jo soch rahe the. They will not utter the word cancer. I don't know what fear they have. So that's all I have to say.
Thank you so much. So I think that's where the word R has to be there, that it cancer, our bodies are kind of naturally made that it can produce cancerous cells. So anyone can get cancer. We need to be, kind of prevent it and diagnose it early if it happens. Dr. Sikha Sarma.
So first thing I would say is that eat natural and organic, because pesticides and chemicals are going to harm our bodies, and they are leading causes of mutations. Second thing I would say, get enough sunlight, because sunlight is very, very important for setting our rhythm and also protecting against many diseases. Third thing I would say is that for fiber, start eating natural vegetables and fruits, which are at least 4 bowls every day. So the quantity is very important. The next thing
4 bowls.
4 bowls, yes.
Of fruits.
Of fruits and vegetables, yeah. Fruits, vegetables, salads, I mean, all. So that would be very important. The next thing I would say is make sure that any kind of processed food which you are eating should be limited to only once a week. I mean, ideally avoid it, but max to max once a week. The rest should be all natural. And most importantly, make sure that the oils you are using is not refined oils, but they are all kachi ghani oils, cold pressed oils, and they are not stored in plastic bottles. They are stored in glass bottles. That's really important.
Thank you so much. Thank you, Dr. Sikha. I'm sure this will help our audience to practice or start practicing some of the changes. Dr. Asha Nair, your quick remark.
Most of the remarks which I have gathered has been told by Dr. Vedant Kabra and many of them here. But to sum it up, the point which I would really love to stress, as Dr. Kabra told us, everything is your mind, right? The mind is a very strong factor. So even though we know that the patient is going down the lane, it is to be told them that you will live. You will live. Have a happy life. You will live. So it depends. So what I feel is as India or as Bharat is a spiritual land, I feel that calming your mind and your thoughts along with your protocol of going on prevention of cancer is a very, very important factor. Like Dr. Vedant had told, the yoga setup the spiritual line of thinking, and this all begins at home. And we are responsible for our young generations to do this. So I think that everybody can inculcate for the minds not to go behind anything. Okay, you can do your passion, you can make your kids anything you want or what they want, but the pressures, reduce the pressures and calm the mind. That's all what I want to give as a point, because all other points have been taken up.
Thank you so much, Doctor.
Yeah.
And these are the lines which has to be, kind of reiterated again and again. It is something which we hear always, but we forget. So, we need to keep hammering this. Dr. Isi Khosla.
Well, like you rightly said, so much has already been said, but I will leave it as a blessing. BLES, bless, eat better. What is better has been already identified very well by Dr. Sharma and all the other panelists. What is better is more vegetables, better oils, less pesticides, and more organic, all of that, and better fats. More diverse. Diverse is very important, because let's not forget that lack of diversity is a factor not only in human nutrition can be a problem, but even for the entire ecosystem. So don't just restrict yourself to one staple, wheat or rice. Have millets, have ragi one day, have jowar one day, have bajra one day, have rice one day. So that is also part of eating better. Eat less. Eat early, BLE, eat early, and S, there was a talk about chewing, so eat slow. That's something which we all need to work at. We are all, I think, guilty of eating in a rush, and so we need to talk about it. So that's really what I'd sum it up to. And just that very often we are suffering problems and which are chronic and not being able to resolve them through conventional therapy. So then it's time to what I say EDTS, which is begin to look at a food sensitivity. You may be reacting to some foods which you don't know. So start by elimination and maintaining a food diary. That's E, elimination, maintaining a food diary. Then go for a test if you feel that you're feeling better on elimination, and then seek professional advice. So that's what I'd leave it at.
Thank you so much, Ms. Khosla, for your doctrine of eating healthy. Dr. Salini Singh, your quick remark, man.
So I think the panelists have summarized it very well. And I'd like to just add that there should be food synergy. You must try and include all kinds of food in your diet, and whatever you're eating, it should be sustainable, because sometimes people go on to some kind of a diet which they cannot sustain for the rest of their lives, or maybe another 6 months or so. They'll reduce weight and for using a certain kind of diet, but then they give up. So that should not happen. So use common sense and eat something which is, sustainable, which you can follow up for the rest of your lives. And that will become a pattern. I mean, you should not be eating somebody's in the family eating something else, you're eating something else, then that doesn't create a synergy. The message doesn't go out clear to the other family members, especially the young children. So they should eat the same kind of food, sit together, talk. So that's the happy time of the family, and it reduces stress and increases communication. So they're likely to come back at the time when they want food rather than eating elsewhere, pizzas and burgers, I think. And also important is that the risk factors for cancers are not really something which are out of the world. These are the risk factors are common to other chronic diseases also. So you're not only preventing cancers if you're preventing these risk factors, but also many other chronic diseases.
Yes. Thank you so much, Dr. Salini, and all of you have summed it up very, kind of effectively, and I'm sure that the audience would get a lot of takeaway message. I would like to leave them with something which I always, end my program with. And I have made some little bit of modification after hearing today's experts, that eat healthy, sleep well and sleep in night. Or sleep at night, because that's where sometimes we are in the quest to watch more of Netflix or other OTT programs. Forget and make your body move, and make it move as much as possible. Dr. Salini said that don't count your step that you have done 10,000. I normally try to count. I try to kind of burn 650 calorie, and I stop there. I try to stop there. So make it move as much as possible, and keep giving your body and mind the daily dose of positivity, mind and soul, the daily dose of positivity, because that is going to help you have a better mental health, which is also the critical part of keeping your overall health and well-being. So thank you so much, all of you, Dr. Salini Singh, Isi Khosla, Dr. Rasha Nair, Dr. Sekha Sarma, and Dr. Vedant Kabra, for your time and for sharing this wonderful knowledge and insight for with us and with our audience. I will now move on to our next panel, which is on the palliative care, another major important aspect, where the curing is not the only thing. You have to kind of make the people who are having cancer or any other disease to even live comfortably, and palliation is one important aspect there. So my colleague and veteran media professional Anisa Nair Dhawan will be moderating the next session. So over to you, Anisa. So much.
We are live now.
Personalized medicine, also called precision medicine, plays a very important role in the treatment of cancer. This treatment is based on your genes and your specific disease, which maybe can impact the behavior of cancer and how the treatment works against it. And by understanding a patient's genes, oncologists create a custom-designed treatment plan, which turns out to be more effective. This is one of the issues that we will be discussing in this session. Another very important issue that we're going to discuss is palliative care, which is often associated with end-of-life care for patients with advanced cancer only. But the truth is that all cancer patients need this type of care. Its goal is to improve the patient's quality of life. Many times it's not possible to give cancer patients curative treatments, but much can be done to prolong their lives and make it worth living. Even for those with early stage cancer, palliative care can be used to help prevent and relieve symptoms and side effects related to cancer and its treatment, such as pain, nausea, and fatigue. In India, what we're discussing is who's responsible for palliative care. India only has a ratio, which is doctor to patient ratio, about 1 in 2,000. So do cancer centers have enough doctors, nurses, physician assistants, counselors, and dietitians to ensure that cancer patients have access to pain and symptom management and receive emotional, social, and spiritual support? These are some of the issues that we will be discussing today. Please welcome our esteemed panelists who will be discussing these issues. We have with us Dr. M.R. Rajgopal, Chairman, Pallium India, and Director, WHO, Collaborating Center for Training and Policy on Access to Pain Relief. Please welcome Jyotsna Govil, Vice Chairperson, Indian Cancer Society. Please welcome Dr. Shushma Bhatnagar, Professor and Head Department of Onco Anesthesia, Pain and Palliative Care, AIIMS, New Delhi. And Dr. Zareen Delaware Hussain, Managing Director and CEO of Integro Pharmaceutical and General Secretary of Palliative Care Society, Bangladesh. And also please welcome Dr. Sai Priya Tiwari, Consultant, the Department of Pain Medicine, Manipal Hospitals, Dwarka, New Delhi. Thank you all for joining us for this session today. It's a real pleasure to have all of you with us. Palliative care is very, very important, and let's start with that first. Dr. Rajgopalan,
what in your experience works best for patients? Do they trust their immediate doctor, and hence that is where palliative care needs to flow from? Or do we need specialized personnel to help patients manage pain, nausea, and other side effects?
Thank you very much. Do we need specialized personnel is the question. And when you talk about specialized personnel, you usually think about some high-tech, highly qualified, super specialized doctors. Is that what you mean? Palliative care is treatment of suffering. Sorry, I didn't. I mean, like, I was not really waiting for an answer.
So please go ahead.
I was just raising that question to the whole audience. Palliative care is really treatment, prevention and management of suffering. And suffering is not only physical, it is also emotional, social, financial, spiritual. So, to treat cancer, we certainly need very specialized treatment. True, absolutely. But to relieve suffering, we need human beings with compassion. And much of the suffering can be taken away if there are people who are trained to give counseling, medical social workers. And think of the cost. Think of how much it will cost to get a super specialist doctor. How much will it cost to have 10 medical social workers available to look into patient's eyes and see, you seem to be worried. Would you like to talk about it? And when we do that, certainly I'm not saying that palliative care doctors are not needed. Palliative care doctors are also needed. And we certainly need doctors and nurses to look after the physical elements of suffering. That alone will not be enough. But without that, no psychosocial suffering is possible. If somebody is doubled up in pain, they certainly need to have that pain treated. If they are finding it difficult to take a breath, that breathlessness has to be treated scientifically. And usually you don't need high-tech treatment for that. As a matter of fact, much of the high-tech treatment that's now used for people with breathlessness are counterproductive. And so what am I saying? This is really about treating symptoms and also offering psychosocial support. All of this has to happen together. And this has to start from the time the patient first appears. In the ideal world, healthcare world that we see, when the patient comes, there will be somebody to evaluate symptoms like pain, psychological issues, social issues, spiritual issues, financial issues, and customize treatment, oncology treatment, to suit that reality. Thank you.
Right. Right. Very important points made by you, Dr. Rajgopal. Jyotsna ma'am, you have seen so many cancer patients in your life. What is the role of palliative care? Is there a greater understanding? Because, you know, at one point we want to remove the fear of cancer, but then the treatment also has to be humane. How much progress have you made in that field?
I think we made a really good beginning by getting people to understand that palliative care is not end-of-life care. If they understand that, they are then willing for a palliative care nurse or a paramedic or social workers or even emotional support workers like us to come in and work with them. And we can do that right from the beginning of treatment. If we are made partners in the care of patients by the doctors. I come from the Indian Cancer Society, and 30 years ago we set up an emotional support group called Cancer Sahyog. Please mark the word Sahyog. We are not leaders and we are not followers. We walk the path with the patients. So we wanted to be able to hold their hand and to reassure them. Our volunteers are cancer survivors. They have been down that road. So when they tell a patient, don't worry if you lose your hair, it comes back, or your skin will clear up, or whatever reassurance they need, which is non-technical, I think they are providing a very strong service because a relaxed patient accepts treatment better.
Definitely. I want to check with you, Dr. Shushma. Jyotsna ma'am is saying that the outcomes are better. Is it because if you're more sympathetic, then the patient stays the course and completes the treatment, and that effect affects the outcome of the treatment?
So, thank you very much. First of all, what Mrs. Jyotsna is saying is absolutely correct. When we are a patient, imagine what we will like to have from a doctor. We want to know what is happening to me and what is the realistic hope possible from the treatment. So these are the two things which we want: honest information and realistic hope. We don't want a false hope that I will be cured or something, because a patient is quite intelligent and they understand that their condition is constantly deteriorating. Now, if a person or doctor or a nurse or a counselor or a volunteer, if they will go and make them understand that what is the status of their disease right now, and these are the treatment, when they make the goals of care, that this is the treatment, from chemotherapy is possible, whether radiotherapy is possible, whether radiotherapy, chemotherapy has no role, and only symptom management we will provide. They want assurance from all these. And see, I always tell my residents that patients are very brave. They understand everything and they take everything very, very bravely. Only thing, doctors and nurses and the people, those who are surrounded by them, are not brave enough to explain them properly. Once they will understand that this is my status, they will make this a baseline. They will make this a baseline that I will not be able to take solid food, I have to take liquid food, and then I will be getting radiotherapy. So they will make this baseline and they will start imagining their life after that baseline. Only thing, we need to explain them properly. This is the lacuna in our medical science, that we offer them a lot of treatment, but we don't give them a realistic hope, and we don't give them a two side of the coin, that this is what we are planning to do and these are the possible side effects and this is the way we are going to treat you. So this is very important, that explaining them, making them brave, making them understand that what is happening to them, and they start believing and they start taking treatment. They will go for chemotherapy. I have seen patients, they are ready for everything. Only thing, they say that I don't want permanent colostomy, I don't want permanent tracheostomy, I don't want permanent rice tube in my. If you are offering me any of the treatment which will not give me permanent, they think I am ready to take everything. So you have to explain them properly, and then your life will be very, very easy once explained. Once you have an option that my patient is like this, and this will be fine.
All right. So, Dr. Saipriya, why are doctors not able to do this then? Explain, call a spade, and explain to the patients what options do they have. Do doctors sugarcoat stories for cancer patients? Are they concerned about the reaction a cancer patient may have, or whether they will complete the course, or are they understaffed? They don't have the time to explain all of this. Where is this gap?
Good afternoon, everyone, and thank you very much for that question. And first of all, I want to say that I'm extremely humbled to be a part of this esteemed panel. And yes, taking the question forward, you are absolutely right in saying that when the time comes to break bad news, it is delivering this diagnosis, and extreme prognosis is always delivering bad news. So when the time comes to break bad news, most doctors honestly are scared of this part of their job. Because it's very easy to make, not very easy, it's much easier to make treatment plans, but it is very difficult to communicate it to the patients honestly and empathetically. And this is a part of medical training which I feel is lacking even during our undergraduate days. And we learn this art of communication as we go ahead. So yes, doctors are scared of breaking bad news, and sometimes they do try to sugarcoat it, or sometimes they tend to give over information without realizing that the patient has understood what has been told. Sometimes a lot of medical language is used which the patients are not able to comprehend. So I think that your concern is very, very correct. And yes, all of us do need to learn the art of communication in order to, convey honestly the diagnosis and the true prognosis to the patients who have just been given probably the worst news of their life. And it needs to be done very with a lot of empathy.
All right. Dr. Hussain, I want to come to you. Dr. Saipria is saying that, in your undergraduate studies, you are taught medicine, how to treat, how to diagnose, and the basic cut and dry things. Empathy, support to the patient, these are not something that are taught to you. You learn on the job. But given the realities where the number of patients to the number of doctor is so skewed that you cannot expect the doctor to hold your hand, wipe your tears. There's so many more patients who have to be treated. So can some other people also help the doctor in this? If I'm a patient, I trust my doctor, but when I meet the sister, maybe she can be my sounding board. Can we have a system like this so that palliative care is empathetic?
Yes, ma'am, definitely. It has to be a teamwork. It cannot.
Dr. Saipria, the question is for Dr. Hussain. Please hold.
For me?
Yes, Dr. Hussain.
Zareen, right?
Yes.
Thank you so much for asking me this question. But before I even answer that, greetings from Bangladesh. And I will ask the moderator that before being General Secretary for Palliative Care Society Bangladesh, I have a different designation. I'm the MD and CEO of a pharmaceutical company. Yes, I've been a doctor for many, many years. I take pride in that, but I also take pride that I have changed my orbit. So coming to a question, yes, in our medical studies, when we are doing our undergrad, our MBBS, we are taught how to cure, how to treat. And there's no subject called death and dying or end of life care. So basically, death is taken as a failure of treatment. But over the years, when a patient goes through this kind of suffering, not only cancer, some life-limiting diseases, incurable, there is when palliative care comes forward. That is the time you realize as a patient that you need to live. But how do you need to live is the question. Take each day as it comes. So palliative care is a new subject, though it was there from ancient times. But I will say it is both art and science that we need to cultivate in our life of practice. Because when a doctor focuses, he focuses or she focuses on the treatment, but does he focus on the mindset of the patient at all? Are we thinking about the broader picture? We don't, because we don't have time. So we need assistants, we need palliative care assistants, we need nurses who can give that care and attention to somebody who suddenly hears that she has or he has got cancer. And how traumatic it is for that person. And imagine, and then her next question is, how long do I have? I mean, so we all can be a part of a consortium where we can break the bad news in a way, giving hope. And I mean not giving false hope, because false hope has no place in palliative care. You need to be truthful to the patient's family, and help her fight this disease. Help her live each day to the fullest. And that is the only way you can make her life or his life meaningful. I hope that answers your question.
Right. Thank you for your comments, Dr. Hussain. Jyotsna ma'am, I want to understand from you. You said, that the patient can hire a nurse who can help them with their palliative care. Now, usually in India, people don't take their health seriously. They only go to the doctor as the last resort, and they expect the doctor to do everything. Do people pay for palliative care? Can palliative care be done by other members of the society, their family members? Could they be trained? NGOs, many NGOs help you connect to the right treatment. Do they also help you with, palliative care and, getting the right drugs, administering the drugs and things like that?
Yes, I think, palliative care, as Dr. Rajgopal has said, just requires human beings with a big heart who can feel somebody else's pain and who can anticipate and empathize with those patients. People who understand what pain is and the role that it plays in getting in the way of your active treatment. So, yes, again, I'm coming back to the point that palliative care is not end of life care. It is not only end of life care. You have to understand palliative care begins from the day of diagnosis.
Exactly.
Maybe if you give the doctor a little time to work up the patient and get everything ready, but the doctor cannot just go on reports, blood profiles and MRIs. They need to know that the patient is ready for treatment, that the family understands what is happening. So any human being who can be trained to understand the nuances of medicine or where to draw the line, they are all palliative care workers.
Right. Dr. Rajgopal, I would trust my doctor the most, whether whatever be the diagnosis, however harsh be the treatment. Then should I also then turn to my doctor if I'm feeling stressed, if I'm having negative thoughts about the outcome of my treatment, if I'm in a lot of pain? Is the doctor the backstop for everything?
You are troubled by negative thoughts. The question is, should you talk to the doctor about it? Certainly. To the treating team. I hope that doctor will not just tell you, hey, you shouldn't think negative thoughts. Be positive. As if positivity is something that you can bring out there and put in there. You're not thinking negative thoughts by choice. The problem, unfortunately, is that in our education system, communication with the patient was not a subject. So the doctor, nurse, or any healthcare worker so far has not been largely not taught how to respond to that question. If I say, doctor, I'm feeling miserable, I would like that doctor to sit beside me for a minute at least. This is what the former editor of New York Times, when he was suffering from cancer, wrote, I want my doctor to sit beside me at least for a minute and connect with me as a person. And rather than saying, be positive, I should be asking, what is it that is troubling you most? Why are you sad? Talk to me. And if I do not have the time, maybe I'll get a colleague. Listen, see, so and so is very sad. Will you please stay with her and find out the matter? When I come back in a little while, we'll continue the conversation. I think we have to look into the person. And you were asking, should the patient be asking the doctor. They should be, but hopefully we will have a system tomorrow where the whole medical team is capable of handling that question.
Right, that will be the absolute ideal condition for all patients. Dr. Shushma, I want to understand from you, how far have we evolved when it comes to palliative care in our country and management of cancer patients who have, many side effects. Now, innovation in cancer treatment has seen that at least some of the side effects have reduced compared to 20 years ago, the kind of chemotherapy we had. Nowadays, it is better tolerated. But what has been the evolution of palliative care in our country? Do hospitals have proper systems of a counselor or other paramedics who may help with palliative care? Are healthcare facilities investing enough? If required, engage your local chemist or your NGOs to see that you stay the course. Have we evolved on all of these points?
Ah, I know this is a very tough question to answer, but definitely I will answer. See, palliative care is basically not something different of some special medical science. It is basically people know how to handle a human being and how to handle the side effects and the difficult symptoms. Only thing, whatever knowledge they are having, they have to extrapolate and they have to put this knowledge in the right context. Unfortunately, this is not there in the medical science, that it is required that we need to talk to the patient, we need to sit down with the patient for a minute and explain him. It is not there that if patient is suffering with intractable symptom, we have to treat it, because once we will treat the symptoms, then only the patient will be benefited. This is not there in the curriculum. We are extremely busy in diagnosing and treating means treating. Treatment means treatment till the end. We are afraid of the symptoms and we are afraid of the end. We think that end means we have lost something and this is our defeat. So this is not been, nobody has taught us this. Now, second question is, who will treat it and how, whether the whole country is equipped with it. I will say in the simple word that it is not there. In the major institutes of the country, major district hospitals in the country, there are not enough. I will not say that everywhere there will be palliative care physician or palliative care trained nurses, but at least we can reach out with the basic knowledge to the people, those who are available there. Again, I am saying that it is not necessary that palliative care physician should be there everywhere, but the knowledge of palliative care should be there in all the hospitals, in the district hospital as well as in the village as well as in the community, which is not reaching to the masses up till now. Although positive side, it has developed a lot. In last 3 decades, palliative care has developed a lot. Medical Council of India has recognized MD palliative medicine in 2012. But unfortunately, in 10 years or 8 years, 2010 Medical Council of India has recognized MD palliative medicine. But only in 3 institutes we could start MD palliative medicine. Similarly, the NDPS Act, there was an amendment that, based on the amendment, that morphine should be available in all the hospitals for cancer pain management. But this knowledge has not reached to the hospital. People still, they don't know that, oh, I am eligible to procure morphine, dispense morphine. Even the bureaucrat, even the drug controllers of the states, they are not aware of the recent amendment of 2018 amendment, that yes, we should provide more medication, essential medication to the hospitals, those are treating cancer pain patients. So, there is definitely a lot of things have happened, lot of good NGOs are working, good volunteer groups are working. Many of the institutes, I can say that 50-60 institutes of this country, they are giving very structured palliative care program all over country. It is now, the best part is that it has spread everywhere in north, east, south and west. So we used to say that it is basically in the south, but now it is there in all the part of the country. So the positive parts are there, but still I can say that structured implementation or structured dissemination of the knowledge is still not happening. Although again, Ministry of Health and Family Welfare has a national palliative care program, they have a dedicated
Right.
district hospitals, but there are a lot more we have to do. But many things have happened in last 3 decades. Indian Association of Palliative Care is working very, very hard that everything should go to the masses, and now we are making a directory of palliative care facilities all over the country. So it will be available that if a patient wants anywhere country, even in the village, he wants to know that which place I will get palliative care, they will be immediately getting the information that this is the place they can go and get the help and support from maybe in the terms of pain management or symptom management or counseling or something like this.
All right. So work is being done, and Dr. Saipriya, I just want to quickly get your input on what is the role of family in palliative care. Because emotional support is something that we also require as cancer patients, and because we have a strong family unit in our country, does it help in palliative care? What would you tell family members to do? Because at one point, the costs are so high, so the family feels, how are you going to do this? The patient feels, my family's going to blame me. I can't reach out to them. So what role will the family play?
For the family plays a huge role. It does. And believe me, when a patient is diagnosed with cancer, it's not just the patient who is diagnosed, it's the entire family who bears the consequences of it. And caregiver stress and caregiver burnout is a very, very real thing. It's very much there. We often focus on the patient and the psychological distress of the patient alone, but the family and the caregivers are also very, very stressed, and that also needs to be identified and addressed. So in palliative care as a philosophy, we never treat the patient alone, we treat the family as a unit, and it is our duty to understand the kind of stress that they must be going through. And in our country, I think it's a blessing that you said that we have very rich family units. In most of the cases, that is a blessing because there are so many people who can take care of the patient who is suffering. Sometimes it leads to a bit of a problem if the family is not able to reach a consensus about the kind of treatment that needs to be given. But usually that problem can be tackled. And by and large, I think the family plays a very, very huge role in caring for the patient. And, as Ms. Jyotsna has been saying, that anybody can be a palliative care provider. You just need to have empathy. So I think the family plays a huge role, definitely.
I also want to talk about the advances in sciences and how treatment of cancer is now more tolerable because now you have some kind of specialized treatments which are targeted treatments or drugs that treat specific genes that help your body respond better. Dr. Hussain, I wanted to understand from you, when it comes to personalized treatment of patients, what is the step involved here? How do, because if I want to have personalized treatment, will I have to cough up more money? Will I have different diagnoses? Will my treatment be delayed? How does it work? I think we're having a problem with the connection with Dr. Hussain. Dr. Hussain, sorry, couldn't hear you. Could you please repeat?
No, I could also hear your question. There is some network problem.
Yes.
If you just could repeat it again.
Dr. Hussain, my question was about personalized treatment for cancer patients. Which cancer patients are eligible for this kind of treatment? Are some type of cancers more responsive to targeted treatment? Does this involve greater diagnostics, greater testing? And does this lead to any kind of delay in treatment or starting of the treatment?
Thank you so much for asking this question. In fact, the other day I was talking about artificial intelligence. So the advent of artificial intelligence has given us the opportunity to find out about my entire body, starting from my microbiome study to my DNA study. And when I go to a doctor, I'm talking about this in a modern world. I'm not talking about India or Bangladesh. So this personalized treatment that we are talking is based on gene. So when you go to a doctor, an oncologic doctor, and you are being diagnosed with a particular cancer, or even if you're not diagnosed, say for Angelina Jolie, I mean, she is a living example that she knew that, you know, she was to get breast cancer. And how did she know? Because she has done that the microbiome study, the DNA study, and that's how they found out. So that is one prevention kind of a treatment. Now, when you go to your doctor in the modern world, the way science is approaching through artificial intelligence, you get to know about your entire genome study, that what is specific for you. Have you, if you were to diagnosed with the cancer, then the oncologist, according to your gene and according to your DNA study, according to your microbiome, will give a personalized therapy. And today, if we look at the world, cancer therapy has made advance in leaps and bounds by target cell therapy. If I were to name the top selling drugs of the world, we will look that oncologic products are the top selling drugs of the world, and they constitute 155.4 billion. And among them, if we talk, say for example, if I were to say about MAPS, it's a drug, it's an immunotherapy drug. So this drug in the Western world is $4,000. In India, it is made and it is sold at 99,000 rupees. In Bangladesh, there is no manufacturer who can manufacture this drug. So if we, in this region, in this part of the country, India, Bangladesh, Nepal, Sri Lanka, if we were to talk about our masses, this is next to impossible unless we bring India, because in our country, in Bangladesh, the labor cost is low, the utility cost is low, but India has the technology, they have the R&D. If we can merge together, then we can break the patent, because Bangladesh does not fall under any patent law due to TRIPS. We can break this patent and join hands with India and come up with target cell therapy. And we can give it to government hospital at subsidized price, so that every patient who needs to have this kind of target cell therapy can avail that at a very subsidized price. Having said that, I don't want to say that we are a charitable organization. Yes, we will make money through export, but for our country people, for our masses, we want to give them a subsidized therapy where they will benefit. Because in the Western world, today cancer is not looked upon as a killer disease, a chronic disease. Thank you.
Dr. Rajgopal, in your experience, targeted therapies are relatively new. What percentage of patients are undergoing these treatments, be it the targeted treatments or the pharmacogenomics that are used to determine how well a drug works for you and how safe it is for you, and what's the best treatment for you? How many patients, as a percentage of the total cancer patients, go for these kind of treatments in India?
Sorry, I'm not an oncologist. I'm a palliative care doctor. This question certainly should go to an oncologist, and I wouldn't be competent to answer this question. But I would just remind you to think about what tiny percentage of Indians would be able to offer this. And before you come to the answer, I would like you to remember that in our country, 55 million Indians are pushed below poverty line by catastrophic health expenditure in 1 year. But sorry, I am unable to answer your question.
Jyotsna ma'am, could you give us some data there? Because, for a cancer patient, all over the world, actually, cancer treatment costs are prohibitive. In India, you could become destitute because you have to take a cancer treatment. Now, we are making strides by having the Ayushman Bharat program where cancer is also covered. And many state governments have their health plans where they are giving chemotherapy, etc., at a very reasonable cost for people to be able to afford it. So where does targeted treatment fit in our context? How many people have access to this, and how can this improve?
Nisha, I don't think too many people, I don't have statistics either, but I completely agree with Dr. Rajagopal when he says 55 million Indians a year are being pushed under the poverty line. It's the same, I think, in Bangladesh as well, possibly even more. But the fact of the matter is that we do have chemotherapy drugs which are cheaper, made in India by Indian pharma, than it is when it is bought as a patented drug. The problem arises because many doctors tend to downplay generic drugs and Indian pharma. And it's only now that the medical schools are also accepting that Indian pharma has reached world standards, and in fact is a pharmacist to this part of the world, to to Afghanistan, to Pakistan, India, Bangladesh, Sri Lanka. All of us are trying to get drugs from local resources which are cheaper than the Western drugs. So it's a matter of perception, and this is where I think that the media plays a very big part. You need to educate everyone about the fact that drugs can be made and are being made and are made available at very competitive prices. Even at those prices, we see people who come to us in absolutely dire straits. They tell us they have sold their house or they've sold their jewelry. What else can they do? They come from wherever they are to a city like Delhi. They come to an organization like the All India Institute of Medical Sciences, hoping for a miracle to happen to them. And there are very wonderful doctors. Sushma Bhatnagar, I know, is one. We have sat in on her clinic, and it is really an education in the art of listening, which is such an important part of the art of communication. It's what Dr. Rajagopal also has been saying. Learn how to listen to a person. And only then, that is your most targeted therapy, frankly. All the drugs in the world do not replace that human touch and the art of listening to somebody else and to absorb what they are saying. I don't know that it answers your question.
Right.
You're
Definitely. Yeah,
technical information, which I think this is the wrong panel for, frankly.
Okay. Dr. Shushma, let me then come to you. My Marcy had, she had lung cancer, and she also underwent targeted treatment. Now, I would say that only extended her life, and ultimately she passed away. So, how do we look at targeted treatment, and what is really required in our country? You need simple, common drugs to treat people and give them good outcomes. The only condition being that they come early. What is going to work in our country?
So I think you have asked a very, very relevant question. First thing, definitely we have to work hard, and especially media will have to work hard that they should come as early as possible, because definitely there are many cancers are there. Those, if diagnosed early, definitely they have a cure possible and they have a significant survival possible till the end. One thing. Second thing, there is a role of chemotherapy agent, and which are definitely in this present government, they have done a lot in making it cheaper for the patients. those drugs are definitely now patients are affordable. The patients are getting them, or hospital are giving them free of cost. So this is again second thing. Regarding targeted therapy, I see at least once in a month a patient whom oncologists have prescribed targeted therapy. But fortunately at AIMS, scenario is different. When they prescribe targeted therapy, we are seeing this patient long time before. Means like when targeted therapy is prescribed, most of the time patients are in the almost in an advanced stage. But this does not happen at AIMS. Patients are our patient already long time before. Maybe we knowing this patient 6 months before, 1 year before. So they come to us, they again talk to us, and sometimes even the oncologists come and sit down with us, and they want to talk to the patient in front of us that I am going to prescribe this medication, whether can you consult this patient about the treatment. What they want me to talk to the patient that what is the realistic hope possible with the treatment. Once you will explain the realistic hope, because nobody wants to live longer at the cost of quality of life. So once we will tell them that this is the realistic hope possible, you will may survive 6 weeks more, or 6 months more, or 2 weeks more. I think they are able to design and they are able to decide. So this is what is required in all over country, that in the hospitals we have to make a combined decision. We have to discuss diagnosis, prognosis. We have to discuss the outcome possible, realistic hope possible with the patient. Patient should be an important party on decision making. And once they understand, they decide that I need to take targeted therapy or I don't need to take. Only if you will say that targeted therapy I am prescribing, this will postpone all your life and this will give you additional life, they will definitely take. They will sell off their land, they will sell off their jewelry and everything they will do, if we will not explain them the other part of the targeted therapy. So fortunately in IRCH AIMS where I am working, this is a practice that in an advanced stage we are knowing our patient long time before. We talk to the patient, oncologists come to us, we sit down with the patient, we give them the both the sides of the and explain them, and that is why our patient number of patients, those who are getting targeted therapy, must be definitely less than what is going around in India. So I think it is required that we have to have a integrated plan, integration of this care which we are talking and discussing long time before. At the end, if somebody will prescribe targeted therapy, patient will take targeted therapy. They will never refuse. And I have seen when patients are taking targeted therapy, even the richest of rich person, they start getting really tired because it costs in lakhs of rupees per month, and it is not possible for a common man or a middle class family in India. Thank you.
Dr. Sureen, you spoke about artificial intelligence and how that also helps. You can determine genes, and AI and ML also helping in cancer treatment. Now, how much innovation is being done in countries like India, maybe other Southeastern Asian countries? Because we have seen, some progress being made on genomics. You can get those advanced testing done in India at a cost which perhaps a fraction of what you would do, because some doctors take samples, send them to the US, etc. So, to your mind, what is the outlook for increasing all of this, improving on the innovation required domestically? Because you said that Indian companies make generics, Indian pharma companies, Indian pharma companies also make biosimilars. What more needs to be done? Dr. Hussain, request you to unmute yourself.
I did. Firstly, about artificial intelligence, if I were to talk about it, yes, it is being done in the Western world. I cannot think of anybody doing in Bangladesh, or even if it's India, I think very few, I think top brass, probably they have gone through that of genome study, microbiome study, so much so that they're aware what their actual health status is. So it requires a lot of money. I mean, if I were to say that the modern world, how it's going, Every day when you wake up from your sleep and stand in front of your mirror, there is a sensor. This sensor will immediately tell you what is your blood pressure, what is your heart rate, and the mole that you have, whether it's a melanoma. It is as advanced as that. I don't know if you follow Bertil in Moscow, because I do have sessions with him. And trust me, when you do this genome study, you are giving your entire information to the cloud. When you're giving your entire information to the cloud, there are some people who would not like to give. But in this context, a poor country like Bangladesh, and I would say India is not as poor, but has a lot of population, as very rightly said, below poverty level at a certain percentage. How can you expect artificial intelligence to work there when they are deprived of the very basic drugs, very basic prevention method as to do their yearly checkup? I mean, that is far away. We are looking leaps and bounds, but let's come to what needs to be done to give them at least that medication that is required to sort of combat their cancer. Now, since I have worked in palliative care and I have been an anesthesiologist, to me, no matter how much drug or chemotherapy you do, at the end of the day, it is the human touch. Your one touch can boost up a person mentally and physically, because what you manifest in your mind, you will manifest in your body. So if I were to talk about artificial intelligence, I do not think right at this point in our country, it is on the need of target therapy come to Bangladesh or India or this region, so that masses can avail that at a very, very subsidized price. As I said, you can make generic, we can make patent. We can't make patent drugs because we fall under TRIPS. So I'm always telling India to join hands with us so that we can make these drugs and make it available to our country masses who are suffering from incurable life-limiting disease, as well as India.
All right.
So artificial intelligence, I wouldn't even go there, because when you're totally, you lack in the basic thing, how can you even think of something so advanced?
All right. So I'll take closing comments from our panelists, and very quickly, since we don't have a lot of time. Dr. Saipriya, all our panelists are saying that you need a humane response along with the drugs and the technology and the innovation. You're treating human beings, and it's very important on how you treat them as a holistic being, not just as a guinea pig who is going to be treated with X medicine. So in your closing comments, what do you think is the most urgent thing that needs to be done?
Most urgent thing that needs to be done?
Yes.
Okay, I think the most urgent thing with regard to palliative care that needs to be done is that we need to, create more awareness about palliative care, not just among not just among patients, among doctors as well, and among all medical professionals, so they realize what it is. Okay, and we need to emphasize the fact that when we are treating a patient, we need to treat the patient in totality, not just look at the physical aspects and not just look at the reports and the blood tests and the scans which are available. And I think, yeah, if we look at the patient and the family in totality, and if we are able to give this message across to as many people as we can and create more awareness about palliative care, I think that would be a step forward.
Dr. Rajgopal, what do you think needs to be done in our country to extend the reach of palliative care to everybody who needs it?
Anisha, if I donate my time to you, you mentioned a targeted therapy and cancer experience in the family. Do you think your family member received total care? Did it all make her live with some degree of enjoyment? Because your answer may make a good summary for the whole webinar.
Yes, Dr. Rajgopal, my Masi survived longer and she lived better and she had a better quality of life because of targeted treatment. I don't know the kind of counseling she received, but I'm sure her doctors communicated to her what she was going for and the impact it would have on her life.
So my closing comments would be that kind of affordable treatment. It depends on the family. The rich need not be deprived of care. The affordable treatment given with compassion and with the whole medical profession being schooled in the management of in communication and in psychosocial support and symptom control would drastically improve things. Thank you very much.
Dr. Shushma, what would you like to say in your closing comments?
Yes, Anisha. Anisha, I think this is important to teach communication, humanity to all our undergraduates, doctor, nurses, and because they are going to be the young doctors after some time and they are going to lead the country. It is important to teach humanity to all our doctors because humanity is a wonder drug and I think they are not using humanity in their day-to-day practice. And if they will amalgam this humanity with their own knowledge, what they are reading and writing in the medical curriculum, I think it will be wonderful for the patient because ultimately we are teaching human being and they need human touch. So we have to teach them that humanity is a wonder drug. It does not have overdose and it does not have underdose. We can use humanity as much as we like. Thank you.
That's really very pertinent. We can use humanity as much as we like. Jyotsna ma'am, for many patients, they see God in doctors. So we expect them to be humane. What more needs to be done? What would you like to say in your closing comments?
I think that the days when patients saw God in doctors are sadly over. The patients see God in Google. They go to Google, they find out a whole lot of things. They don't know how to navigate their way through that. They come back and they spew all this pseudo knowledge at their doctors. That irritates the doctor, and the end result is that neither the patient nor the doctor is happy with that consultation. So my message would be, trust your doctor. Don't keep shopping around all the time. When you found somebody, stay with that person, trust that person, and build a relationship with that person. For the doctor as well as for the patient. That's where humanity comes into play. And if the doctor has the humility, I will add humility to humanity, to be able to accept other views from a nurse who sometimes is far more experienced than the doctor himself or herself. And if they can accept that other people also have some knowledge, which may add to the patient's comfort, we would have a much happier system. Then Google can be safely put to bed. Thank you.
Right. Dr. Sen, very quickly, your closing comments. We've heard about the need for humanity and the need for humility from the doctors as well, and how the entire ecosystem can work together to help patients get good outcomes and feel comfortable. What would you like to say in your closing comments? Dr. Sen, would request you to unmute yourself, please. Dr. Hussain, we can't hear you. Can you unmute yourself, please?
Anisha, if all the consultation rooms had a beautiful garden like the one behind you, I think we'd instantly have more relaxed doctors and patients.
I think that should also be part
sorry,
of our
I just missed your. Can I talk?
Yes, yes, Dr. Hussain, please go ahead and give us your closing comments.
So there are 3 myths regarding palliative care. Because when we talk about palliative care, you know, somebody who gets admitted in palliative care says that the 3 Ds, dead, dying, and death. So palliative care does not mean that you're dead to die. It surely doesn't mean that. People need to be aware. People need to be aware of what actually palliative care is. I'm so sorry, my connection is really, really bothering this time. People need to be aware what palliative care is. And palliative care is not necessarily a doctor. It can come from the community. You can build a compassionate community. You can build a compassionate society. Because what the person needs is hope to live a dignified and quality life each day as it comes. Take each day as it comes and make the life worthful, not add days to life, rather life to days. So that is what I want to say in my closing remark. Thank you.
Thank you to all our speakers for joining us today and giving us a bird's eye view of palliative care, the importance that it has in the treatment of cancer patients in our country. Thank you so much for joining us. Thank you, Dr. Rajgopal. Thank you, Jyotsna ma'am, Dr. Shushma, Dr. Hussain, Dr. Saipriya. Thank you so much for joining us and sharing with us your thoughts and views on what is happening in palliative care in our country. Thank you so much.
Thank you, Anisha. Thank you.
Topic of discussion, and this is the access to healthcare, something which some of our speakers have spoken about, and how the prohibitive cost of cancer care sometimes also leads to many unintended effects. You want to treat your patients, but the cost sometimes turn them away, and they are not able to afford that care. So in this session, we are going to be talking about improving the patient's access to cancer drugs in our country. Now, affordable and equitable cancer care is one of India's greatest public health challenges. Affordability is often cited as the cause of poor or no access to cancer care, leading to even deaths. Now, while national governments, the question being asked is, should national governments shoulder the main responsibility of putting cancer care systems into place? Do pharmaceutical companies also have a unique role to play here? Now, in this session, we will discuss how India's pharmaceutical industry is improving the access to cancer drugs in India and making them more affordable. Now, the WHO has estimated that, on an average, every year we see 10 lakh cases of cancer being reported in India. And the mortality rate is not very good. Nearly half of them will die. They will not make it beyond a very long time span. And sometimes the access to healthcare also plays a part in the high mortality rate. These are some of the stats that I've seen on the internet that on a national level, the average cancer care expenditure is upwards of 1 lakh rupees. And here, 90% of the total cancer care cost is medical care, be it doctor's consultancy, be it the drug cost, be it diagnostic testing, imaging services, and only 10% of the total cost is spent on transport, on food, on place to stay, etc. Now, our government moved ahead and brought in price control to see that the drugs are readily available to patients who need them, even cancer drugs. About 42 anti-cancer drugs were put under price control, and here the price, the way the price fell was up to 95%. The price fell as much. So in this session, I'm going to try to find out whether Is this the model that is going to work? Price control, so that you forcibly hold drug prices down, and the drug companies are forced to reduce their prices when it comes to cancer care. How will innovation happen? Will we get newer drugs? Will drug companies then invest in drug discovery if somebody is going to tell them that this is the price you're going to sell at? So we want to understand how drug companies are doing their bit to increase the access of cancer care in our country. We have some distinguished speakers who are joining us now to share with us what progress is being made in this field. Please welcome Mr. Uttra Kumar, the head Market Access and Alliance Management at Novartis Oncology. Please welcome Dr. Piyush Bajpai, the head of Medical Oncology Sciences, Manipal Hospitals, Dwarka, New Delhi, and Dr. Ajay Sharma, the head of Government Affairs at AstraZeneca. Good afternoon to you, gentlemen. Thank you so much for joining us today. Mr. Kumar, let me come to you. Now, I've already touched upon price control. Now, a lot of people say, oh, price control has made it so much easier for us because drug prices are so much lower. Now, generics are the answer because in a large country like us with limited resources, generics could be the answer to many chronic diseases. Now, what role does price control play? And does that really improve the access of healthcare?
Thanks, Anisha, and thanks to you and IHW for setting up this event on World Cancer Day, and thanks for hosting this panel on improving patient access. And thanks for setting up context and a very relevant question on the role of price control, the role of generics. Maybe I may take a step back before I answer that question. Right now, cancer as a therapy has had a lot of advances over the last 50 years, and it's also the one of the fields in which there's the significant part of pharmaceutical R&D investments is going in, and hence we can see a pace of innovation, pace of new drugs coming up. Right now, both innovative medicines as well as generics have a role to play in the treatment of cancer. Right. So when a company innovates, does R&D, brings a new drug into the product, it adds value to the patient's lives. And that is a premium that the company charges for this innovation that's being brought into the market. Over a period of time, as the protection of this product reduces, you have generics coming in, which tend to bring down the prices. So innovative medicines and generics are two essential and complementary components of the pharmaceutical industry. Now, both kind of medicines are used in different contexts, different settings, and as a lot of panelists over here, as well as the audience might know, that in cancer you have different lines of treatment. Right now, a lot of new hue and cry has happened around price control. Right, whether price control is good or not, one thing which is clear is that price regulation is good. Now, the kind of price regulation determines how suitable the market is for bringing in innovation as well as to manage access. Right, these are two things that need to be kept in balance. So from a pharmaceutical company perspective, one of the key things is that the drug prices in India are among the lowest in the world. A lot of pharmaceutical companies have varied pricing, and especially the pricing for India is typically much lower than what we see in developed markets. Right. On top of that, there's also further work that happens by the industry on improving access to assistance programs or partnering with various institutions on being able to get products included in formularies and have them provided to patients. I get a lot more, but I think I'll stop here for now. I hope I've been able to answer your specific question.
Yes, Mr. Kumar, we'll come back to you for more inputs on how access can be improved. Dr. Sharma, let me come to you. Now, Mr. Kumar is saying that there is a role of generics that they will play, but there has to be some reward for the risk pharma companies take for innovating new drugs. Now, Dr. Sharma, what is the way ahead? Because drug companies can work with the government in India. Already, drug prices in India are lower. See, cancer care is expensive around the world, but chemotherapy cost in the US is much, much higher than what it is here. There is a reason for it. It has worked in a way that, even in government hospitals, cancer chemotherapy treatment is not very costly. So what is the connect and the synergy that drug companies can do with healthcare providers in developing countries like us? There is a model where you charge more premium in those who can afford it in developed countries. So how do we go ahead here in less developed countries like India?
So Anisha, I think it's a very loaded question. It has multiple facets. Let me put that way. It's not a simple answer which I can give on this panel, because what you have asked is a very pertinent question. Cost of care. See, we have to all understand that healthcare has always been an unwanted cost. So it's not a cost which I take it willingly. So till the time that negativity of unwanted is attached, we always face this challenge that how do we get the cost lower. And this actually intrigues me. Imagine in our country where we are talking about healthcare which should actually be the best. Instead of demanding for the best, what are we saying? No, we want the best, but we want it at the lowest cost. How the two goes together. Whatever access model we try and talk, if we say I will allow all the equipments or ingredients of NCDs which actually create NCDs, let's say liquor, tobacco, it is out of price control. I'll keep increasing a sin tax, but I'll keep it out of price control. But the things which actually saves lives, it should be under price control. Where will this take us? And we have been seeing the impact of price control. So you're right that pharma companies with the healthcare providers will have to look at newer innovative access models if we want to continue the innovation pipeline coming to the country. And that's where I have seen brilliant models which has been actually created in the past. So since Uttaras from Novartis, they have been doing brilliant job on sickle cell anemia recently. In the past on rare diseases, Takeda, one of the companies, has been doing brilliant models where they actually even, a simple reimbursement also needs a lot of push for a rare disease in the country. So they have been doing some brilliant job with the patient assistance group out there with a few of the healthcare providers where they have even knocked the doors of court to make sure that the patients who really need those drugs get a funding mechanism created. Hemophilia, it was non-reimbursable. Today, almost every state in the country does hemophilia reimbursement. So yes, there have been instances in the past. Unfortunately, in cancer, the focus has not yet dawned upon, because largely the country is still NCD care is heart and diabetes. I think that's where we are stuck up with. But yes, I do see a huge potential of pharma companies collaborating with healthcare providers, even patient groups. So I would add another layer there. But there is a huge potential where India can be shaped in the next decade by the collaboration between these three.
All right. So, Dr. Sharma, we will discuss at length the initiatives being taken by drug companies during this discussion. Dr. Bajpai, I'd like to come to you now. India is an underinsured company because in the US, while treatment is expensive, it's usually, or a large part of it, is covered by insurance. Now, when it comes to getting admitted to hospital and taking the, and paying the bills, most of the bills are out of pocket in our country. Most of the patients pay out of pocket. Very less insurance coverage is there. So what is the way out? More insurance coverage, lower pricing? Because if I go to a government hospital, I'll have to wait a really long time to be able to get that cheaper medical treatment. But by the time my time comes for the treatment, my case may have really deteriorated a lot. So where is the balance? I don't have the money for immediate treatment. And if I wait too long, my case is worse than it was.
Yeah, thank you, Anisha, for this question. Well, this is something I think so which the policy makers have to look into. We are, struggling with expanding our insurance base in India. Now, this year's budget probably has something for the health sector. Hopefully, this is what is some important changes which the policy makers need to now look into. So this is important, and this is a policy-based decision which has to come. Cancer is definitely one of the major non-communicable diseases which is going to be in epidemic proportion in coming times. In 2050, what figures we are seeing, it's almost tripled of what probably would be. So the burden is going to really increase. We are going to see more of patients. The challenges will increase. Of course, insurance, increasing the insurance cover is important. The number of percentage population should be insured. Having said that, with the current situation today, I think so. In India, we are lucky to have generics. We have good, patient assistance schemes from the companies, various innovator companies. So that is there, but still a lot more needs to be done. We are waiting for several molecules which are actually, life-saving, can extend the life, which have not actually entered the Indian market. So these aspects are important. So we do have Indian generics and we do have good patient assistance programs, but there is a lot more to be done. I think so. Yeah.
All right. Mr. Kumar, in an ideal world in our country where we have adequate number of hospitals and patients don't have to wait too long, and we have many generic drugs of cancer care treatments, this ideal world will take some time to come. Dr. Bajpai mentioned patient assistance programs. What are these programs? Dr. Sharma spoke about the work Novartis is doing in sickle cell anemia. Could you tell us what that is, and how can you connect with patients, drug companies themselves, to help improve their outcomes even if they don't have the means to pay?
Sure, Anisha. Maybe, well, Dr. Rajesh talked about sickle cell anemia, but that's something that's an area in which we just entered into. Maybe I can talk about another drug and another program, which is something that we've been proud of and something we've been sure for almost 15 years now. This is about the drug imatinib. So imatinib was one of the first targeted therapies for blood cancer, specifically for CML, chronic myeloid leukemia. Right? And when Novartis launched this product, way back at 15 years back, there was a lot of discussion about the accessibility of low middle income or low income countries to this drug. And at that point in time, Novartis took a bold bet that anyone who requires this drug would get it free. Right? And for 15 years, we've been supporting thousands or tens of thousands of CML patients across the world who don't have affordability to access that drug free. Right? So this was the first experimentation that we've had with a kind of a access program, right? Obviously, this kind of programs have their own merits and flaws because your drug is just, as you had started off saying, that in an ideal world, right? So the drug is just one part of the entire health system that's required to treat a patient, right? And providing the drug free does not solve all the problems. For example, we still realize that there are gaps in diagnosis, there are gaps in treatment, there are gaps in the accessibility, right? For example, in India, the treatment centers are clustered around very few cities, while the patients come from across the country, right? How do you bridge these kind of gaps? So now, going forward for some of the other diseases, the work we are doing is more on partnering with the health system, being able to bring in insights from experts as well as from other world-class centers and helping facilities in India to adapt to it, to be able to improve patient outcomes. So that's the kind of work we are looking at going forward, which is working as an integral part of the health system and being able to support them to improve capacity and capability to treat patients, and not just treat patients. Maybe starts off from diagnosis, starts from screening in a lot of cases, right? And so that's the kind of work we are now moving towards as an organization.
So, Mr. Kumar, how have you done this? Have you worked with governments? Have you worked with NGOs? Have you worked with hospitals? How have you done this with this particular drug, where your company decided to give this treatment free, and you have covered thousands of people? what is the way of doing it? As a patient, how do I know that this company has such a plan, and perhaps I can request for my treatment to be done on this plan?
Okay, so again over here, I would say that there are different models of operation, right? So while I talked about the program for CML where we have been giving the drug free and mostly it's been directly to patients, there are also other programs that we've done on leprosy, malaria, tuberculosis. These are some of the flagship programs that we have, where we have been providing drugs free to governments in Asia and Africa, primarily through a WHO-run program, right? So there are different models of operation depending upon the kind of partner you have, depending on the kind of disease area and the kind of health infrastructure that's available.
All right. Dr. Sharma, you did talk about price controls and how the government will only tax tobacco products or liquor products, but not put a price control there. There isn't enough disincentives for the wrong things that lead to disease, but what cures disease has, many, you try to control that. Now, what about taxes? Because cancer medicines are usually high price, tax rates would net the government a lot of revenue, right? And I guess GST on drugs, especially cancer drugs, is another big point.
So absolutely, you actually pick up the right buzzword and right advocacy tools which we have been pushing, Anisha, and this is something which we have been telling the government. At one end, you say we do price control, but under the same price control, they make 12% as a GST, and that includes cancer drugs. Huh? So imagine someone who is, when the government says, your, I mean, when the patient says the cost of treatment is 2 lakh rupees per drug, I mean, out of that 24,000 goes to the government kitty. And I would have still understood if that 24,000 would have been rerouted in the benefit of the healthcare. So one of the things which we all been seeing today is a 147% increase in healthcare budget. That is not actually the number. So if you really see, the real increase has been in the Ministry of Health budget, which is from 59,000 odd crores has gone to 65,000 odd crores. And largely, if you see the amount of payment which happens from all of this goes to people's salaries. So almost 60% goes in people's salary. And this is not my data. One of the data which came up from the government portal itself said that the total state and center procurement of medicines put together is not more than 18,000 crores. And the entire pharma market in India is almost 1.4 lakh crores. So imagine the share of purchase of medicines which the government does. So that's what I said. Now, if the taxes which you are if you are collecting, I mean, for an industry of 1.4 lakh crore, a 12% tax rate in itself is 18,000 to 20,000 crores. Even that, I would say, not coming to purchase medicine in the country. So you have a tax, but that tax probably goes in funding infrastructure and other places, and it is a shame that the government of India, the policymakers who talk about price control for everything else, are not ready to leave their 12% kitty of GST. And if that can happen, I think that could be one big area which will push, because imagine for a poor cancer patient, 11 months of therapy and 1 month of therapy free. I mean, it's that kind of push which can be achieved. So yes, I would say that this is something which we as an industry should come forward to. And there have been in the past instances where medicine taxes have been 0 or 5%, and probably that same should be extended to cancer care medicines as well.
Let's hope the government, does move to a tax rate which is affordable for all cancer patients. Dr. Bajpai, what would you like to say on how patient access can be improved in hospitals? At your hospitals, would you offer any treatment at below market rates to people who can't afford it? How much can you scale this kind of, charitable work or whatever minimum that you are either obligated to do or you want to do on your own? How can access improve in such a fashion?
So there are 2-3 aspects to it. I mean, it's One thing is that with COVID times, we learned how to use telemedicine optimally. So we realized that somebody who has to travel all the way, probably for certain things, if we can actually develop the hub and spoke model, a lot of travel costs for the patient gets cut down. If we can ensure that if we have the facilities, what we would actually deliver in a main center, a tertiary care center in Delhi, if that can be carried out in a peripheral city or a second, third tier city, why not? That cut downs a lot of cost for the entire thing, the entire treatment, number one. Number two is, so telemedicine is definitely playing an important part. Number two is that, as I mentioned, that there are generic drugs, and this is something, a boon for Indian, which we have the Indian healthcare system. Apart from that, as I said, that patient assistance programs are there, but then they need to improve. So this we can actually translate into, getting the cost down for what it would be. The third, another important aspect is looking at the policies. If we have a guideline, and if we are following that, or rather a set guideline for a particular drug, so there should not be any deviation in whatever the indications are. Moreover, if that particular drug, we should have our own indigenous protocols for cancer. So just to give you an example, that when we started with this drug called trastuzumab, we knew it's a very good drug and was a great drug for breast cancer, HER2 receptor positive. And it really made a very important increment in the lifespan of our patients. With period of time from 2008 to today's date, we have learned that you need not give trastuzumab for 1 year of time. You can probably just give the maximum benefit to the patient with a shorter protocol, shorter exposure of trastuzumab. Probably just 9 weeks or sometimes 6 months is good enough, rather than just giving on for a year. So these all things are important that we need to, with time we have learned it, but if we can just look into these aspects, there would be certain research data which would say that the benefit would be there. But then the percentage of benefit is important. The European Society of Medical Oncology has put a scale of a cost efficacy in terms of benefit to the patient, which is called the MCBS scale. So we should have some sort of scale which is actually looking into the clinical benefit which is being passed on to the patient, and what is the incremental cost with that particular percentage of benefit. That in the natural history of the disease should be very clear. So if the cost of a particular drug is very small, is very incremental, the increment is very small, then we actually need to deliberate whether what is the actual requirement of that particular drug in the trajectory of the whole natural history of the patient's treatment. So that becomes important. So I think so a lot of deliberations.
So Dr. Bajpai, who will do this research? Because drug companies will have their vested interest. They want their drugs to sell. Why would they invest in this research to see that you can cut down the treatment time?
This is happening, Anisha, and this has happened over time. For example, in trastuzumab, we have grown wiser with the duration of trastuzumab. We have learned where to use. Dr. Sharma is there, and AstraZeneca has one drug, olaparib, and we have learned why. We have grown wiser where to use olaparib. We must have a particular mutation where you should be using that, rather than just giving as a blanket. So there should be personalization of the entire thing, and which is actually my request to, of course, the industry is to actually look into these aspects to give the maximum benefit to the patient, where we can, get this. Of course, this has to come from the industry, of course. The research, further fine-tuning of the research has to come from the industry. industry support. Yeah.
Right. Dr. Sharma, do you think that we need to have our indigenous models of research or indigenous subjects used in research in our country? Because, you have an innovator company who has used particular drug in a developed world environment, has had this impact, and then we have years later a generic company, and we're using the same protocol in our country. Do we need to do things differently? And is enough work being done here in our country for that?
So I think again a pretty loaded question. And as I said, innovation is a very different space, and which lens do you see it from also is very important. So if we are today the generics of the world, somewhere we have innovated. You can't just become generic by or you can just have the tag without doing anything. So there has definitely been, because even if I have to make a generic copy, I have to invest in some form of research to make a generic copy. So till now, the pharma world was largely chemical driven. And as Dr. Pugh said that, now the future probably will look at more biologics coming in. And that's where companies like Biocon, Glenmark, the Indian homegrown companies, they have taken this mantle of seeing how can they make a dent in the biologic world, but they're still again to a limit sense of biosimilars. So as I said, the way India has been looking at the innovation world is, okay, fair enough, I may not have all the resources to start from a scratch, but how can I learn from the models of the West? And that you see not only in pharma, you see it in across the industry. Flipkart, a brilliant example. Similar to that, you will get our own other aggregator companies which we have seen in the past. So I think we do look at the West world, we try and see what best can we do and replicate it in India in a fashion which can get the cost down. So somewhere our mindset has been that the cost has to be down, and till that day, I don't see India coming with a very breakthrough innovation. So, and as I said, it's a nature of any country, it's a evolvement of any country, because how long can India continue with the generic bandwagon? And today we have serious competition from Bangladesh. We have serious competition from Malaysia coming in. So there will be other countries which are catching up. Egypt has a very good generic base nowadays. So I think there are other countries which will start coming closer to us, and that's where India some way has to leapfrog. And I feel the next 10 years is the best period for India to leapfrog into the actual innovation space. Yes, the budget could have given a lot on the R&D and innovation, and that I think the Indian stalwarts have also spoken on multiple forums. But yes, I also wanted to address what you had said to Dr. Piyush, that pharma companies are investing in research, and this is what we call is it's a new form of research where after a drug is launched, we still continue to learn. So let's assume our own vaccine, which is out there in the market today, and we realize that a half dose or full dose combination, will that combination work with another Pfizer vaccine? How much better can it give a coverage? Whether it will work with a Sputnik 5, how bigger the coverage can extend. So there are these kind of investments and research which everyone keeps doing. And Harshaptan, Dr. Vajpayee has very rightly said, I'm sure Tata Cancer Hospital, we are partnering, multiple other companies are partnering to see how or what could be the adequate dose. Because as I said, the dosing scheme comes from the West. How can we learn from Tata, learn from the experiences of the Cancer Grid Network, and probably have our own protocols? So yes, those kind of research are happening, and the pharma companies are partnering on the research.
That's very heartening to know. Mr. Kumar, while Dr. Sharma is making a strong case for drug companies to invest in innovation in our country, whether you get incentives from the government for doing the research or not. The truth is, research companies, not just pharma companies, across in our country spend very little in research, and they believe in jugaad, and jugaad doesn't always work. Now, on one side, you innovate to bring in new medicines which have better outcomes for cancer treatment, perhaps because your innovation is your own, it's not as expensive as a foreign competitor. On the other hand, it is estimated that the burden of cancer is going to explode in our country. You could be selling your drugs to a larger number of people, and perhaps because you have that volume, you could reduce your prices. What is the way ahead for drug companies in our country? At this point, seeing where we are placed in the burden for cancer care?
Sure. Thanks, Anisha. Very valid question. So now maybe let me start off with how the funding for medicines happens along with the economic development of the country, right? Typically, for a low-income country, a lot of the funding for healthcare happens from external sources, aid developments, etc. As a country becomes low middle income, the percentage of out-of-pocket spend increases dramatically, right? And as the company moves in a middle income or a high income, you'll have increase in two things. One is participatory contribution, basically insurance, and the second is public spending, right? And India right now is a transition where we're moving from a low middle income to a middle income country. And hence, the growth of source of funding for health is going to come from these two places, which is private insurance and public spending, right? There's a good amount of movement that's happened on both of these fronts, right? While India is far away from a stated goal of spending 2.5% of GDP on public spend on healthcare, but we are inching towards that. There's been a good increase in allotment to health in this budget. There's been the launch of the PMJY scheme nationally, which covers the bottom part of the pyramid. And on the other side, you also have a rapid increase in private insurance. However, both of these modes still have a lot of design changes or design improvement that's needed, right? Especially if I come to cancer, right? Most of the insurance policies sold in India typically cover hospitalization, right? Right now in cancer, you don't need to, for every treatment, you don't need a hospitalization, right? The latest innovations are oral therapies which help the HCP treat the patient at his own comfort, bringing better quality of life, right? Without the need to have a patient admitted, occupying an OPD bed or a hospital bed, right? And also not having to have more adverse events, right? So that is a last year ILD came out a new notification which instructed insurance companies to include even innovative therapies, right? This is still being rolled out. Maybe by end of the year, this year we'll have almost all insurance policies covering innovative or oral targeted therapies, the way it's called, right? That's a good point or more. And we expect the personal population is going to get covered and the medical insurance is going to increase. And on the second one, which is the public assurance model, which is what earlier state governments used to have, and which the central government has now taken over as PMJY, right? Some of the publications coming out of PMJY indicate that cancer is one of the biggest source of claims to PMJY, right? Which clearly indicates the burden the country is having and the high level of unmet financial assistance need in this segment, right? Currently, PMJY is not covering a lot of therapies, and that's something maybe where there's a good amount of partnership work that can happen between the industry and the stakeholders to ensure that even latest innovative therapies are being able to be provided to the wider Indian population. So I believe the country is moving in a positive direction as far as increase in spenders, and hence there is a significant potential. But a lot of it depends upon the kind of partnering between the various stakeholders and strengthening with the right kind of models to have a future where cancer patients in India are getting as good outcomes as in Western countries.
Right, and Mr. Kumar, we've had representatives of the government also telling us on our platform that they want to engage with drug companies, increase the number of drugs that can be included, especially for cancer care, within the PMJ coverage as well. So I'm sure we'll see greater progress there as well. But like you said, that only covers the bottom rung of people needing treatment, and there is also a hope that PMJ will be expanded in a fashion that some part of the middle class also gets covered, because cancer care can kill your finances completely. Even if you have a job and you think you're secured, who knows, because of cancers that is diagnosed in the family, you may run into a loan, you may have to sell your assets, and that's how it works out many times. Dr. Bajpai, that is one thing that the drug companies are working with the public sector to increase the number of drugs that can be included in the government's insurance plan. Now, if I am a patient who has been diagnosed with cancer and I have come to a private hospital like yours for treatment, how can you connect me to? Can you connect me to the patient groups that drug companies run? How do you decide which patient should be referred to? Who's more suitable? how does it work in the private sector?
No, so that's what I'm saying, Anisha, that we should have protocol-based treatment. That should be one thing which should cancer treatment should adopt. A cancer center should be defined. A patient who is walking into a cancer center should expect a multidisciplinary meeting board, what we call as a tumor board, to take place. That defines that the worldwide accepted protocols, number one, are followed. It is not something I follow, something of my own. Number one, it all starts from there. Number two, of course, then whatever is the drug, the benefits, if it's a curative intent, we must define what intent we are dealing, number one. If it's a curative intent, we should, of course, then connect to the company or the third party or whatever patient assistance is there to get the maximum benefit. And here comes the actual real patient assistance in curative intent. So we must define what this drug is made for. If it's a curative intent, that it should be widely, as Mr. Kumar actually pointed out about imatinib. So it's a wonderful thing that it was the GPAP program was available and the imatinib was, available for a large population of patients. But having said that, now if the intent is palliative, that is, there is just an extension of a lifespan. So there we need to actually define what is the increment of the lifespan that we are actually giving. That should be clearly, so patient education is very important. The amount of information the patient should take in a palliative, this thing, it should not be a monologue in a palliative thing. I think so the previous session was covering that. It should be a huge discussion, a big discussion, educating the patient about the possible options, what actually they want to go for, whether they would really want to spend a big amount on something which would increase the survival for 3 months. That is what is important. So empowering the patient about the current data knowledge available is very important.
Right. Dr. Bajpai, my question really is on the connection that hospitals and doctors can give for assistance programs. You have a patient who is young and who may benefit from a targeted treatment but doesn't have the resources. So then how do you decide who you will refer to for the patient support group?
So there actually we, especially in a curative situation, we have crowdfunding. We have a system where we actually look at, the patient can have a crowdfunding. So one of the possible things is that. Then of course, the companies, some of the companies are actually helping out us, their third parties, their groups are helping out in the various, fragmentation of the whole expenditure which could be there. So this is what, as of now, we are doing. Of course, there are patients, a percentage of patients who are below the economic poverty line. So there, the EWS category is actually getting a free treatment. So there are those group of patients who are there. So this is being looked into. Yeah.
All right. I want to come to you, Dr. Sharma, on what drug companies can do to increase the access the patients have for cancer drugs. Like Dr. Bajpai said, there are models for funding. One could be crowdfunding, which we have now platforms like Keto, etc. That are doing it. Then we have third party, some corporates who will fund cancer patients should you make an application. Now, not everybody knows about this. Even if I'm educated and well-to-do, I may not even know that this could be an option for me or somebody I know who's disadvantaged, who could get assistance from this. So, as a drug company, do you have a role to play here in increasing patient awareness about these things, and what could be the models that could help improve the access?
So, Anisha, biggest program which every all innovator companies run today in the country is patient assistance program. So a patient assistance program, the basic principles is it helps people who actually pay out of pocket or who do not have any form of reimbursement. And this is a well established program all across the world for all prescription medicines. So where people are not covered under insurance or they're left to pay for their own treatment, that's one of the key programs which is run by almost every innovator company in the country. So that is something which every pharma company does. Second, I agree with you that there are multiple sources of funds which are available, but people are not aware at that point of time. So probably some states may have a 2 lakh rupees cancer fund, but they are not aware that even beyond that they could probably source some other money from some other funds. And that is a very valid point where it is a gray area or gap area which as a pharma company as AstraZeneca we are trying to see how best can we get it into a common platform. But yes, this is something work in progress, some work which I think all pharma companies in this space, along with the healthcare providers and the patient groups. That's what I was saying that, at the start of this session, that these three bodies have to come together because we have to strengthen each other to actually give the best care to the patient out there. And that can only happen when these three individual entities in the private trade can come together and work together to create avenues to make sure that funding doesn't become a challenge when a cancer care has to be extended. So that's a work in progress, which I would say we are doing. Third, the pharma companies can also play a role is, and I think healthcare providers also can play a role, is to ask the government to start creating source of funds. So if Punjab has a cancer relief fund of 2 lakh rupees, can it be taken to 5 lakh rupees? Can similar schemes be started in Delhi, other states which are on a higher pedestal or which has a higher concentration of cancer hospitals? Can these demands be shaped as a policy tool to actually help the patient in the long run? So I think there is a lot of work which is out there, and as a ethical pharma company, we are committed to work with both healthcare providers and patient groups to make sure that few of these become reality.
Right, Mr. Kumar, in your closing comments, what are your strategies and ideas for increasing access to cancer care for patients where drug companies play a special role?
Sure. Thanks, Anisha. I think one of the critical things is that access to cancer drugs is critical, right? And also critical is the improving the accessibility or the healthcare system strengthening. And then that's a big area of partnership, which as Dr. Ajay mentioned, between patient groups, pharma companies, hospitals, government bodies, so that the entire health system is strengthened to enable appropriate diagnosis, treatment, and appropriate care. I think that's one critical thing. And when we talk about the pricing, we have been talking a lot about pricing, right? One of the critical things for cancer therapies is also we need to understand the value, right? So each drug brings a value to the patient and to the health system, right? In most countries, developed markets, there is a evaluation of the value of the medicine, and then the reimbursement setup decides on how much they can pay for them, right? In India, unfortunately, we don't have any central value assessment, and that's something that maybe if we have can help ensure that innovative treatments are getting accessed, reimbursed, and priced appropriately. So value-based evaluation is something that would be a critical component for the health system going forward.
Right. Dr. Bajpai, in your closing comments, what would you like to say? What more can be worked upon? What could be new models that can come across? Because like you said, COVID has taught us innovation. It has told us that telemedicine makes it easier. The government is moving forward on its digital health plan. What more can be done so that, access can improve? It can be made somehow affordable for patients.
So, as Mr. Kumar just mentioned that, and Dr. Sharma also mentioned that the government, we have to pursue this advocacy with the policy makers. Of course, this access is not just only about money. It is also that there are in second and third tier cities patients who would who could actually afford it, but are they really knowing about the options? Number one. Of course, it is the elephant in the room is definitely the cost. There is no doubt about it, and we need to look into patient assistance programs, or probably the entire policy decision making from the government has to increase the budget in the health sector, increase the insurance base, make sure that those who are actually needy get the drug uh, at a very subsidized price. Those who can afford it have to pay. So there should be certain system. This is to come from the policymakers. I would like to put one point, of course, also that we should have a value-based system, what Mr. Kumar just mentioned. I would like to add just one point that, we see that a lot of times, and it's just, I was reading this article and I came through yesterday that in renal cell carcinoma, there was a lot of flood of medicines in the first line setting. So my, thing is what I took it from there, that there is a lot of there are a lot of companies putting a lot of money in certain disease subset groups, and I hope this particular thing is looked globally, that the funding should go in the cancer care. It should be it should be looked into that where actually the funding is needed, so it could be distributed properly. So that's what I would have to say. Yeah.
All right. Dr. Sharma, in your closing comments, what would you like to say?
Thank you, Anisha. First of all, thank IHW, because this is a great platform, and I thank my co-panelists as well, because they have briefly summarized the next way, which I would wanted to reiterate at myself as well. But to paucity of time, and I just add one more area which I believe could be a new way forward, and this is about somewhere the government needs to play its part. If Ayushman Bharat is there, Ayushman Bharat is still to a marginalized class of 50 crore population. I think there is talks about Ayushman Bharat 2 which can come in. And when Ayushman Bharat 2 comes in, can we address the missing middle class? You see, India is, if you see, the income inequality is existing, right? But traditionally throughout, even if you talk of a price cut, what does a price cut say? It says the price of the medicine will be this. So whether an higher rung, say let's say Ambani wants to buy the medicine, he also buys it at the same price. The driver, probably a laborer or a field farm worker, also will have to buy it at the same price. So is this what the government does when it runs its scheme? They do differential pricing. So we have seen it in the gas yojana or the fuel or any other existence policies which you see. There is always a differential pricing. Even the taxation for products which is to be consumed by poor class will be at a separate rate versus the products which probably would be consumed by the higher or high paying class. So I think if innovation has to survive in this country, somewhere we'll have to look at government playing its part by, as I said, addressing the missing middle class, covering them into the insurance of Ayushman Bharat too. And I would also say that they should look at the differential pricing mechanism and how can they allow in introduction of differential pricing mechanism in the country. But that will really help address the right set of affordability to the right set of population.
All right. I would like to thank our panelists for joining us today and talking to us about improving access of care for cancer patients in our country. Your points are very welcome and well taken. We hope that the government will increase the access by giving subsidies to those who deserve it on drug prices, increase insurance for a larger majority of our country, and we will see progress in the days ahead. And of course, drug companies too will do the bit by running patient support systems, by spending on innovation, by tailor making drugs to our conditions that may work best. Thank you all for joining us for this panel session.
Thank you.
have thought on our feet and innovated quickly. We need to do the same for cancer, because the burden of the disease is set to increase in our country. And we've had a lot of thought makers joining us today. We've been privileged to have top cancer care providers, experts, and health crusaders lay down the path for defeating cancer in our country at a time where it is estimated that the burden is going to increase exponentially. We hope that you've gathered good information during the day today on treatment of cancer, the latest innovation, the need for palliative care, how drug companies are doing their bit, the diet and lifestyle that needs to be changed to ensure the incidence of cancer comes down in our country. All of this has been covered today. We've had great sessions. We would like to thank all our speakers for joining us, and we'd like to conclude the session here. Goodbye.